Okay, so I think that we'll go ahead and get started. Just wanted to first thank everybody for joining. I know we had I believe, a great start to our 128th annual convention last night. I know the program, all of our speakers, and having our student panel, I believe it all was a success. And of course, we also had I guess the kickoff program there in Atlanta on the day before on Thursday, and I wasn't able to make it there, but I've heard and seen great pictures, and so definitely looking forward to being able to see everyone in person again next year.
Yeah.
And yes. um, so I believe, did we have any other housekeeping things that we needed to do initially, Kimberly?
Yes, just a quick reminder, and I cannot pull up the screen right now, but reminder about muting your phones and allowing the presenter to present. You can put your questions for this presenter in the chat box, and we will try to get to those questions. Our moderators are Dr. Winston Price and Dr. Lawrence Sanders, and Dr. Paul Douglas. So those are your moderators throughout the day. And I will place a Word document in the chat box. So those of you who need to create your Morehouse School of Medicine CME account so that you can get your CME credit, you can download that document, and we will also email it out to you. And again, the code for last night for you to claim your 2 CME credits was 11901. The code for today is 11902. And we ask you to only claim credits for the time that you participate today. And with that, I will turn it over to Dr. Douglas.
Good morning, everyone, and thank you for joining us this morning. Our first speaker of the morning is Dr. Sean Javaheri, who is cardiologist in Augusta. He received his medical degree from Midwestern University, Chicago College of Osteopathic Medicine, and did his internal medicine training at Tripler Army Medical Center. He went on to finish his fellowship in cardiovascular disease from San Antonio Uniform Services Health Education Consortium, and then a fellowship in interventional cardiology from Duke University Hospital. Dr. Javaheri is going to discuss updates on heart failure. Dr. Javaheri? Ready?
Good morning, everyone.
Good morning. Let me introduce you, David. Although he needs no introduction, Dr. David M. Williams is President, Chief Executive Officer of Southside Medical Center since 1997. His specialty training is in family practice and preventive medicine. He started his public health career as an epidemiologist with the state of Georgia and was the first director of the Georgia AIDS program. Currently serving as president of Choice Healthcare and a Georgia IPA. He is chairman of the Georgia State School of Public Health Board. He is the Peach State Healthcare Board. He's on the Summerhill Mechanicsville Board and vice chair of the Atlanta Community Access Board. We are very pleased and honored to have Dr. Williams with us this morning. He's going to talk to us about community health centers and what the future holds for community health centers. Dr. Williams?
Okay, good morning once again, everyone. It's always a pleasure to be here. I consider it an honor to participate in this forum. I know we're not in Hilton Head, but we'll make do with what we have. We can imagine that we're there. So I'm going to share my screen. And hopefully everybody can see that. Can you all see my screen?
Yes, we can see it.
Okay. So this morning, I was asked to speak about the future of community health centers. This happens to be, for no odd reason, a favorite topic of mine, and I don't think I need to explain why. An easy topic for me to go over because this is what I do for a living. And so the question was, what is the future of community health centers? And so I'll start off by a quick definition of who we are as a community health center. Let's see. Okay, so community health centers were founded in 1965 by Dr. Jack Geiger to provide health care to low-income, minority, and disenfranchised populations in the United States. And it had support of the Federal Office of Economic Opportunity, and it was based on the South African model of care, which combines local and federal resources to develop a more organized system of community-based healthcare. In short, community health centers use a team approach to provide quality patient-centered healthcare in a most cost-effective manner. Community health centers provide an array of services, including case management, translation, health education, dental, behavioral health, pharmacy, pediatrics, family medicine, internal medicine, OBGYN, optometry, and a variety of specialty services. And some of us provide free transportations. As you might, if you know community health centers, you will find that no two health centers are alike. They vary in the amount of services they offer, but we all have the same common purpose, and that's to provide primary and preventive healthcare services that are coordinated, culturally and linguistically competent, and community directed, and not to mention cost effective. Presently, there are about 1,400 federally qualified health centers, and combined, these represent 13,000 clinic sites throughout America. Community health centers serve over 30 million patients nationally, of which 7 million are children, 1.1 million are homeless, nearly 300,000 are veterans, 62% are racial ethnic minorities, 75% are covered by Medicaid or uninsured, 92% have family incomes below 200% below the federal poverty level. Community health centers are considered safety net providers. In other words, they're the ones who catch the ones that the other healthcare systems miss for many reasons, which include mostly insurance reasons and access. So community health centers have grown significantly over the years. And if you look at this slide, you can see that the amount of actual centers went from 1,131 to about almost 1,400 here. But look at how many sites they've doubled, from 7,000 sites in 2009 to right now we're at almost 14,000 sites. As far as patient visits, community health center has also grown significantly, serving almost 30 million patients annually, representing 122 million visits annually. In Georgia, there are currently 34 health centers and with 229 sites throughout the state. We serve approximately 600,000 patients. That would be over close to 2 million patient visits annually. We're located in 123 counties. We serve approximately 1 in every 34 Georgians, 1 in 10 Georgians with Medicare, 1 in 20 Medicaid recipients in Georgia. And wherever you find a community health center, the annual rate of ER visits for uninsured is 25% less compared to those counties that still do not have a health center. So as we talk about healthcare and the future of healthcare, there are certain things that I think we all realize that are driving change. In particular, perhaps, and the most important is money, or the cost. As you can see in this graph, the cost of health per capita spending for healthcare has gone up from $7,000 per capita in 2007 to now we're actually almost $12,000 per capita in 2021, and it continues to rise. You can look at the share of the gross national product. You can see that healthcare is right at almost 20% of the cost. And this is, many realize this is really not sustainable. It's forcing the system to look for change. And that is a change in healthcare that provides better outcomes at lower costs in a more patient and consumer-friendly way. Many of you are aware that we're shifting, and the shift is occurring rapidly from fee-for-service to value-based payments that puts providers and insurers at some or total risk for the cost and quality of care. And so new innovations and startups, industries within healthcare have come into existence focused on reducing costs without compromising quality outcomes. As you can see, also analytics, hospitals, and other major players are seeking new methods, and they're looking towards data and other things to try to figure out a way to reduce the cost and improve quality. The Affordable Care Act, also known as Obamacare, brought the healthcare industry to the realization that value-based reimbursement was inevitable. Providers recognize they need to step up their innovation efforts. Medicare created incentives to provide change using the hospital value-based purchase program designed to reward or penalize providers when they don't meet a set of quality metrics. CMS also instituted the Medicare Shared Savings Programs, an initiative that encourages but doesn't actually mandate yet providers to organize in accountable care programs. All these things are leading up towards why community health centers have a bright future. Health centers save more Medicare and Medicaid dual eligibles than other ambulatory care providers. And most of these slides are just showing what we do as healthcare centers. Health centers serve patients throughout the life cycle. Every age group, you can see that health centers are serving, with the largest group between the ages of 18 and 44. And of course, the higher amount of patients who are insured are being served by community health centers. Health centers achieve higher rates of hypertension and diabetes control than the national average, despite serving more at-risk patients. And this is interesting because most of the patients who come to community health centers are considered at risk or high risk, but yet and still they're able to achieve better outcomes and controls in some of the long-standing chronic diseases such as hypertension, diabetes. Many health centers exceed the Healthy People 2020 goals. As you can see here, they most exceed at least one goal. 66% exceed the dental ceilings for children goal, hypertension control 61%, access to prenatal care 57%, and low birth weight 44%. Health center patients have lower rates of low birth weight than the national average, despite health centers serving more at-risk patients. I think you all know that Georgia has high infant mortality, high infant, low infant birth weight, more so than many states. But although most of our patients that come in for OB services in health centers are considered high risk, we actually have a significantly better outcome than the statewide average. And you can see here in all levels of birth. In all births, 8.1% compared to 8.3%. And in the different groups, especially in the high risk groups, you see that we do much better than the national average. Health centers exceed Medicaid managed care organizations. As we all know, they're the ones that control the Medicaid, the MCOs, high performance benchmark scores. We do significantly better in most of the scores: diabetes, blood pressure, pap tests, and many others. Usually there's about 10 HEDIS scores that most of you are familiar with. Health centers tend to exceed in most of those scores when compared to other providers. Health centers provide more preventive services than other primary care providers for uncontrolled hypertension, asthmatic, smoking, health education, immunization for 65 years and older, pap smears in the last 3 years. You can see in all these parameters, health centers, when compared to other providers, we are significantly better in all these preventive healthcare services across the board. Health centers reduce unmet healthcare needs. So as you can see, unable to receive, when you compare health centers to other providers, other clinics, and to private physicians, the amount of unmet patients who have unmet needs is very low, 7%. Those who have delayed medical care, only 6% when compared to the others. Unable to get dental care, only 13% across the board in health centers compared to other providers in the industry. Many of you are familiar with the term patient-centered medical home. This is an area where health centers tend to exceed significantly over other plans and other providers, including managed care health maintenance organizations, academic organizations, hospital organizations, federal, military. Health centers save 24% per Medicaid patient compared to other providers. And this is significant because the healthcare dollars that we spend, that the federal government spends, and when we talk about managed care plans, when they can see a 24% savings for when a patient is seen at a community health center versus a private physician, it doesn't take rocket science to know where they're going to push their patients, because as I mentioned earlier, what's driving all these changes are the healthcare spend. And so if they can show a 24% savings is huge, and that represents billions and billions of dollars, they see the solution as being healthcare centers. And this is across the board in all the different states. In some, like Alabama, is 63% lower when it's seen in a community health center when compared to other centers for care. The same holds true for Medicare. When compared to other providers, you can see the average cost, $3,580 compared to $2,370 in a healthcare center. Significant, significant savings. Medicare overall is lower in health areas where health centers are located. And so when they're low income patients, health center costs is significantly lower. When it comes to children, there is a 35% savings per child compared to other providers. Also, huge savings, huge impact on the economy and the cost of healthcare when it is provided by a community health center. So this slide, I just need to change where it says 5,300. This slide, somehow I got the wrong. This was done in 2009. This number here is actually now close to 12,000. Okay, the annual costs per capita. And on the health center area, there's a 24% saving, which this would be about 8,000 or so. So the costs have gone up significantly, but the percentage savings holds true, about 24% from the actual cost. During the COVID-19 pandemic, which still is ongoing, even though we see it going down, you can see how rapidly health centers responded. Each week, health centers tested over 194,000 patients, in which 25,000 were considered positive. It was a quick response, and you can see how quickly health centers are able to were able to expand for the walk-in testing. Other providers at 80%, health centers at 96%. In the walk-in, 82% walk-up testing, 34 other providers, and ability to test 96 compared to 80%. Health centers also are rapidly adopting new technology, in particular telehealth, which was very crucial during this pandemic. As you can see, health centers using telemedicine was significantly higher than other providers. And these are the modalities that were used for. Likewise, health centers have responded, expanding their capacity to provide more services, such as enabling services, behavioral health, dental, pharmacy. Many health centers have their own pharmacies, vision, and there's been a growth of 4 more services. You'll recall my original slide when it says health centers provide an array of services. It varies from health center to health center. Our center, Southside Medical Center, boasts that we provide more services than any other community health center, a variety of services than any other community health center, definitely in the state and perhaps nationwide. Most of them are focused just on primary care, where we provide substance abuse, housing, transportation, and a number of specialty services. Health centers are increasingly participating in new payment and delivery system models. In other words, we're adapting very quickly to the way healthcare is moving. And this is important in our efforts to survive in this healthcare dynamic. As we all know, it's quickly changing, and health centers are adapting very quickly. So health centers are ready. Southside and several others are part of an accountable care organizations. The one that we have here in Metro Atlanta is called Morehouse Choice. And it has health centers partners from areas as far away as Albany. At least 8 or 9 health centers are part of our ACO. We also have independent practice associations. We're participating in pay for performance, pay for outcomes, patient-centered medical home, care coordination. So for every dollar spent, there's a return of $1.75. This makes huge sense for anyone who is controlling the purse, the managed care organizations, government facilities, etc., because of the huge costs. And you recall when I started this talk that what's pushing this is cost, effective, high quality care at low cost. So reasons why health centers have a bright future is because we have a proven primary care model. Provision of care equal or superior in quality when compared to other providers. Focuses on the elimination of health disparities. Exceeds national practice standards. Have proven positive health outcomes. Diminish hospitalizations. Poised to become national model of the delivery of cost-effective healthcare. And also very, very important, health centers have had bipartisan support for the last 30 years. Regardless of whether it's Republican or Democrat, they've all recognized the value of community health centers and have continued to support health centers throughout. And this is important. So I'm stopping there, and I went quickly because it almost sounds like I'm bragging on health centers, but the question was, what is the future of community health centers? And I would say the future is very bright. Health centers are designed to answer the issues that we are facing now in healthcare, issues such as cost, high quality care, and use of technology. By collaborating with many organizations through ACOs and IPAs, it allows us to provide an effective and efficient model for the future of healthcare. So I put this slide is healthcare is like a wave, and you either miss it and get left behind, or you get on the wave and ride it. And health centers, we're pleased to say that we're doing our best to ride the wave and be prepared for the future. I still have 4 minutes for any questions.
Thank you very much, Dr. Williams. Are there any questions for Dr. Williams?
Excellent presentation, Dr. Williams. This is Linda Walden. I just had one question. Have you all had any difficulties when it comes to referring your patients to specialists such as GI, cardiology, vascular, and who takes care of the bill for that?
Very good question. All health centers have that particular problem. We have individuals who we call referral coordinators, and their job is to find when a patient needs to be referred to a specialist. They look through all the different means. We have lists of people who will accept Medicaid. Not everybody accepts Medicaid. Not everybody will see a patient who is uninsured, but there are certain providers out there who will. So their job is to get them into those providers, set the appointments, and get that information back to us. Whether sometimes we have to get them in Grady or other places, and sometimes it's difficult. What we do at Southside is to try to hire specialists and who can come in on maybe half-day clinics, and they're paid for that half-day clinics. And so they have no concern about whether a person has any ability to pay because we took care of their costs for that period. It's not a perfect solution. As we move forward in healthcare, there's a likelihood that Medicaid will be expanded. And then when that happens, the amount of uninsured will reduce dramatically. And it will obviously lead to more ability to find specialists, but it is a problem.
Yeah, I was going to say you might want to look into getting community health centers for subspecialists where all of them are in that center.
Yes, very good idea.
Very good. Any other questions for Dr. Williams? Here. Thank you very much, David, for your insightful presentation. This is we know that the future is bright for the federally funded health centers, and certainly Southside is very fortunate to have you in the leadership. So thank you very much.
Thank you.
Our next speaker is Dr. Java Harry, who I introduced earlier. He is at the Augusta University Medical Center, and he's going to give us an update on heart failure. Dr. Java Harry. Thank you. Good morning.
Good morning, sir. Thank you so much. Thank you, everybody, for having me. Can you see my slides okay?
Not as yet. You can share your screen.
How are we doing? Are you able to see my slides?
Yes, we can see them now.
Wonderful. Well, thank you for having me. My name is Sean Jamahari. I'm an interventional cardiologist at Augusta University Medical Center, and I'm going to be giving you a little bit of a historical perspective on the management of heart failure, and also tell you a little bit about new treatments that have come up recently. I have no disclosures relevant to this talk. These are my objectives. I'm going to review medical therapies for heart failure, specifically focusing on vasodilators and adrenergic blocking agents, and then review the role of newer medical therapies and review the role of device-based therapies in the treatment and management of heart failure. We know heart failure is an epidemic in the United States. It is only getting worse, and it's projected to get worse with millions and millions of heart failure patients being diagnosed over the next few decades, and 550 new cases a year is a plateau number that has been held steady for over 3 decades now. As cardiologists, we classify patients in 2 different ways. We look at their stage of heart failure, which is something that carries them through their entire life. And then we look at their functional class, which changes over time. So any patient that's ever been symptomatic from heart failure, we always say that they're at least stage C heart failure. If they've ever required specialized interventions, admission to the intensive care unit, inotropic therapy, they stay with the stage D. And then their functional class varies over the course of their treatment. The risk factors for heart failure are varied. Coronary artery disease is the one that we think about the most, but there's a lot of other risk factors. I'll talk a little bit about valvular heart disease. Alcoholism is a unique form that I myself have seen more and more of in taking care of the prison population here in Georgia. And we've seen plenty of cases of people that have been put in the prison with alcohol-related cardiomyopathy come back and see us as outpatients, as prisoners, and their cardiomyopathy is now resolved. Some other risk factors that we've looked at are obesity, obviously aging, smoking, hematocrit level, and obstructive sleep apnea all pose risks to heart failure. The pathophysiology is complex, but you have some form of myocardial injury that leads to pathologic remodeling and this neural hormonal stimulation that causes myocardial toxicity. Your ejection fraction declines initially after your pathologic injury, your symptoms develop, and you go on to develop either pump failure or sudden cardiac death. So when we talk about heart failure and mortality in heart failure and how it occurs, the primary etiologies are sudden cardiac death, mostly related to ventricular arrhythmias, and progressive heart failure. And these are the areas that we target our therapies. The compensatory mechanisms of heart failure revolve around the renin-angiotensin-aldosterone system. As you can see, there are two things that happen simultaneously once you see angiotensin II start to be created. This is the most powerful vasoconstrictor known to man. It increases afterload, decreases cardiac output, and at the same time, it causes an increase in aldosterone secretion that then causes salt and water retention. And that aldosterone is a direct toxin to the myocardium, causing myocardial fibrosis. Our therapies, until about 1980s, the mid 1980s, all we had was digoxin and diuretics. As you can see, this digitalis purpurea foxglove plant was the original treatment. And this is all we had until about the mid 1980s, when we started to see things like vasodilators, ACE inhibitors, angiotensin receptor blockers. In the late 1990s, I'll show you some data on beta blockers. Aldosterone antagonists entered into the early part of the 21st century. And now we're in a new age of therapies where we're talking about these SGLT2 or these sodium glucose lowering transport inhibitors. We'd love to be able to give everybody that needs one a heart transplant. The problem is that our supply cannot keep up with our demand. So approximately 2,200 heart transplants are performed every year, but this number has remained stable and we just don't have enough supply of heart transplants. We'd love to give everybody an artificial heart. This is Dr. William DeVries with his artificial heart in 1984. But unfortunately, that technology has not been further advanced, and we don't have a lot of artificial heart capability. These devices are in use, but most of them are being used as bridge devices and not destination devices. The modern era of heart failure therapy began in 1986 with the introduction of vasodilators. Beta blockers started to be introduced in the late 1990s with the MERIT-HF trial in 1999. But it's important to understand, until very recently, there really have not been any advances in heart failure therapy with regard to medical therapy. So we've gone for about 15, 20 years without any good advances in medical therapy in heart failure with a reduced EF. What I'm showing you here is the original VHEFT trial. This was a trial looking at isosorbide and hydralazine. And as you can see, there is significant mortality benefit. And when I look at this data, from slide to slide as I go through, this data is very consistent. They all show somewhere around a 3 to 5% mortality benefit. And if you look at these curves, the survival curves all diverge at around 6 to 12 months from slide to slide. This is kind of what I term as biological consistence between trials, showing these very consistent benefits with add-on therapy. We looked at the consensus trial. This was enalapril versus placebo. And as again, you see these curves diverge very early, and this is a dramatic survival benefit in ACE inhibitors versus placebo in heart failure with a reduced EF. This is another trial, the SOLVED investigators, looking at not only reductions in total mortality, but you get reductions in heart failure mortality. But here it's important to understand that we do not get reductions in arrhythmic mortality. So this was the main limitation behind vasodilator therapy, that we were seeing reductions in heart failure hospitalization and heart failure mortality, but not arrhythmic mortality. Well, what happened when we compared vasodilator therapy to ACE inhibitor therapy? This is the VHEF2 trial, and we saw consistent benefits with ACE inhibitor therapy over vasodilator therapy. Now, beta blocker use was limited due to the risk of adrenergic blockade in the heart failure population. I graduated from medical school in 2001, and I remember being a medical student early in my medical school years and being told that beta blockers were absolutely contraindicated in heart failure, and then being in a journal club in 1999 and being told that everything has changed now and we now need to be giving beta blockers for heart failure. This was the COBB-NMAHI trial. This is one of the trials that showed how beneficial beta blockers were. Again, this is a 5% absolute risk reduction in mortality with beta blocker therapy. And what you see when you go down into this exploratory analysis is that a lot of reduction that we're seeing here, a 2% absolute risk reduction, is related to sudden cardiac death. And this is presumed arrhythmic mortality. This is the MERIT-HF study that I talked about. When you looked at total mortality, it was reduced. Cardiovascular mortality was reduced. Sudden death was reduced. And even death from worsening heart failure was reduced. And again, another trial looking at consistent 3% absolute risk reduction. This is the Capricorn trial in mortality with beta blockers. And trial after trial after trial that we've done has shown consistent reductions of between 3 and 5% mortality with beta blockers. Now, aldosterone blockade was brought into the late 1990s. This is the RAILS trial. This was class 3 and 4 heart failure patients with utilizing aldactone. This was a 10% absolute risk reduction in mortality. But as you can see here, background medical therapy was relatively low with beta blockers because they hadn't been adopted yet. When we looked at the benefit of aldosterone antagonists in the post-MI study, this is the EPHESIS trial. This is now on a background of excellent medical therapy with ACE, ARB, beta blockers, and statins. What we start to see is significant reductions in death from any cause. Again, this very consistent number that we're seeing is about 3% absolute risk reductions in mortality. Now, these were class 3 and 4 heart failure patients. When we looked at this, there was some hint that perhaps with these aldosterone blockers, if you started to have elevated creatinine, you might not benefit as much from these therapies, that you have to exercise some caution if your baseline potassium is greater than 4. I'm not saying that you can't use these agents in patients with mildly elevated creatinine or mildly elevated potassium, but you really need to be careful in how you use it and closely monitor those patients' electrolytes. The other thing that we looked at in this trial with aldosterone antagonist eplerenone was that if you were not on an ACE inhibitor or an ARB and a beta blocker, you didn't appear to benefit from this therapy. You really needed to be on the background of good medical therapy to derive this benefit. When we looked at the lower grade of heart failure, so this is now class 2 heart failure patients in the EMPhASIS trial, what we start to see is, again, very consistent reductions in the primary outcome. And remember that number that I talked to you about, 3%, 3%, 3%, consistency, another 3% absolute risk reduction in mortality. Now, one of the things that came out of the VHEF trial that was very interesting was the differential response with self-described Black patients and white patients. When you looked at this, the predominant benefit of vasodilator therapy, this was isosorbide and hydralazine, was seen in the self-described Black patients, whereas in the white patients, there was really no benefit with vasodilator therapy. This suggested that there was a differential response with vasodilator therapy. When you went back and looked at the VHEF2 trial comparing vasodilator therapy to enalapril, what you see is that the white patients benefited from the enalapril over the vasodilators, but the self-described Black patients did not benefit from enalapril over vasodilators. What this led us to do is a separate trial looking at the addition of vasodilator therapy to a background of ACE inhibitor and beta blocker. and or ARB and a beta blocker. And when you looked at this addition of isosorbide dinitrate and hydralazine, at about 1 year, you started to see significant reductions in mortality. Overall survival was significantly reduced. And as you can see here, it's about a 4% risk reduction in total mortality in this trial. So that's the background of where we were. And up until about the mid 2000 teens, we didn't really have another treatment target for patients with heart failure, until we started to look at these things called natriuretic peptides. Now, you're all familiar with the hormone BNP that we draw on patients to determine whether they're in heart failure. But BNP is a hormone that's released from the left ventricle. It's released in response to increased filling pressures. It causes vasodilation. It causes sodium excretion. It causes diuresis. And it actually causes an increase in cyclic GMP. And it's very important in regulating fluid homeostasis. BNP is something that we use to diagnose heart failure, but it's very important for the patient with heart failure to keep them symptom-free. It reduces preload. It reduces renin release, and it decreases angiotensin II, which then decreases afterload. Now, we know measurement of BNP is a reliable indicator of fluid overload, and clearance of BNP itself is receptor mediated. So that as you clear more BNP, you're having less and less response to heart failure, meaning that your heart failure is actually getting worse. We want some BNP to stay around. Now, this is the seminal trial that was done. This is the paradigm trial. This was the largest heart failure trial that has ever been performed. This was 8,000 patients looking at this drug that they called LCZ696, which we now know better as Entresto. And they randomized people to Entresto versus enalapril. It's important to know that the patients that entered this trial, many of them had heart failure for several years, over 5 years, and many of them were already on a background of ACE inhibitor and ARB therapy. This drug, this LCZ696, or Entresto as we know it, is a combination of valsartan and sacubitril. Sacubitril is a neprilysin inhibitor that actually prevents the breakdown of BNP. And by preventing the breakdown of BNP, you actually continue to get vasodilatation, a lower blood pressure, reduced sympathetic tone, less aldosterone levels, and more diuresis and natriuresis. When you looked at the data in this trial, these patients were on the best background of medical therapy that's ever been produced in any trial. And when you looked at the outcome, what you saw, if you just look at the mortality, again, it's roughly about a 3% absolute risk reduction in mortality and a significant reduction in the risk of hospitalization for heart failure. These are the forest plots of the patient populations. And what I want to point out to you is most of the patients here in the time since diagnosis of heart failure, you might see your heart failure patient in the clinic and think they were diagnosed a long time ago. But if you look at this 5 years, patients continue to benefit from changing their ACE ARB to Entresto. So how long you had heart failure didn't really matter depending on your benefit from this drug therapy. In our newer age of heart failure therapies now, we're looking at these types of drugs, which are the SGLT2 inhibitors. When we studied these drugs for diabetes, it was quite by accident that we saw that there was some benefit in heart failure and heart failure hospitalization. This is a very large trial called the DAPA-HF trial, 4,700 patients with class 2 to 4 heart failure, EFs less than 40%, and a simple drug regimen of this dapagliflozin or Farxiga, 10 milligrams once a day. And what you see here is the primary outcome is reduced by nearly 5%. Hospitalization for heart failure is reduced. Death from cardiovascular causes is reduced by 2%. And again, you see this reduction of roughly a little over 2% from all-cause mortality. If you look at where the survival curves diverge, they're very similar to our other heart failure therapies, whether it's death from any cause or cardiovascular death. they're diverging at about 9 to 12 months after therapy. This is the newest kid on the block. This Farxiga is our newest treatment option for heart failure. And in this trial, the results of the trial were beneficial of the drug, regardless of the presence or absence of diabetes, and there was no increased risk of major hypoglycemia. What this means is these patients, some of them did have diabetes going into this trial, but a lot of them didn't have diabetes, most of them didn't. And whether you had diabetes or not, you had a mortality benefit from this drug when you had heart failure with a reduced ejection fraction. I'm going to shift gears now. That's kind of a tour de force of the medical therapies for what we have for heart failure with a reduced ejection fraction. I'm going to talk a little bit about device-based therapies. This is the original MADIC-1 trial. This trial enrolled a very high-risk group of patients, people that had had non-sustained ventricular tachycardia, and then had inducible and suppressible ventricular tachycardia on an EP study, and randomized them to a defibrillator or conventional medical therapy. Now remember, conventional medical therapy at this time in the late 90s was essentially afterload reduction. There were no beta blockers, there was no afterload. There was no aldosterone antagonist, but we saw dramatic reductions in mortality in this high-risk group of patients with a defibrillator. We extended this to the MADIC-2 trial with 1,232 patients, and we required them not to have non-sustained VT, and they did not have to have an EP study. All they had to have was a prior MI and an EF of less than 30%. And we saw significant reductions, not as dramatic as MADIC-1, but nevertheless a 6% absolute risk reduction in mortality, with survival curves starting to diverge at about 9 months. The sudden cardiac death and heart failure trial was a 2,000 patient trial. This looked at the effect of antiarrhythmic drug therapy. Maybe amiodarone would prevent sudden cardiac death, and we didn't have to put a defibrillator in these patients. So it's essentially the same group of patients, with the exception of the fact that the SCUD-HEF trial enrolled non-ischemic and ischemic cardiomyopathy patients. What you see here in the overall trial population is that there's a benefit for implantable defibrillator therapy, with survival curves diverging at about 18 months. And when you break this down into the ischemic population here and the non-ischemic population, the Kaplan-Meier curves are very similar, but the p-value for the non-ischemic was not quite met in this trial. It was met in the ischemic population. Nevertheless, it's accepted therapy now that if your ejection fraction is less than 35%, whether you're ischemic or non-ischemic, on optimal guideline-directed medical therapy, that it would be appropriate for you to have a defibrillator. What about this concept of cardiac resynchronization? We know that there are a group of patients whose left ventricles don't contract synchronously, people with very wide QRS rhythms and left bundle branch blocks. And those patients derive a benefit in LV remodeling from resynchronization therapy. We didn't really understand this benefit until we looked at this trial called the CARE-HF trial. In this trial, patients were given a resynchronization device, but they were not given a defibrillator. And as you see, there's significant reductions in heart failure and heart failure hospitalizations, but there's also a 10% absolute risk reduction in mortality simply with putting the patient, giving the patient a pacemaker that resynchronizes their ventricle. Now, more recently, we've identified this problem of secondary mitral regurgitation. Secondary mitral regurgitation occurs in a lot of our heart failure population, and it does improve in a significant percentage with guideline-directed medical therapy. But a lot of people remain with moderate or moderate to severe mitral regurgitation. This is a trial called the COBB trial, and it looked at this therapy called transcatheter edge-to-edge repair. This is a percutaneous way to repair the mitral valve. Patients in this trial had to be evaluated by an interventional cardiologist and a surgeon and deemed not to be a candidate for mitral valve surgery. And when you looked at this, heart failure hospitalization in 2 years was significantly reduced. So in patients with moderate to severe or severe mitral regurgitation with a not severely dilated left ventricle on maximal medical therapy with an EF of 20 to 50%, they derive a significant benefit in reducing heart failure hospitalizations. What was surprising about this trial to some, including me, was the mortality benefit that you saw with this trial. This is a 17% absolute risk reduction in mortality that was out at 2 years. So just to kind of review our therapies, we saw reductions with angiotensin receptor blockers and ACE inhibitors in mortality. We saw really dramatic reductions in beta blocker therapy and additional reductions in mortality with mineralocorticoid receptor antagonists, or so-called aldosterone antagonists. When we looked at the effect of adding Entresto, or this what we call ARNI, this angiotensin receptor neprilysin inhibitor, it again added another 20% reduction in mortality. So it's now considered a class 1 indication to change your patient from either an angiotensin receptor blocker or an ACE inhibitor to a ARNI, or an angiotensin receptor blocker neprilysin inhibitor drug. And this slide reviews everything. So you look at ACE inhibitor or ARB and decreases in mortality and how much we get. We again talked about the addition of the ARNI, talked about our reduction in mortality with beta blocker therapy, reduction in mortality with aldosterone antagonists. In patients with class 3 and 4 heart failure who are self-described African Americans, the addition of isosorbide dinitrate and hydralazine further reduces mortality. And now we're seeing reductions in mortality with SGLT2 inhibitors. And then we have our device-based therapies, or implantable defibrillators, CRT providing a 10% absolute risk reduction in mortality, and in appropriate patients with moderate to severe or severe mitral regurgitation, further reductions in mortality with the mitral clip. This is a paper that was published last year out of the Lancet, and this was a projected analysis looking at the number of years added with the newer medical therapies. So if you just looked at this red line right here, this is the ACE inhibitor and beta blocker therapy. So this is essentially what we're doing from the 1990s to the early 2000s. And if you looked at this conventional therapy, this is years of life added to the patient. So you could add 6 years of life to your patient. Now, when you look at the addition of the angiotensin receptor neprilysin inhibitor replacing the ACE inhibitor or ARB, adding your mineralocorticoid receptor antagonist in appropriate patient populations, aldosterone and eplerenone, and then adding also the SGLT2 inhibitors, the one that we have approved right now is Farxiga, but there are other ones in the pipeline. We can now add another 8 years to patient's life with a projected survival now extending out to 15 years. So in summary, there's a large symptom and mortality benefit from guideline-directed medical therapy in heart failure. Standard guideline-directed medical therapy should be up-titrated maximally, especially with beta blockers to help prevent sudden cardiac death. Heart failure with a reduced ejection fraction is a progressive disease, and maximal guideline-directed medical therapy is critical for best long-term outcomes. The addition of device-based therapies such as a defibrillator, cardiac resynchronization, and mitral transcatheter edge-to-edge repair in appropriate patients serves an important complementary benefit in the management of heart failure with a reduced DF and mitral regurgitation. And this is in patients who have been on maximal guideline-directed medical therapy. I'll open things up for questions, and I want to thank everybody for having me today.
Thank you, Dr. Jabahari. That was a phenomenal presentation. This is Dr. Price, and every myocardial cell seems to know you personally, so you certainly have brought us a lot of information. As we have people pulling their questions together, I just have a poll that I want to present to the participants. So on the poll, just answer whether you are personally familiar with a family member or patient who has had a heart transplant. We'll leave it open for about 10 more seconds and then display that. And while that's coming in, the question that I had was, you mentioned in one of the studies with regard to some race and ethnicity data, but for the large part, we know that people of color are not particularly able to get heart transplants for a whole host of reasons. And so I'm wondering if we have some information with regard to how there is oversight on transplant ethics and who's on the list and who's not. And as you can see from the poll, the majority of individuals who are not familiar personally with individuals who've had a heart transplant. And that's somewhat telling.
So I'm not, I know a little bit about the heart transplant list. I'm not an advanced heart failure transplant specialist. How patients and their ethnicity play into that is not something that I am personally familiar with. What I will be honest with you and say what I worry more about rather than the transplant is device-based therapies like ventricular assist devices and making sure people are offered those ventricular assist devices. To me, that's kind of the gatekeeper type. Once you're in the hospital and you're getting inotropic therapy and you're getting vasoactive therapy, or you're being evaluated for a ventricular assist device, that's what kind of starts the ball rolling, so to speak, for transplant. And because of the shortage of hearts, what I really, and device-based therapies like VADs have really extended people's lives and allowed them to have a good quality of life. So what I want to see is, as much as I want to see heart transplants in the bodies of underrepresented minorities, I want to see VADs in those patients. I want to see our social system, our case management system be able to provide patients the support, the health insurance and what they need to be able to qualify for a VAD, because that's what helps keep them out of the hospital. And those patients keep on coming back to the physician office for care. And as long as they keep on coming back to the physician office for care, they're getting their medicines adjusted, they're being kept out of the hospital, those types of things.
Great, thank you very much.
Dr. Price, if I could add, remember that heart transplantation is at the end of therapy, and I think that one of our goals, particularly for our primary care community, is to identify people at risk early on. Prevention is really the key here. Unfortunately, irrespective of what therapy you're looking at, whether it's medical therapy, device therapy, or transplant, unfortunately, underrepresented minorities have poor outcomes and are identified and participate in those types of therapies in every demographic that we look at. And unfortunately, we haven't solved the problem of the systemic problems that need to be addressed. I want to thank Dr. Jabahari for a whirlwind lecture from Foxglove to SGLT2 inhibitors, RNAs. In just a few minutes, he's covered just a tremendous territory in the history of our approach to heart failure. And so thank you very, very much for this wonderful presentation.
Thank you very much, Dr. Douglas. That means a lot coming from you.
Any other, if no other questions, I will turn over the moderating duties to Dr. Price.
Thank you, Dr. Douglas, for that wonderful session and for bringing these speakers to us. Our next session is going to talk about addressing healthcare gaps for women of color. We have two phenomenal presenters who are going to bring us up to speed with where we are with regard to bringing equity for healthcare for women. Our first presenter is Dr. Mackenzie Jackson, who's at Compassion Care for Women. She's an obstetrician and gynecologist in Savannah, Again, the power base of politics because of our president, Dr. Petty. She completed her medical education at the Morehouse School of Medicine and completed a residency at the Bethesda North Hospital. Dr. Jackson, please present.
Thank you. All right. So today's talk is about the Georgia Moms Project. And I wanted to start with a little bit of background on how this project got started. And it's really based on this maternal mortality crisis that is happening in the United States. I consider myself a community obstetrician. I'm under the umbrella of the Curtis V. Cooper healthcare system here in Savannah. And we are an FQHC and a safety net facility with a diverse patient population. But when you look at the national maternal mortality rates compared to industrialized nations, they're really high. About 29 per 100,000. But when you drill it down to Georgia, the maternal mortality rates overall are about 49 to 50 per 100,000. And when you look at Black women, that rate is as high as 66 per 100,000. These rates are staggering. And it's really only been since 2008 and really around 2012 and 2013 in Georgia that the Maternal Mortality Review Committee has been able to provide a lot of information in terms of the cause and also some issues that are leading to these deaths. So one thing that we do know is that about 2/3 of the deaths occur right after delivery up to 1 week postpartum. And 2 out of 3 of these deaths are preventable. So when you think about that, that is really something that is a crisis. I mean, we're in an industrialized country, and instead of the mortality rates decreasing, they've been increasing over time. There's been a lot of work around looking at preventable factors, and that's around education and around hospital preparedness, and also something called social determinants of health. And I want to mention the groups that are doing a lot of work around that. There's the Georgia Perinatal Collaborative that works with hospitals in terms of readiness, being prepared for postpartum hemorrhage, for hypertensive disorders, and prevention of venous thromboembolism. But there's somewhat a gap in terms of even with these interventions and even with a lot of information that's out there, these disparities for Black women persist. And I do have an infographic that I want to share from the CDC, which I think it's important for everyone to see to kind of drill this down. So as we're looking over time, and so many of these interventions—
I was looking for the questions, and there were no questions in the chat.
Okay. We look, if we look at the bar, Black women are represented by the deep purple color. If you look over time, the number of deaths are significantly higher despite many of the interventions. We're also looking across the nation, and I may not be able to move this down, but even when you look at states that have lower rates of maternal mortality, Black women still have significantly higher rates. When you look at age, the rates are still higher for Black women. And when you look at educational level, even with a college degree, a Black woman is about 5 times more times likely to die during childbirth or within the year after. And there have been a couple of high-profile cases, such as Serena Williams, Beyonce Knowles, women who have had complications. Beyonce had preeclampsia. Serena Williams actually had a pulmonary embolus and felt that she wasn't listened to when she alerted the staff that there was something that was wrong. And so there may be issues related to, we know that there are issues related to implicit bias in women of color not being heard, particularly around pain and some of the concerns for complications. So as a community OBGYN, mostly focused on taking care of patients and just the day-to-day of prenatal care, I really felt that I needed to get off the sidelines. I'm in Georgia. I'm taking care of women. I have a predominantly African-American population. I really felt that there was something that could be done to add to the vast work that's already being done. And hence, I reached out to Dr. Heidi Altman, who is an anthropologist and who has worked with me on other projects outside of my practice. And so we literally sat down in the office, and hence the genesis of the Moms Project. And it's really designed, it's a different type of study. It's a qualitative study. It's involves interviewing women, but not in the traditional, just recording a interview. They're asked questions in a way that we will hopefully be able to take this data and make some meaningful change. So I'm going to hand this over to Dr. Heidi Altman so that she can tell you a little bit more about the project and where we are right now. Dr. Altman.
Thank you. Good morning. I'm so glad to get to be here with you all. This is not my normal my normal conference setting. I am a qualitative researcher, so I'll be talking about things probably a little bit differently, certainly than the previous presentation, which was very detailed in medicine. But Dr. Jackson talked about how we came to do this project, and I've worked in Native American communities and African American communities in the Southeast for a long time. And in my prior work with Native American communities, we did a lot of work with trying to reestablish traditional Native American midwifery practices in contexts where the Indian Health Service or other agencies had come in and closed hospitals on reservations so that women had to travel extensively to get to care and things like that. And there are a lot of similar issues happening in Georgia. We do have a physician shortage for especially OBGYN care. We have difficulties of women being able to get to care in a timely fashion and so on. So I thought there might be some overlap. I'm going to just share my screen with you with a little short PowerPoint. It's nothing really exciting, but it just sort of gives us the background for some of the things that we'll talk about. So we, as Dr. Jackson highlighted there, we have got a serious problem in Georgia with maternal mortality. And for Black women especially, but women of color in general, there is a much more significant rate of death before, during, and after birth. The data in Georgia for Hispanic women is not exactly clear, but we're also going to try to work on that as well. And so, as she mentioned, the windows of concern for women are 18% experience this mortality issue during pregnancy, 55% within this 42-day window around the birth period, and then about 27% in the 1 year postpartum. The CDC and Georgia Maternal Mortality Review Commission used this model looking at these 5 factors that contribute to the maternal mortality problem, and those include the patient and family, the provider, the facility, systems of care, and the community. So we use those 5 points later. I'll come back to them. After reviewing all of this data that was collected, I think everybody was sort of taken by surprise when these reports started coming out about the maternal mortality rate in the United States, but especially in Georgia. I don't think anybody was quite, I think when you're in your own practice or you're doing your own thing, you may not see how big this problem is. And I think people were sort of set back by that. So the Maternal Mortality Review Commission came up with some recommendations that Georgia should mandate an autopsy on all pregnancy-associated deaths, that obstetricians should provide case management during pregnancy and postpartum, and that Medicaid should be extended. So this is certainly a problem that has come up in the interviews that I've had. So during the window of time when the maternal mortality crisis, especially in that postpartum period, was so significant, women who were on pregnancy Medicaid only had 6 weeks of care, and then the pregnancy Medicaid went away in Georgia. And so they were basically left for the rest of that year with little to no care, depending on, what other care they were able to put together. They also recommended that obstetricians use a validated instrument for screening perinatal mood and anxiety disorders. And this is something also that we see in the data from the MOMS Project, that mood and anxiety disorders are not uncommon. And they also recommend that all providers, primary care, obstetric, and any other providers, initiate pre-pregnancy counseling on all women of reproductive age in accordance with the ACOG, and recommendations to optimize health, address modifiable risk factors, and provide education about healthy pregnancy and family planning counseling. So these are recommendations that are certainly borne out by the things that we've seen with the MOMS Project. So let me just give you a little information about that. As Dr. Jackson mentioned, this is a qualitative project, which means that I'm not necessarily looking to collect statistics about people's health, but I'm trying to capture their lived experience and then correlate that with their demographics through statistical correlation of that. So that means that we collect, anthropologists do what are called ethnographic interviews, which means that we're trying to frame the interview around particular issues, and then allow the person an open-ended opportunity with prompts and follow-ups to provide all the information that they can about their experience, or that they will about their experience. And so this is something that has not really been done before, especially in Georgia. And so we wanted to use the factors identified by the CDC, those 5 patient, family, provider, community, and so on, those factors, and then the recommendations by the Georgia Maternal Mortality Commission, to see if we could get some information about how women are experiencing these things in their own lives. So we collect these narratives, and among the various, again, this is sort of just a continuation of the prior slide, but basically, as Dr. Jackson mentioned, it doesn't matter whether women have law degrees. I mean, I've interviewed women of all socioeconomic states, of all professions, women of color, women, white women, all kinds of women in this process. And there's not really anything that that has to do with profession or education or anything that has an effect on these things, although you would think that it might. But on the other hand, social determinants of health have a huge effect on these outcomes. So we started collecting 45 to 90-minute open-ended interviews with adults who've had babies since 2009. So we set 2009 as the start date because that's when the Affordable Care Act was passed, and that changed some things about insurance and Medicaid here in Georgia. And we also want to make sure that women are outside the windows of concern identified by the CDC. So no one is interviewed during their pregnancy and no one is interviewed during the postpartum year, because I am not a medical doctor. And if they present with some sort of problems, I can't help them. And so I want them to be sure to have been through this concerning period. And so the interviews are structured around those 5 factors identified by the CDC, but they particularly focus on the person's experience of pregnancy and maternal health care in the state of Georgia. And these participants are recruited through social media. So we have a Facebook page and a Twitter account that we use to identify, and we got a fair number of our interviewees through that, where people sharing that. And then also by doing intercept interviews at Dr. Jackson's clinic and some of the other Curtis V. Cooper clinics in Savannah, where a provider could recommend someone or recruit someone, and then I would just be there waiting, and they would come and I would interview them. And so the first round of interviews has been completed. We've interviewed about 40 women. Those are basically, we sit down and go through the questionnaire with the women. They fill out a demographic survey that gives us information about their socioeconomic status, their ethnicity, their education level, the number of children they have, and so on. And then they're interviewed, and all of this is completely anonymous. So all the data are de-identified. So when they fill out the demographic survey, they're given a random ID number, and then that's how their interview is identified and kept together. So that's all been done. The transcripts are then mechanically processed, and then I've been having students go through and clean up the transcripts so that we can get them into working order. And then those transcripts are analyzed using in vivo qualitative data analysis software, where we can go in and code according to the questionnaire. So we have some outcomes that we expect based on the people's response to the questionnaire, but then we also can do open coding based on women's own particular experience that may not align with the questionnaire. And so throughout this process, it's mostly just been me doing the interviews, and then we had the pandemic and everything else happen. So things kind of slowed down after we got about 40 interviews. But thanks to Dr. Jackson's connections to the Medical College of Georgia and the St. Joseph's Candler campus for the Medical College of Georgia, the MOMS project is about to, as soon as we can get all the details worked out, which we're working on, we're about to include a cohort of medical students as interviewers. And so this will greatly expand the reach of the MOMS project, and we'll be able to reach patients and interview subjects that we would not otherwise have access to. And it also gives young medical students training in qualitative data collection and analysis, which I think, I hope will actually end up contributing to the quality of their practice, because they'll be able to ask questions or know how to ask questions in open-ended fashion that gives them probably more information than they might have otherwise. So that's something that we're hoping to get going in the next week or so. Formally, they'll get 3 trainings on how to do qualitative interviewing, how to work with transcripts, and then also how to do coding and analysis of qualitative data. And that'll go on as long as, as long as we're all agreeable to that. So we, has a potential to go on year after year. And so we're using this information that we're collecting to potentially, the goal is to write a grant that will propose interventions on the behalf of the mom, so that they would have more connectedness with other people who are in their same position. Some of the things that have come out of this preliminary round of interviews is that women don't have care if they've been on pregnancy Medicaid. They don't have care after the pregnancy Medicaid expires. And so I know that the MMRC has recently influenced the Georgia legislature to expand that, I think, to 6 months after delivery, which is better, but still not the whole year after. Another thing is that women, especially in rural areas in Georgia where I live, are experiencing isolation and also some of the effects of postpartum anxiety and depression without a lot of support in this area. And so these are things that we're trying to figure out, potential behavioral interventions for them, or ways to put them in cohorts with other women who are experiencing similar problems. And so that's all I have to show for now, but I'm happy to answer questions, or Dr. Jackson's happy to answer questions, I'm sure. So.
Well, thank you very much, Dr. Altman and Dr. Jackson. I know we have a number of OB-GYNs on the call, so please feel free to ask questions. I know somewhat unrelated specifically to the projects that you're doing, and certainly the Georgia project on maternal mortality, we're seeing across the nation a wave of legislation with regard to abortion rights and family planning rights. And, this can only impact the numbers negatively if unwanted pregnancies are forced on women. What's your stance with regard to educating students and young physicians about these issues? Because I know it's a moral issue, but it's a life issue as well, and people have to separate their moral issues from that.
Yes, I mean, I'm sure Dr. Jackson can also talk about the dilemma for obstetricians and the moral dilemma about that. But the other thing that I would like to say is that one of the things that we've definitely found in interviewing these women is that Georgia, especially rural Georgia, has very poor sex education in high school and lower grades, so that women end up not really knowing or understanding necessarily how pregnancy occurs. I've interviewed people who weren't really sure about that. And then oftentimes, especially with some of the small hospitals and in these rural areas, there's not a lot of childbirth education that happens either. Certainly not comprehensive childbirth education where women know what's happening to their body throughout the process of pregnancy. And so a lot of the choices that could be available to them or that they might want to advocate for could be improved if they had better education. So I think certainly in terms of educating the moms, that's one thing. And I think in terms of educating the young medical students coming up, they see this as a problem. I mean, the ones we've already begun orienting them to the project, and they've already seen this as a problem. And I don't know, Nkenga, if you want to go ahead and say more. You're muted.
So my comment is, not really getting into the politics of the issue, but a lot of the FQHCs have become family planning centers to kind of cover some of the gaps that are out there in terms of family planning. So at our site, we offer, long-acting reversible contraceptives. We offer counseling. So there are still some facilities that are available, but I think comprehensive education is what is needed. Definitely in terms of pregnancy prevention, options for doing that, as well as preconceptual counseling, as well as good counseling during prenatal care. Dr. Altman talked about the obstetric shortage, and what happens in a place like Savannah. I can't speak for places outside of Savannah. The providers have lots of patients that need appointments. A lot of times patients can't even get in because providers aren't taking care of aren't accepting new patients. So it's really difficult to handle the volume and to do the educational part, particularly during the pandemic, but it is something that we work really hard to do. So there's a lot of pressure on the providers right now.
Mm-hmm. And some of the pediatricians on the call, I don't want to call people out by name. How are you dealing with the teenage pregnancy in your particular area? Because we know they're at higher risk for poor maternal outcome. Anybody out there from Covington, Georgia?
You took it upstairs, you take it downstairs.
And someone in the chat also mentioned. Yeah, go ahead.
Dr. Stafford.
Oh, yes.
Retired OBGYN from Southwest Georgia. I have a question for our two presenters. From the preliminary interviews that you've conducted so far, and looking at your preliminary data in reference to these social determinants that have been well defined, particularly as it relates to this population group. Is access, are you gaining insights in terms of access to any one of those determinants as being a factor towards the overarching and emerging problem of poor maternal outcomes?
Well, certainly. So at this point, when we started this project, it was sort of designed to be as broad as possible, to include as many people as possible, so we could make some comparisons among the experiences of people. And I would say certainly that people who are living in rural areas, and also people who are living in lower socioeconomic status, have greater problems having access to care. And certainly depending on where they live and whether or not they're deemed to be a high-risk pregnancy, that has a huge effect also. So when you live in rural Georgia, you can, if you live in rural Georgia, as I'm sure you know, Dr. Stafford, it's hard for OBGYNs to take on the responsibility for someone who has a high-risk pregnancy, or even the potential for a high-risk pregnancy, because the high-risk pregnancy centers are so few and so, excuse me, so far from everything. So there's one in Savannah, I think there's one in Macon, Augusta, Atlanta, but women who live in rural Georgia, like around here, usually have to drive at least an hour or so for care. So we see those kinds of effects, certainly, in terms of women living in poverty, women who are living in rural areas. Those are huge effects on their care. There's no clear cut. I'm trying to say this parsimoniously, but also clearly. So there's at this moment, with the number, it's a relatively small number of people in terms of statistical analysis, but for qualitative analysis, that's a large number of interviews. But we don't have a clear-cut statistical correlation between ethnicity and care issues, or between education level care issues, or anything like that. But we do see that the farther women live from care, the more difficult their experience is usually. I'm not sure if you can think of something else, Dr. Jackson, please jump in.
I would say that there is in Georgia a distinct difference between the rural experience and the urban experience, particularly because there's so many rural hospitals that are either closed or shutting down their obstetric units. So for those individuals, if there's not a practicing obstetrician in town, they may have to drive or travel 1 to 2 hours for care. And if they don't have the transportation, they may not receive care until the time of delivery. So that's a big issue. So hospital closures, distance to care. And so those are issues, beyond the issues of the racial health disparities that hopefully the Georgia Moms Project can answer for patients.
And one of the questions that came in, how can women across Georgia be referred to be included in the Georgia Moms Project? And then after that, I'm going to ask Dr. Stafford to talk about the Two Georgias initiative to address some of these rural health inequities.
Okay, so I put in the chat, there's an email address, the georgiamomsproject@gmail.com. You can schedule an interview there, or there's also a webpage, georgiamomsproject.org, where you can go. And I think there's a button to schedule an interview there. So either way, and we're happy to talk to anybody. We can do it by Zoom. We can do it by in person, whatever people like. So
Great. And we had a number of dynamic medical students as part of our panel yesterday. I'm sure they would be interested in helping in doing some of the interviews. We actually have a cadre of students at the South Georgia PCOM in rural Georgia interested in research. So I'll also connect them with you.
That'd be great. Thank you.
Great. Dr. Stafford, you want to talk about the Two Georgias initiative with regard to?
Yeah, 2 points to add to the conversation. would the investigators, the researchers, take a look at the data that's been gathered over the decades in reference to early prenatal care access? I think that will give you some insight as to where to start targeting focused activities and areas in terms of backing that with your qualitative research. I go back from the dark ages in terms of my experience, but that was one of the outstanding findings that I had from my years of practice in a rural setting. This early access data that lack qualitative support. In reference to the second point, that one of the activities that I've been engaged in since retirement has been the Two Georgias initiative, which is focused on healthcare improvement at the community level, targeted in rural Georgia. And that would be a good source for you guys to consider linking. And I'll be sure to help you make that linkage with this activity that is ongoing. Thanks, Winston.
You're welcome.
Thank you.
And we have a question from Dr. Staples-Horn with regard to, do you think the expansion of midwifery programs will impact poor maternal outcomes in Georgia?
I mean, Dr. Jackson, I'm sure has opinions about this too. I think it would absolutely affect impact. It would affect the impact to access, right, of some kind of, especially as Dr. Stafford was talking about prenatal care and things like that. But Dr. Jackson.
I think we have to think of this problem in a more collaborative manner, and I think it would be a good idea to expand coverage, more collaboration with physicians and midwives. Once again, the difficulty is really the obstetric shortage. And so, requests for coverage come from faraway places, and most physicians just aren't able to do that. But I definitely access to competent providers would be a solution for some of these issues.
Great, thank you. And we're going to have a robust discussion in one of our later panels with regard to the changing dynamics of healthcare with mid-level providers and how that impacts on physicians. So I'm sure this will be a very heated discussion as we move forward. Any other questions from our audience of participants? Great.
This is Dr. Terrell. I'm a guest from Memphis, Tennessee, and I'm a pediatrician. You had asked a question and I wanted to answer.
Great.
What did we do? Well, for all of our teenagers, when they have physical examinations, it is mandatory for our staff, for our medical staff, to talk about risky behavior, STDs, STIs, and we pull no punches. And we let the patient and the parent know that they cannot leave unless we explain to them the STDs, STIs, risky behavior, and drugs. That's a part of their mandatory part of their physical examination. That's just a short answer. And I want to thank you all for letting us attend this conference. I'm the secretary for the Volunteer State Medical Association. Our president I see is on too. And I also see about 3 of my classmates here too, like Dennis Turner and a couple of the others. Dr. Stafford.
Great. Well, you're always welcome from Tennessee. So thank you very much for joining us. Other questions? Let me throw out a generic one. I know we will have some involvement with regard to COVID-19, but what impact do you feel COVID-19 has had in setting us back with regard to maternal mortality? What do you think it will portend over the next couple of years as we look back on the data for 2019, 2020.
I definitely think it's had a detrimental impact. I think, the data is not yet fully out there, but I think in terms of numbers of rates of COVID infection, in terms of morbidity and mortality, I think it's definitely going to be impactful in definitely in terms of access to care. That was a major issue. We went to telehealth visits. We scaled down visits. Healthcare systems were challenged. I know here we were working on several initiatives related to maternal mortality, and a lot of those had to be shifted in favor of COVID protocols. So I'm also interested in what the data will show, which always lags a couple of years behind.
And as we move forward interviewing, we're going to include questions about that in the questionnaire that forms the basis of the interview. So, we already asked if you have pre-existing conditions and things like that, but we can add this in also as part of the, data collecting method. So we'll know a little bit better later.
Great.
I would suggest that you add in your data collection piece a couple of questions in terms of long COVID related impacts, because it has been my experience that the support systems for new moms in the postpartum period have been decimated over the past couple of decades.
Yes.
And the COVID impacts and the long-term sequelae on grandmothers and grandparents is going to be profound.
Yes. Yes, I agree. And I appreciate the suggestion. I think that's absolutely true.
Right. Yeah, I will send out information. There will be a major conference out of the State University of New York in Brooklyn on the long haul syndrome in African Americans, put on by the Black Health Trust, and I will send that information to all the attendees. Dr. Jackson, Dr. Altman, thank you very much for your presentation. It's been enlightening with regard to a number of issues related to maternal mortality and the disparate care and outcomes. And so we look forward to the ongoing work that you're doing with the Georgia Moms Project. Dr. Collins, did you have a comment?
I did, actually. Thank you. I wanted to offer that the opportunity to integrate telemedicine into our practice has actually provided some unique advantages that we did not have before COVID-19. And so in terms of preconception care and even postpartum care, I have been able to reach a lot more patients who may not have been able to reach me for a consultation. And so that can happen, and then they can come in later on for birth control or for other GYN care. And so I actually have seen some advantages from some of the things that we've been able to do. And in terms of follow-up, if patients, I serve in 2 rural communities and patients are driving easily 45 minutes to an hour. And if they have challenges with childcare or being able to get off work, I'm able to do that follow-up even a little bit better than I was before. And so my hope is that we will have a hybrid model going forward where we can usually really integrate telemedicine into our regular in-person practice. So there have been some challenges, but there also have been some advantages as well.
Great, thank you, Dr. Collins. There's always flowers in every patch of dirt. You just have to look for them and cultivate them. So thank you for that comment. Great. So we're now going to transition over to our next presenter, and that is Dr. Batamosi, who's at Augusta University Medical College of Georgia. She's a pediatric hematologist oncologist in Augusta. She received a medical degree from the Faculty of the Medical Sciences in Jos, Nigeria, and then completed her residency at the New York Presbyterian Hospital in Brooklyn. She completed her fellowship in hematology at the Hofstra Northwell School of Medicine, and her research and expansive work in the area of sickle cell disease and oncology is stellar. I've personally referred patients from South Georgia to her center, and she has been phenomenal in her response and care. And so we look forward to hearing her presentation. So Dr. Badamosi.
Good morning, Dr. Price, and good morning, everybody. Thank you for the kind introduction, and thank you for inviting me to speak here with such an accomplished group of professionals this morning. So, you know, I'm honored to be here, and thank you for the invitation. So I am going to share my screen, but today I will be talking about updates in sickle cell disease treatment. Let's see. Why do I have to? Can you see my screen?
Yes, we can.
Okay, perfect. So today I will be discussing updates in sickle cell disease treatment. One thing I will say I struggle with in virtual presentations is the lack of audience feedback. So my hope for today is that this will be an interactive discussion. And while I have several slides and I'll be talking about different aspects of sickle cell disease treatment, please feel free to interject with questions. I'm hoping for a robust discussion today. So today I will start by giving an overview of sickle cell disease. I'm sure we're all familiar with sickle cell in one form or the other, but I will give an overview of the inheritance and epidemiology of sickle cell, the complications, and the pathophysiology of sickle cell. Next, I will review the current therapies that we have available in our toolbox to modify this illness. I will also discuss some adjunct therapies we've used to deal with potentially serious complications. I will next review the newly approved disease modifying agents and the roles they play in sickle cell disease therapy. And finally, I will discuss sickle cell curative therapies, including bone marrow transplant and gene therapy. So I have no personal conflicts of interest to disclose today, but our comprehensive sickle cell program has received funding for its transition activities through a community grant from Global Blood Therapeutics, or GBT, called the Accel Grant Program. So I'm going to start with an overview of sickle cell disease. And we all probably remember this in one way or the other, but sickle cell disease is an inherited disorder of hemoglobin resulting from a single nucleotide mutation in the 6th codon of the beta globin gene. This results in the classic amino acid substitution for glutamic acid with valine, and this causes polymerization of deoxygenated hemoglobin in the red cell. The most common form of sickle cell disease is the most severe, and this is when 2 copies of hemoglobin S are inherited from each parent. This genotype results in sickle cell anemia. Less common forms of sickle cell disease are inherited when one sickle gene is inherited alongside another abnormal hemoglobin. And these range in clinical severity from hemoglobin C, which may be mild to moderate, to hemoglobin beta 0, which is as severe as sickle cell, as hemoglobin SS, and is also considered a sickle cell anemia. In terms of epidemiology, nearly 100,000 patients are affected by sickle cell disease in the United States, and majority of these patients are African American or of African heritage. In addition, 1 in 13 African-American babies carry sickle cell trait, and nearly 2,000 babies are born with sickle cell disease annually. Geographically, a lot of these patients, babies are born on the East Coast and in the Southeast regions, and I'm sure a lot of us can attest to this in our different spheres of practice. Life expectancy of sickle cell disease has evolved over the last several decades, and it has made, excuse me, and so sickle cell disease has gone from a largely pediatric illness with high childhood mortality to a chronic adult illness. This graph here highlights some of the landmark events in sickle cell disease research that have led to advances in longevity, from the National Sickle Cell Act and the introduction of comprehensive sickle cell programs across the country to different disease modifying therapies like hydroxyurea and transfusion. However, we still have a long way to go in terms of life expectancy, because median life expectancy remains in the low 40s for males with sickle cell disease and in the mid to high 40s for females with sickle cell disease. So we have a long way to go. Next, I will be talking about the pathophysiology of sickle cell disease and describing the three key components of sickle cell pathology that lead to the complications we know with sickle cell disease. So these three components are, excuse me. So these three components are interlinked, but I will describe each of them in detail. The first, the more important one that we all remember, is vaso-occlusion. And when deoxygenated hemoglobin is polymerized in the sickle cells, it causes the sickle cells to change their shape. When these, sometimes that shape change is reversible, but when these cells become irreversibly sickled, that is when they lead to mechanical obstruction, leading to ischemia and preventing blood flow to different end organs. So the ischemia can result in pain, which leads to the vaso-occlusive crisis that we all know. But the long-term infarctive and ischemic damage can cause end organ damage pretty much anywhere. Next is hemolysis, and that's both intravascular and extravascular. The hemolysis can lead to anemia and decreased oxygen carrying capacity, but also an increase in breakdown products of hemolysis, which leads to jaundice and hepatobiliary complications. In addition, free hemoglobin is released during intravascular hemolysis, and free hemoglobin is directly toxic to endothelial cells and tubular cells. And so you see some end organ damage from that and oxidative damage. Finally, endothelial dysfunction. This results from cytokine release during hemolysis. And this results in recruitment of white cells and inflammatory cells to areas where the sickle cells are hemolyzing. This recruitment results in endothelial damage and inflammation. In addition, the nitric oxide, which is a natural vasodilator, is depleted by the free hemoglobin that's circulating around the area of hemolysis. And this leads to impaired vasodilation and endothelial dysfunction. This pathophysiology is contributory, especially in pulmonary hypertension and ulcers and cerebrovascular disease that can lead to strokes over time. So the manifestations of sickle cell disease, and these may be acute or chronic complications. The older our patients get, the more likely we are to see the chronic complications of sickle cell disease. But the acute complications we may all remember, especially the vaso-occlusive crisis, excuse me. But others include acute chest syndrome, splenic sequestration, splenic dysfunction leading to a risk of infection, and stroke. Chronic complications are multi-systemic, as you can see from this cartoon here, so I don't have to go into those. And please stop me if you have any questions. So next I'm going to go over the current therapies that we have for sickle cell disease. And I'll start by talking about hydroxyurea. So hydroxyurea is it was the first disease modifying agent that was approved by the FDA in the 90s. And this was based on landmark studies in adults showing that it could decrease pain episodes. Hydroxyurea targets multiple points in the pathophysiology of sickle cell. It decreases deoxygenated hemoglobin polymerization, and it decreases hemolysis, but more importantly, it increases the synthesis of fetal hemoglobin that decreases polymerization within the red cells. Hydroxyurea can also decrease white blood cell production or leukocyte production, and this can potentially decrease the neutrophil-induced damage to the endothelium and the inflammation associated with sickle cell disease. Even though hydroxyurea was approved in the 90s for adults, it wasn't approved for children until 2017. So prior to that, it had been used off-label. It is currently approved for children 2 years and older. However, a lot of landmark studies, including one called the Baby Hug trial, showed that starting hydroxyurea as early as 9 months can potentially modify this disease long-term for these patients, and it's safe and tolerable in children as young as 9 months. So that is what we currently recommend. The indications for hydroxyurea, again, can be decreased frequency, severity of vaso-occlusive crises, lower incidence of acute chest, but we are using it more and more prophylactically to prevent the onset of these complications to begin with. We use it mostly in patients with sickle cell anemia or hemoglobin SS. However, for the other less common genotypes like SC and S beta plus thalassemia, we consider hydroxyurea if they have frequent or painful episodes of pain. Next, I'll be talking about transfusion therapy. Transfusion essentially increases oxygen carrying capacity by decreasing the fraction of sickle cell hemoglobin and increasing and replacing that with hemoglobin A or adult hemoglobin. Transfusions have been utilized acutely for sickle cell complications for decades, but several key trials have demonstrated its utility in prophylaxis, especially for strokes. So current acute indications for transfusion are urgent, potentially serious complications such as acute chest, a stroke, significant anemia with a more than 2 gram drop from baseline hemoglobin, and other end organ complications like intrahepatic cholestasis and multi-system organ failure. Keep in mind that a lot of our patients with hemoglobin SS disease have a baseline hemoglobin that's low. They are baseline anemic and can go around with hemoglobins between 6 and 8. So if these patients are hemodynamically stable, the anemia in and of itself may be alarming, but is not necessarily a reason for transfusion unless they are showing signs of hemodynamic instability. We also use acute transfusions in prophylaxis or prevention of complications due to prolonged general anesthesia. And some of those complications are acute chest and stroke that are more likely to happen when patients are sedated and have low oxygen saturations from being sedated for a long time. Episodic or chronic transfusions, like I mentioned earlier, are used in primary stroke prevention and secondary stroke prevention. In primary stroke prevention, these patients would have had abnormal transcranial Doppler screens, but when they have had a previous history of stroke, they remain on lifelong transfusions to prevent a recurrent stroke. And like I said, transfusions are not typically indicated for vaso-occlusive crises and asymptomatic anemia, but the jury is still out on the role of transfusions in preventing or treating priapism. The limitations of transfusion is subject to availability of donated blood, the risk of iron overload, and also the type of donated blood. So remember that while most patients who have sickle cell disease are African or African American ancestry, many blood donors are not. And so there are subtle genetic differences in red cell antigens, which while there may not be clinically apparent and causing acute hemolytic or acute transfusion reactions, may lead to alloimmunization and development of antibodies over time. Some of the adjunct treatments we have for sickle cell disease deserve mention, especially penicillin prophylaxis, which single-handedly alter the trajectory of sickle cell from being a childhood illness to a disease of adults. So penicillin prophylaxis prevents invasive or encapsulated bacterial infections in sickle cell disease patients. And it typically started as soon as these patients are screened or found to have sickle cell disease on newborn screening. And we continue up until around the age of 5 or when they've completed their childhood vaccine series. And so penicillin prophylaxis is important for any of our patients, for the pediatricians on the call who are seeing patients and who for any reason are not able to be seen in a sickle cell center as soon as they are diagnosed or as soon as the newborn screen comes out. Please, please, please remember the importance of penicillin prophylaxis in these patients.
Dr. Badamosi, as you're about to talk about pain management, may I ask the participants a question?
Sure.
So the majority of sickle cell adult patients overuse potent narcotic pain medications like codeine and opioids. Please respond to the poll. The majority of sickle cell adult patients overuse potent narcotic pain medications like codeine and opioids. We will close the poll in about 10 seconds. Poll closing.
Absolutely. So that's an excellent question. And I was going to, discuss opioids briefly, but it's important to remember that a lot of our patients have their pain misdiagnosed or their pain undermanaged, especially in acute care settings like the ED. There's a lot of bias that surround patients with sickle cell disease who present for acute pain management in the ED. And there's a perception that a lot of these patients are drug seeking, unfortunately. However, a lot of evidence has pointed to the fact that patients with sickle cell disease are no different than the general population in terms of use and abuse of opioids. And one thing I always tell my medical students or my residents who are working with me or who question patients' pain is, if a patient tells you they're in pain, believe them. If they say they're in a 10 out of 10 pain, believe them, even if they have a smile on their face, because these patients have been accustomed to pain for so long that they will manifest it differently from everybody else. So yes, that is an important question and an important point for us to review today. The other thing I wanted to mention as far as pain management is the use of NSAIDs. Now I know this is, I struggle with the use of NSAIDs in patients with sickle cell disease too, because a lot of our young patients, pediatric patients, it's very common for them to use Motrin or ibuprofen over the counter for pain or fever, even in infants. But as they get older, the risk of sickle nephropathy increases and the NSAIDs can exacerbate that risk. And so there is ongoing discussion in the sickle cell community about when to start limiting the use of NSAIDs. It is certainly part of acute care in younger patients, but at some point when we start to see early signs of sickle nephropathy, and this may not necessarily be a change, say, in their creatinine levels, this may be that on a UA, they may start having microalbumin or having proteinuria with still normal BUN and creatinine levels, that we may want to consider avoiding NSAIDs in this patient population. So I just wanted to highlight that today. Let's see, it's frozen. Okay. So next, I am going to talk about the newly approved drugs. Since 2018, there have been 3 newly approved drugs in sickle cell disease management. And so I am going to start with voxelotor. Voxelotor is a new molecule. It was FDA approved in 2018. It is a polymerization inhibitor. So it inhibits the polymerization of deoxygenated hemoglobin. So it targets sickle cell pathology at its core. It has been shown that once it decreases polymerization, that it can increase oxygen affinity and result in decreased hemolysis. It is currently approved for anemia alone. Even though sickle cell anemia patients or hemoglobin SS patients tend to have the most profound anemia, it is currently approved for all genotypes of sickle cell disease. Currently, we use it for patients who are 12 and older. There are currently expanded access programs to offer this to younger patients with profound anemia as well. And that's one of the programs that we offer in Augusta for patients between 4 and 11 who are unable to get access to voxelotor because of FDA approval. Dosing is a once daily oral tablets, and common side effects that some of our patients have discussed are nausea, abdominal pain, diarrhea, and occasionally a mild rash, but these are self-limiting. I think one important thing to remember with a lot of the newer medications is that they do not require the same amount of monitoring that hydroxyurea does. Hydroxyurea is myelosuppressive, and so we have to monitor blood counts very frequently with hydroxyurea use. But with a lot of the newer medications, they don't require as frequent monitoring. Next is L-glutamine. And L-glutamine is an amino acid and oxygen donor. It is believed to replete the NAD redox pathways and just increase red cell and endothelial cell resilience to oxidative damage. As a result, you have decreased hemolysis, but it is currently approved for vaso-occlusive crises. It was shown and demonstrated to decrease frequency and severity of vaso-occlusive crises. It can be used alone or in combination with other sickle cell therapies. It is currently approved for patients who are 5 years and older, and all genotypes of sickle cell disease may benefit from glutamine. The dosing is a twice daily dissolvable powder, and some of the common side effects, all mild, but constipation, nausea, headache, abdominal pain, and again, self-limiting, that parents can modify the dose at home, and they don't need to be seen in the clinic or have blood counts to make those modifications. And those side effects tend to self-resolve. Next is crizanlizumab. So crizanlizumab is a P-selectin inhibitor that decreases leukocyte and platelet adhesion at the site of inflammation and sickling within the endothelium. This decreases the likelihood of a vaso-occlusive crisis and the inflammation around a vaso-occlusive crisis. Its current indication is for frequent vaso-occlusion, and it is approved for patients 16 and older. All genotypes of sickle cell can benefit from crizanlizumab as well. The dosing is a monthly IV infusion, weight-dependent dosing following a loading dose. Common side effects that our patients have described are nausea, fever, occasional pain in the joint and back. But again, these are these tend to self-resolve or tend to be very mild. Any questions so far? Okay. So next, I will move on to updates in curative therapy for sickle cell disease. And first, I'll be talking about bone marrow transplant. So bone marrow transplant is currently the only FDA-approved cure for sickle cell disease. It involves harvesting donor bone marrow or stem cells and selecting the hematopoietic stem cells using antibodies, infusing said stem cells into a recipient or a host after they have been conditioned either with chemotherapy or with radiation therapy. Now, the conditioning for these patients may either be myeloablative, where you are making them profoundly myelosuppressed and getting rid of all of bone marrow stem cells, or it may be considered reduced conditioning, where they are not as high risk for infection, and there's still some residual stem cell activity left in the bone marrow. The actual procedure of bone marrow transplantation is pretty straightforward. I think what makes this a risky procedure is the toxicities associated with conditioning or the chemotherapy. I'm required to prep the recipient, but more importantly, the availability and the selection of donors. So the important points to remember in a bone marrow transplant is that an ideal donor is one who is fully matched, preferably related, and that decreases the risk of rejection and many other complications. Many of our patients, unfortunately, do not have full siblings who are fully matched with HLA. So remember, with HLA genetics, every full sibling has a 1 in 4 chance or 1 in 4 likelihood of being a full match with their sibling. And so in patients who only have 1 or 2 full siblings from same father and same mother, you know, it's a 25% chance, or a 75% chance that they do not match, and only a 25% chance that they will match. So that is one issue that depletes or diminishes the donor pool. And if you decide to look outside the family, you are looking for a matched unrelated donor. So an unrelated donor, this is also where the type of donor comes into play again. So another issue we find is that, again, a lot of patients with sickle cell disease are of African American ancestry, but a lot of bone marrow donors on the bone marrow registry are not. And again, so subtle differences in HLA and genetics can lead to difficulties in finding a matched donor. And this is one thing that I tell my patients too, that, you know, there are a lot of bone marrow registries that I encourage patients and their families to just register for. And a lot of the registrations are free. Just sending in like a cheek swab or a sample and you put yourself on the registry. You never know who you will be helping, but we need more African-American donors on bone marrow registries to increase the likelihood of available donors for our sickle cell patients. When unrelated donors are unable to be, a fully matched unrelated donor is unable to be found, the less than ideal situation is looking for a haploidentical donor. And this is a patient or a family member of a patient who is not fully matched. There are a lot of risks with this type of transplant, and that one is not currently FDA approved. It's still in phase 1 and 2 trials. So, you know, I think the important thing here is that donor availability is really important in getting our patients cured for sickle cell disease. And unfortunately, a lot of our patients don't have access to ideal donors. And maybe one thing I should point out in bone marrow transplant too is the age of transplant. You know, I think there's always a question about when to do a transplant, whether to do it when a patient is younger or when a patient is older. And one of the dilemmas we have is that when a patient is younger, they tend to be healthier, they tend to have less organ damage, so they tend to be able to withstand the effects of chemotherapy and toxicity a little bit better. But some of the long-term effects of chemotherapy have to be considered, and one of those include infertility. So potentially subjecting a patient who has not had any plans to expand their family or to have kids, potentially exposing them to a treatment that could make them infertile is one of the issues that transplanters struggle with. So finally, I want to talk about gene therapy. Now, up until March of this year, I think gene therapy was the promising new therapy on the horizon for patients with sickle cell disease because it avoided the major setback in bone marrow transplant, which is looking for a donor. Gene therapy, there are 3 main types of gene therapy, but they all involve manipulation of the patient's own stem cells And so the risk of rejection is completely eliminated. The three main types of gene therapy are gene addition, gene correction, and induction of fetal hemoglobin. Excuse me. So with gene addition, this involves using a viral vector, most commonly lentivirus or adenovirus, but different centers have used different viral vectors. And the goal is to insert either a non-sickling or an anti-sickling beta globin sequence into the beta globin gene complex. The idea is that when these stem cells are reintroduced into the bone marrow, the patient will start making their own anti-sickling beta globins or beta globins that will decrease not necessarily eliminate the sickle cell completely, but will decrease the fraction of sickle cell and hopefully, convert patients to maybe 40 or 50% circulating sickle cell, and maybe like similar to patients who carry sickle cell trait. The next is gene correction. And in gene correction, we are using either CRISPR technology or TALEN technology to correct the sickle mutation directly on the globin gene. The concern with CRISPR is that it is very labor intensive. Some of these gene correction techniques are very labor intensive, but they also have the risk for off-target sites, even though some centers will say that that risk is low or that risk has been mitigated, but the risk for off-center sites means you never know where else this CRISPR will go and if it will create potentially oncogenic or cancer-causing mutations. And finally, fetal hemoglobin induction or gene induction involves the use of chemical inducers or genetic modifiers to reintroduce the gamma globin that tends to get clinically silent as babies get older. So gamma globin is the analog of beta globin in babies and fetal hemoglobin, but that gets silenced around 6 to 12 months of age. So this induction either targets some repressor genes such as the BCL11A that naturally silence gamma globin production. And by targeting these repressor sites, hopefully increases the expression of gamma globin and makes these patients essentially like patients who are getting hydroxyurea because their fetal hemoglobin increases, and then they have all of the downstream effects of high fetal hemoglobin levels in their red blood cells. So until March of 2021, like I said, a lot of these were promising, but following a report of from Bluebird Bio, I believe, one of the industry-sponsored clinical trials in sickle cell, where there were reports of AML, acute myeloid leukemia, and myelodysplastic syndrome in 2 out of their 9 subjects on the study. The NIH halted all of the studies that they were funding in gene therapy until this was investigated. I believe outside of the United States and in Europe that some of these gene therapy trials are continuing, but that just kind of put a damper on the expectation for gene therapy, and the I guess investigation is still ongoing as to whether or not this was truly related. I believe this was related to a gene addition technique. So I believe it was the lentivirus viral vector that was involved in that the 2 trials that have been halted. And so all of the other studies or trials that involve gene correction and fetal hemoglobin induction are still ongoing. But, I think it just begs caution as to this novel technique and what the long-term effects of that are. And so with that, I believe I've covered a lot of information today, but I'm happy to take any questions, and thank you.
Well, thank you so much, Dr. Badamosi. It's been an excellent overview and deep dive into the issues related to sickle cell disease. As you know, there's been a little bit of a inequity with regard to even federal funding coming for addressing this genetic disorder that affects our population. When you hear the amount of funding and research, even coming from NIH and the private sector, with regard to cystic fibrosis compared to sickle cell disease. But it appears that a lot of the cutting edge gene therapy and new pharmaceuticals are on board, and we really just need to get our clinicians to be aware of the newer treatments and to make those available to our patient population.
Right, absolutely.
Yes.
And again, the new therapies do not require monitoring, and so they can be started by anyone who is comfortable with it. That's not, that takes care of sickle cell patients.
That is wonderful. That is wonderful. Other questions?
Yes.
I know there was one question regarding whether patients needed to stay in the hospital for the treatments.
All of these treatments are outpatient. The newer therapies are outpatient.
Right, but for the prepping for transplantation.
Okay, so for bone marrow transplantation, the prepping, once they get chemotherapy, the conditioning makes them profoundly myelosuppressed and at risk for infection. Many of these patients will spend like 30 to 45 days in the hospital while they're getting, once they get their stem cells reinfused and are waiting for count recovery and, before they are discharged, because they're profoundly immunosuppressed at that time. So usually a 30-day admission, at least.
Is there, do we still talk about a difference between the reaction to crises for children and adults in the United States versus our neighbors in the Caribbean?
In terms of what are we talking about in terms of like pain management?
Yeah, no. I've been taking care of patients, sicklers for years. And when I first started, we were told that even though there was no genetic difference, the people in, say, the Bahamas, Trinidad, and Panama who had sickle cell anemia did not seem to require as much medications in there. They tolerated their crises much better than the kids we treated in the United States.
So I think there's some nuance to that. I think a lot of the sickle cell complications we see, because many of them are related to acute stressors on blood cells and blood vessels. We see that maybe some of our patients who live in high altitude areas or places that are not as humid or places with extreme temperature changes tend to get sick more often. And so, even when I trained in New York, I had a lot of patients who would eventually move down to Florida because they felt that they had fewer pain crises down closer to the equator. So I think maybe in patients in the Caribbean or in some African countries that are, have different climates, more humidity, more warmth, those patients tend to do better. And I think that's climate related. They may not have access to the same disease modifying agents that we do, but they are still at risk for infection and leg ulcers and some of those other long-term complications, sickle nephropathy. But in terms of pain crises, they may have fewer pain crises because those tend to be exacerbated by weather changes.
Thank you.
Sure.
Other questions? Great. quick question with regard to COVID-19. I know my sickle cell patients, the ones over 12, and certainly their parents, I've advised them to rush out and get the COVID-19 vaccine. What have been your recommendations?
So I have been telling all of my patients to go for it. The benefits certainly outweigh the risks. We have taken care of several patients with sickle cell disease who ended up in the ICU from COVID, even though the COVID was generally considered milder in children. But because many of these patients would develop acute chest or other pulmonary complications, we have seen our sickle cell children get the worst end of COVID. And so I definitely encourage all of our patients to get the COVID vaccine.
Well, thank you so much, Dr. Badamosi, for your comprehensive and thorough presentation on the update on sickle cell disease.
And thank you for having me. It was a pleasure speaking to you.
Great.
Okay, I will stop sharing. Let's see.
While we're waiting for Dr. Bass to log back in, are there any other questions from the other presenters that anyone wants to raise? Yes, Dr. Fowler, you had a question?
Yeah, I wanted to comment again on the sickle cell presentation, which I thought was fantastic. One of the questions I think was about how and why in the Caribbean areas and also in Africa that there do seem to be less sickle cell crises and sickle cell patients. I looked at this years ago, and one of the reasons that was thought to be the case was diet. And the diet mainly was because in those areas they eat more yams and cassava, which have a compound called thiocyanate, which decreases sickling of the sickle cells, okay? So years ago, I would tell my patients who had sickle cell to go to the farmer's market and get some cassava, okay? And because the American diet is deficient in this, but in those areas that were mentioned, there are higher concentrations of these foods, and that seems to be why patients don't get into as many crises. So I wanted to comment on that. Another thing is with respect to sickle cell is, and this was mentioned in the presentation about oxidative stress. Oxidative stress definitely can precipitate sickle cell crises. So the question is, how do you get in front of that? And one of the best ways to get in front of that, again, is through obviously appropriate nutrition. I'm back to that again. Plants, that have high amounts of phytochemicals, which are antioxidants, help to obviously decrease oxidative stress. So again, one of the things I think we need to make sure of, and this is really kind of tough because of cultural differences and so on and so forth and what we eat, but I think, this has to be taught not only to children, but also to parents about that we should be feeding these folks more plants and fruits and vegetables in general. And hopefully we can decrease some of these instances of sickle cell that way as well. So I'll stop on that. Thank you.
Great, thank you for those comments. Dr. Bass?
Dr. Price, I also want to say that this is Adrienne Sneed, that I love Dr. Badamosi's presentation. It was excellent. We mentioned about oxidative stress. One of the treatments I use to relieve that, especially for wounds for sickle cell patients, is hyperbaric therapy. It works excellent, takes that stress off the wound, and also it prevents some of the sickling and the sickle cell crisis. So I would add that to a therapy.
Great.
2020 was a very good discussion on heart failure.
And we want to, in addition to Mag Mutual, one of our major sponsors for this conference, want to acknowledge all of our other sponsors for the program who have been instrumental in the work and the success of the Georgia State Medical Association. We will now go ahead and continue with our program. Dr. Bass, are you able to talk with us now?
Albany, Georgia. It's a privilege to present to the Georgia State Medical Association my topic involving COVID-19. First slide.
You're up.
We have experienced a traumatic pandemic over the past 17 months here in the United States. And as most of you know, Albany, Georgia was one of the first locations in the country that was hit hard with the coronavirus. So I had the experience to treat on an outpatient basis, inpatient basis at my local acute care center, and also at my local nursing home. Some brief COVID-19 statistics as of June 17th. Globally, we have 177,120,609 cases, 3.8 million deaths in the US, 33,611 cases, and 606,000 deaths. State of Georgia, 129,177 cases and 21,171 deaths. And just for comparison purposes, in California, we have 3,805,966 cases and 63,252 deaths. Next, please. Of course, basic COVID symptoms, everyone's aware of this: fever and chills, cough, shortness of breath, fatigue, myalgias, headaches, ageusia, diarrhea, abdominal pain, constipation, nausea, nemesis, sore throat, and runny nose, and anosmia. Next. First case, 58-year-old African-American male presents with viral syndrome onset Martin Luther King weekend 2020. Initially presented with sore throat, persistent cough, fever, chills, fatigue, diaphoresis. Past medical history significant for A1C 8.5. During that time, he was inactive, imbibing, and having very little sleep. During the following week, he experienced a persistent fatigue and was out of work for over a week. Only treatment at that time was multiple vitamins. And that was me that experienced that before we had any COVID testing back in January 2020. Next. Of course, universal precautions. This has been stressed throughout the pandemic. The need for social distancing greater than 6 feet apart, frequent hand washing with soap for at least 20 seconds, use of sanitizers, isolation, covering mouth with sneezing. The vaccine has made a tremendous impact, and we have vaccinated 314,969,386 people in the United States, which is quite remarkable. Of course, we need to avoid crowds in poorly ventilated spaces, clean and disinfect areas. At my office, we had been doing temperature checks, and different businesses are utilizing this. And of course, wearing masks. At my office, we're currently wearing 2 masks. Thank you. Next. High-risk populations. These include the obese population, smokers, whether current or history, vitamin D deficiency. Now, the CDC does not recognize vitamin D deficiency as a high risk at this point, but I've noted that in my experience. Of course, patients with organ and stem cell transplants, diabetes, I inserted uncontrolled. It's interesting, the elderly greater than 65 comprised 80% of deaths from COVID, and the age group greater than 45 comprised 95% of deaths. Other high-risk people include COPD, interstitial lung disease, asthma, moderate to severe, cystic fibrosis, and pulmonary hypertension. Neurological conditions, including dementia, heart conditions, including heart failure, coronary artery disease, hypertension, cardiomyopathies, people with substance abuse, and immunocompromised states, which may be iatrogenically induced with immunosuppressants such as prednisone. Next. Vitamin D deficiency and COVID-19 risk studies. I have utilized vitamin D in prevention. I've been checking vitamin D and was sensitized to vitamin D deficiency probably a decade ago at the Georgia State Medical Association. Vitamin D is associated with COVID-19 positivity and severity of disease, according to several studies. I've listed Mustafa Demir et al., who published in the Journal of Medical Virology, May 2021. You can take a look at that study. We've also noted in that study that patients with vitamin D levels less than 12 had poor outcomes versus placebo, 44% versus 31%. Those who had vitamin D levels greater than 30 had lower D-dimers, CRP, and less affected lung segments and shorter hospital duration. However, there was not much significant change in outcome with patients that were slightly less than 30 in that study. Next. Vitamin D deficiency and COVID studies, the Journal of Clinical Endocrinology and Metabolism, Jose Hernandez noted that over 80% of the 200 patients which were studied that were admitted for COVID had vitamin D deficiency. Next. Next case. 63-year-old African-American male, obese, presented after 2 weeks of cough, severe fatigue, and progressive shortness of breath. This is back March 29th. Actually, this should be 2020. Past medical history, BMI 44.6, weight 302 pounds, obstructive sleep apnea, SVT. He recently had a rotator cuff repair and grade 1 diastolic heart failure. He called my office and the nurse immediately instructed him to go to the hospital, which is only a quarter mile from his house. And I called to check on the patient 2 hours later at the hospital to find out that he was still at home. So we arranged for transportation, got him down the street to the local hospital. And of course, he was immediately transferred to our parent hospital here in Albany. At that time, inpatients were being given hydroxychloroquine and azithromycin. He received oxygen, unfortunately experienced DVTs, acute renal insufficiency, and was intubated and expired. This was a patient of mine for 20 years and also a tenant of mine for over 15 years. And unfortunately, although he had my personal phone number, he did not use it until 2 weeks into the disease state. So unfortunately, he did not utilize the access that he had to me. Next slide, please. 69-year-old African-American male presented to office with fever, fatigue, temperature greater than 101. Past medical history, hypertension, diabetes, grade A1C 5.7, BMI 29, weight 202 pounds. Past medical history, remarkable for remote CVA, residual hemiparesis, and dyslipidemia. Unfortunately, when this patient presented to my office, he had a temperature greater than 101.5 as noted. At that time, we had a system-wide policy to send patients home and give instructions. Later that day, the patient's condition declined. EMS was called. Personnel presented to his house. He had a blood sugar greater than 500 and told to take extra insulin. Unfortunately, later that evening, the patient expired. And again, this is a patient I've had for 20 years. His wife was our pre-kindergarten teacher for our children, and he had my personal phone number, but felt they did not want to intrude on my personal time. Next. Hospitalization and death by race and ethnicity. Of course, we all are well aware of the disproportionate impact of COVID-19 on African-American population and people of color, as well as the other high-risk groups. These are race ratios compared to whites. And Native American, we have 1.6 times the cases, Asians 0.7 times, which is actually less than whites. African Americans 1.1 times the number of cases, and Latinos 2 times the number of cases. Hospitalizations, Native Americans 3.3 times Caucasian populations, Asians even, African Americans 2.9 times the white population in terms of hospitalization. Latinos are about the same. Deaths, Native Americans have 2.4 times the deaths of the white counterparts. Asians are equal. African Americans 2 times the number of deaths, and Latinos 2.3 times the number of deaths of the white counterparts. Next. COVID-19 pathogenesis. We're all familiar with the cytokine storm that often leads to poor outcome. This is hyperactivation of the complex immunogenic pathways, which causes various insults to body, including lungs, gut, vasculature, kidney, brain, heart, liver, eyes, and brain. Immune cells such as macrophages, BNT lymphocytes, and MASK, and others are involved. Non-immune cells such as endothelial, fibroblasts, and stromal cells, and others are involved. There's also dysregulation of the renin-angiotensin system. It's believed that ACE2 is the target receptor for SARS-CoV-2. Biomarkers include elevation of CRP, ferritin, decreased albumin levels, and decreased platelets, decreased lymphocytes, and neutrophils. Next. Early during the pandemic, prior to having COVID testing back in late February, March, and April, we would admit patients, and on chest x-ray, sometimes they would have segmental changes in ground glass opacities on chest x-ray. So I started doing CT scans instead of waiting for the test to return 7 to 10 days later. And I found that the acute pneumonitis seemed to be consistent with COVID, which has been proven to be true. The reason that I inserted radiation injury is because there seems to be parallels in terms of the cytokine response with acute radiation injury and COVID. This is an article quite detailed by Carmen Rios et al. In Radiation Research, which you can review, which gives a comprehensive review noting similar pathogenesis, effect on biomarkers, clinical presentation, and disease manifestation. The article suggested much could be learned from acute radiation syndrome in terms of affecting the immune system. Next. The cytokine insults on the immune system and correlations between COVID and acute radiation poisoning. This case is a 65-year-old male employed at a local plant that had been exposed with an employee who had COVID. He presented with a 14-pound weight loss, fatigue, anorexia, and a headache. He was experiencing active pancreatic neuroendocrine tumors and was actually scheduled for surgery the following week. This particular patient, of course, this is prior to the FDA June withdrawal of the emergency use authorization for hydroxychloroquine, but he was given hydroxychloroquine, high-dose zinc, and azithromycin, and his symptoms significantly improved in 72 hours, and he had a successful surgery. Next. Next. This particular patient, 81-year-old male, back in March 19, 2020, presented to my office with acute sinusitis. He returned the following week with a temperature 101.6, mild hypoxia, and he was actually admitted upon being called by the emergency room physician in the middle of the night. The initial diagnosis was community-acquired pneumonia. He was started on ceftriaxone, Cipro, etc. He had no improvement for 3 days. He was placed in respiratory isolation. He had abnormal chest CT and chest X-ray suggesting acute pneumonitis. He had elevated SED rate, CRP, and his COVID test was pending again at that time. It took about 7 to 10 days. He was started on hydroxychloroquine 20 milligrams twice a day, zinc 20 milligrams twice a day, as well as vitamin D, IV, Medrol. Amazingly, 2 days later, he began to improve, and but however, of course, the FDA withdrew emergency use authorization for hydroxychloroquine. But of course, that is not used as monotherapy. Next. I have utilized natural immune enhancers in my practice, including vitamin D, A, and C, echinacea, black seed oil, moringa, zinc, multiple vitamins. There are a lot of agents that have alleged enhanced immune capabilities, but this is what I recommend to my patients. Next. Unfortunately, although the vaccines have obviously shown tremendous impact, just recently I had a patient 2 weeks ago that had her second vaccine, and unfortunately expired a week later. She did not have a autopsy, so we cannot 100%, of course, link her death to the vaccine. Next. CDC and COVID vaccines are recommended for 12 years of age and older. It's been established that they're very effective. You can see 94% after the second vaccine and those vaccines which apply. It's effective from keeping you from getting infected or seriously ill if infected. Typically takes 2 weeks for full immunity after second dose. Helps asymptomatic carriers from spreading. We're still learning about the durability of the vaccine, but it appears it's good for at least 4 months. And of course, we've been talking about boosters. We're still learning about the percentage of the population required for herd immunity, and it appears the vaccines offer protection against variants. Next. Other COVID treatments on the horizon. I know we have another speaker that's going to talk about the latest. However, we're currently using IV remdesivir on inpatients that has full FDA approval. There have been use of convalescent plasma, and of course your immunoglobulins. As recent as June 3rd, 2021, there are various combinations that are being used currently. And of course, I mentioned before, EUA had withdrawn hydroxychloroquine back in June 2020. Next. Final thoughts. In my nursing homes, I would suggest reverse airway rooms, preventive treatment with vitamin D, or certainly treating those patients with vitamin D deficiencies. And all staff should have negative tests, plus or minus COVID vaccine. Regarding home management of my patients, I require close monitoring by my clinical staff, including myself. I suggest my patients to utilize pulse oximetry, thermometers, and frequent monitoring. Generally, this condition, in my opinion, requires physician-level care or mid-level under direct physician supervision. We're in the infancy of this, and we have a lot to learn regarding this situation. All confounding factors should be appropriately evaluated, and the art of medicine is manifested when knowledge and experience intersect. And we just had a case out in the Southwest United States where we've had the court system to uphold one of the hospital institutions' mandate for its employees to receive the vaccine. So there's a lot of consternation and a lot of robust energy regarding this, and hopefully we'll learn more in the future. Thank you very much, and sorry for the initial technical difficulties. Thank you, Dr. Price.
Great. Thank you for your presentation, Dr. Bass. And we have one question regarding the use of ivermectin for the treatment of COVID-19. As many of you in pediatrics know, we depend on ivermectin for pinworm and other parasitic infections. Your experience with ivermectin?
Well, personally, I have no experience. I've been reviewing that. Yale has been doing some great research. They looked at a population of 116 patients between May 2020 and January 21st this year. And they saw some favorable outcomes in terms of quantifying viral load and culture, and saw significant improvements as short as day 6. And in terms of the viral load, there was a 13% of the samples were negative as opposed to 48% of placebo. And regarding cultural viability, at day 6, it appears it's there was a significant decrease those who were treated with ivermectin also. And that could be, let's see, however, that was not a peer-reviewed study. And I was looking for the Yale site, but I don't see it right now. I think it's Yale MDRX-IV.
Interesting. A question came in wondering how successful you've been with regard to getting your patients to accept the COVID-19 vaccine. Obviously, vaccine hesitancy has been a problem all along, but we certainly know that it's been effective with regard to the reduction of COVID-19 in the population and allowing us to get back to near normal. What techniques have you used to encourage your patients to get the COVID-19 vaccine?
Well, I like to present both sides of the story. I certainly tell them the benefits, which have been apparent in terms of the vaccine's efficacy. A lot of my patients are concerned about long-term unknown side effects. And so I have about 50% that are taking the vaccine and or greater, and maybe 40% that are kind of holding out. So I think the remaining percentage, many of them will eventually accept the vaccine.
Great. Any questions from the participants?
Great presentation, Bass, as always, sir.
Yes.
Yes,
Thank
this
you.
Dr. Guy, I apologize. Yeah, a couple of things. One, that we have found that as we learn as we go, and we learn that a couple of things, that the things that have been recommended previously, such as social distancing, very effective, mask wearing, very effective, cleaning contact surfaces, no substantive impact on disease. There's been no real issue with people contacting COVID from contact surfaces. So the CDC is not necessarily recommended at this point that you do, extensive cleanings, etc. So one of those things that have been taken down. The president did announce that they're investing $3.2 billion into an oral over-the-counter pill to treat active disease. That is going to be along the line of the remdesivir, I believe, as far as treatment is concerned. So that means that doctors will be out of the equation. The person will go to the local Stop and Cop and get a diagnosis, and then they'll be able to use in the over-the-counter treatment. But the thing that I reiterate is that healthcare really dropped the ball on this disease state, because originally when people were presenting with the signs and symptoms, they were just sending them home and say, go isolate for 14 days. I mean, if a person presents with bronchitis and they have a cough, you treat the cough. If they have a fever, you treat the fever. You would treat the symptoms at minimum. And that was one of the things that we were negligent in doing. And do not underestimate the power of vitamin D at a dose of 5,000 international units per day. I still recommend that everybody, no matter whether they are COVID or not, take a vitamin D5.
We lost you, Dr. Collier.
Those particular stuff, but it's been, research has shown that if we can get everybody's vitamin D level up to 40, normal range being 30 to 60, we can get everybody's vitamin D up to 40, then we could effectively have no available host for the coronavirus. And that's a simple and elegant solution that is not being advocated the way that it should. And so, I think that that's one of the things that I would tell you to share with all your patients, those 3 supplements that will help boost their immune system under any circumstances, but also it has been found to be very effective against coronavirus. Thank you.
Thank you very much for that. So let's see where the rubber meets the road. I know that during the GSMA meeting that Dr. Petty hosted several months ago, we asked the question. So let's just see where we are now in regard to this poll. Have you had your COVID-19 vaccine? Please respond. And we don't have vaccine cards, but we want an honest response so we can have dialogue. 10 more seconds. Great. All right, so here are our results. I think we were somewhere in the high 80% during that particular meeting. I'm glad to see 92%, which certainly puts us over the threshold for herd immunity. But without putting anyone on the block, if we're trying to get our patients to accept the vaccine, obviously trusted practitioners are what patients look for in making their health decisions. And so I'm wondering if there are still issues among health professionals with regard to the vaccine. What are some of those barriers that we can discuss and unpack in helping to get compliance with our patients? Because I can tell you, one of our staff just lost 2 family members this week to COVID-19, and one of our 12-year-olds in our practice just was positive for COVID-19 last week. So we know the virus is still around. We know it still has the potential to kill. We know that we've begun opening up the US and people are traveling for the holidays. And the Delta variant is more infectious, more virulent, more likely to lead to hospitalization. And there's going to be a lot of commingling over the next several months. So as that is a backdrop, feel free to share your successes in getting people to go from hesitancy to compliance, and also be frank about why there may be still some hesitancy amongst the practitioners. As you're thinking and getting your confidence to interact. One of the things we do know is that the data for children under the age of 12 is being analyzed as we speak, and the intent and hope of the NIH and FDA is to have some determination as early as October, and certainly before the end of the year with regard to children 2 years and above. There have been some concerns about whether there was an increase in the number of cases of cardiomyopathy related to vaccine in children. And after looking and doing a deep dive on the data, the incidence of cardiomyopathy in children between 12 and 18 years of age in the general population was not significantly increased. And as you know, there are probably 25 or 30 viruses that can lead to cardiomyopathy. And so the concurrent incidence of individual receiving the COVID vaccine and then coming down with a cardiomyopathy was not seen to be at an increased level.
Dr. Price, regarding vaccine hesitancy again.
Sure.
A lot of discussions I've had with my patients. Many prefer to roll the dice and take preventive measures, as the data clearly suggests that there's a strong correlation with vitamin D deficiency, as stated earlier, and lowered immune state. People are leaning toward taking vitamin D as well as other immune enhanced herbs and vitamins. There's concern regarding long-term manipulation of our DNA in terms of what we will see in the near future. Hopefully we won't see any significant cases. And again, as I alluded to before, we have cases which have not been recognized, at least publicly, where we have thromboembolic phenomenon in my own personal practice, where I've had one patient that died after a second vaccine 2 weeks ago, cause unknown, no autopsy was done. I have another patient that did, in fact, within a week of his second dose, have fatal pulmonary embolism. So I think those type of things are concerns that people have.
Right. And of course, you know, the same issue comes to light with regard to influenza vaccine and patients feeling that they got influenza from the vaccine. And we know that whenever you have a large number of individuals receiving a vaccine, there are going to be instances where the time sequence of developing phenomena naturally coincides with the timing of the vaccine. And I think we do a disinterest to our patients if we continue to propagate the falsisms that we know are clearly not true with regard to vaccines. And certainly we want to look at the data and we want to be cognizant, but we know that COVID-19 disproportionately impacted our population. The people who want to kind of throw things by the wind and say they're waiting. They were waiting when only 1 million people were vaccinated. They were waiting when only 2 million. They were waiting when there were 100 million. And I think that there comes a time as they see family members continuing to suffer, to die, and have long-term effects, that they need to make a decision about protecting not only themselves, but their family and their community. Other comments?
Dr. Price.
Yes, Dr. Wilkes.
I'd just like to ask Dr. Bass, what other comorbidities that those patients have?
The gentleman 2 weeks ago, 76 years old, was an oxygen-dependent COPD, as well as obese, hypertension, dyslipidemia.
And we don't know if he was already COVID positive.
Correct.
Dr. Bass, can I ask a question?
Yes, sir.
I hope you didn't answer while I was away, but I wondered what you thought of the significance of the fact that your 3 early fatalities were all male, because now the scientific community is suggesting that being a male sets you at a immunodeficiency state compared to women. And they think that it has to do with the ACE2 receptor, which is on the X chromosome, and it's less prevalent in men. You know, the fact that we have a Y chromosome that's not as robust as the X chromosome.
Yes, Dr. Griffith, that's an interesting point. I'm just not intelligent enough at this point to even address that, but that's certainly something that I will look into.
Dr. Price, is it possible to give a question to Dr. Bass?
Absolutely. Absolutely.
Even though I didn't get a chance to get it early in.
Go ahead.
Okay. In the adult world, Dr. Anthony Fauci has talked about something called PASC, post-acute SARS-CoV-2, and there's a set of findings. I wonder if Dr. Bass, in his experience or his research or his library review, has found the same thing in children. And if so, how do they manifest? It's what some places are called long bawler syndrome, but Dr. Fauci has labeled it PASC. Thank you.
That's an excellent question. Dr. Bass, if you're able to speak, you can take that question. Otherwise, we will ask one of our other participants in that space to respond. I know that there are a few centers around Georgia who are beginning to expand their long hauler follow-up clinics. This obviously is going to be an ongoing initiative because of the impact of COVID-19, particularly on high-risk individuals in the people of color. And so that's something that we want to address. And for many of you on the call, have you personally had patients who've had that ongoing foggy complaint or not being themselves yet, even though they've overcome the acute symptoms that have come to you and presented in the office? And what are your options in terms of management? Have you been handling it yourself? Have you been referring them to regional centers? Anyone can share their experience with regard to that.
Well, I'll talk a little bit about my experiences with my children. Of course, I had a presentation that I did earlier on about the MISC, the multisystem inflammatory syndrome in children. And so I presented a few cases back when we did a symposium earlier. I had one child who had a stroke. It's a 7-year-old who had a stroke because of COVID. And I will say that he has he had left-sided paralysis initially, and he has been able to he is able to walk. He has pretty good lower extremity movement and strength now. His left upper extremity, he still definitely has contractures and is continuing to have ongoing treatment for that. He wasn't able to eat before. He couldn't tolerate solids, and so all those things have resolved. And so it's been, I believe my cases were in January, yeah. And so that's my recent experience with him. I had another child, a 6-year-old, who had COVID, and she wound up having intestinal inflammation, and she had has had residual adrenal insufficiency associated with her experiences with COVID. And so she's continuing to receive treatment with that. Her labs have improved. However, she is still continuing to have those issues. And then I have a couple teenagers who had COVID. One of my teenagers, he actually got diagnosed with COVID, then had a test showing that he no longer had COVID, and then about 3 months later had COVID again, and then has had cardiomyopathy because of it, and so he's on 2 different medicines for the cardiac symptoms or the cardiac problems associated with COVID. His symptoms have improved. His cardiac function has improved. His ejection fraction and all have gotten better, but they're not back to normal. So he's slowly kind of getting back into some. He played basketball for high school and all. Slowly getting back into sports, but still definitely pretty winded.
And is our other presenter here for the next session? And I'm going to turn the program over to our distinguished Dr. Paul Douglas, who's going to introduce our next presenter. And we'll come back to you during our break time, Dr. Bass, but thank you for sharing some of your valuable experience with your COVID patients. Dr. Douglas.
Thank you, Dr. Price. I'm going to introduce our next speaker, who is Dr. Robert Chilton, who is clinical professor of medicine. Dr. Chilton is the associate professor of medicine, director of the cardiac catheterization laboratory at the Audie Murphy VA, University of Texas Health, San Antonio. He is a member of the American College of Cardiology, the American College of Physicians, the American College of Osteopathic Internists, and the American Heart Association. Dr. Chilton also chairs the electrophysiology board examination for the American Osteopathic Association and presides over the San Antonio chapters of both the Cardiovascular Society and American Heart Association. Dr. Chilton is going to talk to us about new therapies that we're going to be introducing as it relates to heart failure. The title of his talk is Take Heart, IMPA Reg Trial Outcome. Thank you for joining us, Dr. Chilton.
You're on mute, Dr. Chilton.
Take off mute. I am on there, and let me bring my slides up, which are here. Can you see the slides okay?
Not as yet.
All right, let me see. Do I need to share the slides or anything? No.
You can share them if you would like us to do that for you. We
share
can.
Screen.
Yeah. There you go.
How about that?
That looks great.
How about okay?
Wonderful.
Fantastic, guys. This is just great. You can hear me okay?
We can hear you perfectly.
Are you ready, Winston?
We are ready.
Okay, well, here we go, folks. I'm Bob Chilton from the University of Texas. I know you've already introduced me, and to many of my colleagues, I know many of the folks in the audience probably, and I think you're going to enjoy this talk. Even though it's a drug company talk, it has lots of good information in it, and I think it's one that's very practical, and I will be right at exactly about 22 minutes, so I'll keep you on time. This slide deck is produced with Lilly and BI, and it is actually on label, so I think everything will fit pretty well with what we want to talk about. The indications for actually empagliflozin, which is Jardiance, is to reduce the risk of cardiovascular death and diabetes and establish cardiovascular disease. And it helps in type 2 diabetes. What's interesting is, as we go through this talk, I'll kind of make some commentaries. This drug was brought into the world as a diabetes drug. I was actually present over 15 years ago when we looked at this, and I was the only cardiologist present at the meeting. There was nobody else there except endocrine people. And it is now shifted. The companies had to shift because this became now one of the most powerful drugs we have for heart disease. So let me take you through the most interesting parts of this incredible transition over the last decade. It is not indicated for type 1, although there is research going on, but don't use it for that yet. Give us a little bit more time to sort these out, and then watch for the safety concerns. And I think probably the one that we watch for certainly is urinary tract infections is one we need to watch for. Be aware of the genital infections and Fourier's gangrene, which is extremely rare. And just recently, actually, the kidney, how far can you go with the GFR, is starting to now approach what we saw in the EMPA-REG trial. Right now in the United States, it sets around 45, but in other countries, we use 30. So stay tuned. We may drop to that in the US, but that again, that's FDA mandates. This simply shows you the number of actual opportunities to intervene in cardiology with people that have diabetes. There's a whole lot more cardiologists than there are endocrinologists, but you have to protect the endocrinologist because that is one of the small groups at the university that rarely, it's very hard to get endocrinologists to train. Cardiology have lots of toys, make a lot of money, and so consequently, it's hard to go to the people who do the research. To me, the endocrine person is the research arm of cardiology. It's cardiometabolic. It's not just heart, and it's just not endocrine. So diabetes now has become one of the most important areas to discuss in medicine, and now has exceeded probably or close to actually high blood pressure. It's really common. The referral to the cardiologist is more difficult. Even for me, it's hard. I have to call the cardiologist person I want to send the patient to, and then even he has trouble getting in his own clinic. So it takes a lot longer to get in. At the same time, though, we don't have many endocrine folks, so be careful how you use them too. I think this field of diabetes has fell into the primary care arena probably 8-9 years ago. They see more diabetes than anybody. Now, I would say that we see more specific things in endocrine if you were an endocrinologist related to diabetes. Cardiologists don't like to have to take care of diabetes in some respects because we don't have nurse educators in diabetes. But it's coming, and actually it may be in time. These two fields will merge because it's cardiometabolic. It's not just one thing. It's all connected. We're all connected here. This is the actual number of people who die per day. That's not a big deal to any of you. We all know this. We don't like it, but there's nothing we can do other than treat the primary indications. This shows you the actual life lost, or if you say you want to see your grandkids, don't get diabetes. You can take off about 13 years. Now, this can be adjusted depending on in this study, and it's referenced down at the bottom. You can see it down here. I'm not sure if the pointer works, but look down here at Murphy's paper. In this JAMA paper, what they're doing is they're taking and looking back at emerging risk factors in this huge collaboration of nearly 1 million people. If you get diabetes and you had a history of having a heart attack, you will not live a full life. From our data, it shows a shortening. Now, that varies between patients. So don't go tell a patient he's going to die 13 years early in a sense, but just let him know you're going to not be seeing your grandkids if you get diabetes, and you don't really want to get that because it's something that we have great difficulty with. The evolution, actually, how it came across in the established cardiovascular disease patients in diabetes is most interesting. This is 2 trials you guys all know. All of you know these trials well, but this is important to give you a sense of how important is SGLT2s to the marketplace. When EMPA-REG first came out with empagliflozin, we looked at these numbers trying to make it practical to the doc who is using these compounds. This is the 4S trial with simvastatin, a statin drug. For 5 years, you got to treat 31 people to save 1 life. Over on the ramipril, you got to treat 40 some. Now, where is the SGLT2 if you compare? First of all, our study is only 3 years or so. These are 5-year studies. In the very similar, between 30 and 50 is where it's going to fall, and they'll do it in 3 years, decrease cardiovascular death. So you have to know the SGLT2. It is jumped out of diabetes into cardiology without diabetes now. If you're worried about somebody getting hypoglycemic, you don't have to worry with these drugs as much unless you're taking insulin or SUs. If you're taking insulin and SUs, you probably need somebody that knows this drug really well because they're a little trickier. I'd say a primary care person would know the drug pretty good because they've been using both. Certainly the endocrine person and maybe 5% of cardiologists, that's about all. I say to the cardiology guy, get an endocrine person or primary care to adjust it or recommend it through them and let them take care of the SU and the insulin. But other than that, if it's a first-time starter, you don't have to sweat it. It will be fine. If it's somebody already on metformin, no problem. Go ahead and start the drug. But this gives you an idea of these 2 huge trials all of you know. This simply shows you that if you have diabetes, I don't care what you do, you're still going to have a higher risk. Even if I treat you the very best I can, I still have a higher risk. Now, who has the most diabetes in the US? I suspect it's going to fall in Georgia, Louisiana, and Texas. Maybe other areas, but those are the ones where I think I see most of my disease patterns in tremendous amount of diabetes. Who has diabetes? The guys that got high blood pressure. 80% of diabetes people in this trial had high blood pressure. So if you find high blood pressure, you better look real carefully because you're probably going to find diabetes right there or close to it. If you look at their lipid level, look at their triglycerides. If their non-fasting triglycerides are really high, you know they can't even metabolize free fatty acids. So you know they're insulin resistant. So watch the HDL, which should be low, the triglycerides would be high. Those are very high risk people. That means that their LDL particles are small and dense, and they increase their heart attack rate 3 times higher. So we're talking about SGLT2s, but you can see how important to understand the actual physiology behind the disease is important to your care. This simply shows you all the trials. Now, let me show you just a couple of interesting ones. One is we got rid of the concerns for actual amputations with the drug. We didn't find it in any of the other trials, and even canagliflozin finally did a study and it didn't have it in theirs. So I think you don't have to worry now about that. The thing that dapagliflozin brought to us was that it brought us the non-diabetes patient showed a benefit. In EMPA-REG, and now with the actual EMPA reduced trial, we now find in non-diabetes, these drugs work. This class really does help decrease events. So I like these compounds. I think these 2 companies should be lauded. These are really important studies. They have spent billions on these. So understand they didn't come cheap. These are really expensive, but it was a diabetes drug. Now it's a cardiology drug. So moving on, here is the actual 3-point MACE in cardiovascular deaths, and it shows you the comparison of each of the groups. You can see the SGLT2, the GLP-1s, but look at the SGLT2s on both sides. It really does decrease cardiovascular death and has tremendous benefit. Over here is consensus studies. A bunch of guys get together and they write a paper. It's great. It's not a guideline. It's just a consensus. And they're simply saying, move the SGLT2s up higher in your thinking process. Certainly metformin has taken tremendous heat. Some of my friends, even my friend Ralph, he got me started on metformin, and I still like metformin, and he doesn't like it now. So I don't know. It depends on who you talk to. But if you have patients doing good on metformin, I like metformin. I think it's got some benefits. But the SGLT2s now are just amazingly good, and they have come up and really changed the actual game. This is the actual consensus pathway from that paper. You can certainly look at it on your own. Bottom line of the whole consensus is if you got diabetes type 2 and you got risk factors, SGLT2 probably should be in your armamentarium to protect you from cardiovascular death. And that's the thing we're targeting. This shows you a diagram of how it works. All of you know that. You pee out sugar when you take this drug. How much sugar? make it practical for the patient. That means you got rid of 2 cans of Coke. That means you got rid of 12 tablespoons of salt. That means that you, in the first day, pee out 800 cc's of extra urine, but then it levels off to 150 a day. After about a month or two, we'll even increase your blood count a little bit, and that will help deliver oxygen better to your tissues. So I think that this slide, although very diagrammatic and not quite put together properly, I think it does make the point that this is a drug that works in a very safe place. It does not appear to damage the kidney. As a matter of fact, it may be just the reverse. We may be going back to using it more. This simply shows you on the slide of the observed effects of where it works. I have already mentioned the glucose in the urine. I've already talked to you about the reduction in volume. Now, what does that do to the patient with diastolic dysfunction? That's your patient that has high blood pressure with left ventricular hypertrophy that has diabetes. He will feel much better. He will be able to breathe better because you took the volume load off his stiff ventricle. It's not that he doesn't have power in his ventricle. It's that it's too stiff. It's gristly. It doesn't stretch well. This will help improve their functionality. Plus, free of charge, you'll lose weight. And these people will lose weight. The first week, they'll lose a lot of weight, mainly from water. But after that, if you lose 2 cans of Coke a day in calories, most people that are obese are going to notice that weight loss, and they're going to like that. So again, it has a lot of pluses more than just decreasing cardiovascular death. Over here is the safety information kind of closing out on the talk. Watch out for the low blood pressure. That is if you're already taking a diuretic and you're already volume low. But that's not anything to a primary care doc. He knows this very well. The ketoacidosis, again, there's an advantage to the SGLT2s. They increase the ketones a little bit. Now, why would that be an advantage? The advantage is that is one of the major 3 fuels and is the most potent of all the fuels to generate ATPs from the mitochondria. So this drug has ability to increase your output in at least the research models for ATPs. At the same time, though, you need to be aware it is possible with the increase in ketones that you could get ketoacidosis, but that's usually in people that take insulin or SUs. Watch out for those. That's why I say not to the cardiologist to use this if you haven't familiar with it. You need to be a little careful with this. I also do not give this to people who are on radical diets. If you're taking a ketogenic diet, don't be adding this to the patient. You're just asking for trouble. So be careful with that. The kidney injury and renal impairment has not really been a problem, but it does cause vascular contraction. But with that, at the same time, the tubular glomerular feedback loop is going to correct some of that, and it actually has an effect on the renin-angiotensin system in a positive fashion. So you're actually giving more than just a glucose-lowering drug. You're affecting many systems, including the actual brain-natriuretic peptides in some of our research trials. But again, research is one thing, practice of clinical medicine needs to stay with the guidelines and FDA indications. I always say with that because I like the FDA. I think they do a wonderful job and the guidelines are great, but consensus documents, that's a whole nother issue. That just means your friends got together and wrote a paper. So I'm careful with that one. Here's the warnings again to watch out for. Lowering, do you have to worry about if you get hypoglycemic? Notice in the bold black print, it is only in the combination here. This is what they tell you about. If you don't have those, then you don't have to worry about that. So from all my patients, I don't worry about it because I send it to the primary care doc or the endocrinologist. This Fourier's gangrene is extremely rare, most common seen in people that have actual fungal infections in the groin or mycotic infections. It does increase the risk, but again, this is not real much of a problem. The LDL cholesterol does have a reduced turnover rate of getting rid of LDL. That was a very nice paper recently published in the last few years, and it is not one to worry because most of you guys are on statins anyway, so it takes care of it. This simply shows you the design of the trial, and it shows you the absolute risk reduction. Clearly, it decreases cardiovascular death. You only have to treat 46 people to get the event. This was the IMPA-REG trial of 7,000 folks. You know this trial. I'm not going to spend any more time on it because it's so well published. This is the actual breakout, the side effects. And again, you can appreciate the fact that there are not much differences between any of these. Now, why is there a 10 and why is there a 25? I use 10 because I couldn't find in the paper I couldn't really see the 25 because it's right underneath the 10. So why should I use a higher dose if I don't need it? Now, primary care, endocrine, that's a different game. They play with a different type of patient, and they have a lot more complex patients. So for them, they may need the 25. But for me, I just stay with the 10 because it got all the effects for the heart I needed. This simply says the common things you need to watch out for. Don't give it to pregnant women. Don't give it to lactating women, and be careful with the people who are over 75. Other than that, there is not too much drug interactions except for watch for the diuretic. If it's a person taking that for his high blood pressure, I usually cut the dose in half. A guy that works hardcore labor, sweats a lot, I'd be careful with that guy if he's taking a diuretic and this. So I'd cut back the diuretic and then just give him the 10 milligrams. And again, I mentioned the other one. How do you start it? It's simple. To me, there's only one dose. Makes it easy for the cardiologist. Just give him 10. Do you not? And again, don't use it in hypersensitivity, folks. Don't use it if the GFR is below 45, renal impairment or end-stage renal disease or dialysis. It doesn't work. I mean, now, if you decrease your GFR, does that mean you lost potency or decreased cardiovascular events? You know, it doesn't. You look at the trial, and even if you have a high GFR to a low GFR, it's still statistically significant for the MACE endpoints all the way down. Now, for type 1, I don't know. Give us more time and we'll have answers for you. This is the actual monitoring. Watch for, again, the GFR below 45. You should stop it. And again, this is FDA guidance here. If ketoacidosis, stop it. It would help. And don't restrict insulin if you get ketoacidosis. As a matter of fact, it's the reverse thing. Get some help if you don't know how to treat it. And then certainly treat and counsel the people about mycotic infections. So kind of in closing, it's simple. It's easy to use. It has a great relative risk reduction and absolute risk reduction. It's proven to decrease events with people with type 2 diabetes that have heart disease. Remember, in the IMPA-REG, everybody had heart disease. You know, everybody had type 2 diabetes, but now we're finding that these compounds are going outside of diabetes and they're working very nicely. And the recommendations from consensus have been good. Let me stop here and I'll be glad to answer any questions if you have time.
Great, thank you very much.
That
Dr.
is
Douglas,
fantastic.
Dr. Douglas, you're moderating this segment. I just want to remind everyone that we are in our non-CME component of our presentations. We will resume CME-related activity with our 12 o'clock presentation.
Thank you, Dr. Price. That was a wonderful discussion, Dr. Chilton. Thank you for sharing that with us. Are there questions for Dr. Chilton?
Yes, I have a question.
Yes, please.
Yes, doctor. This is Dr. Bass, and sorry for the technical difficulties prior to your presentation and to the organization on my behalf. I'm diabetic, and I attempted all of the available SGLT2 inhibitors in conjunction with a small frequent dose of glipizide metformin. And I experienced severe bilateral flank pain, which I assume was kidney pain, which lasted for about 7 to 10 days. Have you had presentations similar to that? I think you mentioned that we have to be careful utilizing SUs and metformin earlier.
Yeah, you know, I have not, and that's interesting that you say that. If it's flank pain and it's up in your kidney area is one thing. I guess the other question I would ask is whether or not it is extending further down into your hip area. And what I would worry about there is peripheral vascular disease that might be in people that with diabetes, there's a higher incident. But I have not seen any concern with pain in your kidneys. If your urine cultures and everything were normal, then I don't really have an explanation for that. Would it be that you could have muscle shifts or some type of fluid shifts that would cause muscle spasm in that area? I've not seen that. I've not heard anybody tell me about it. So that's a good comment. I just don't know. That's a great one.
Dr. Douglas? Dr. Douglas?
Looks like we lost him.
Oh, okay. Any other questions?
They may be muted. I don't know. Some of them.
Hey, Dr. Chilton, I'll throw one out that definitely has been many hot topics among cardiologists, and it's more around understanding that risk of hypoglycemia for these patients that have type 2 diabetes, knowing that they're on other medications, specifically when it comes to adding on an SGLT2. Can you share your experience with that hypoglycemic incidences with your patients?
Yeah, it's a really good question you asked, because I have a lot of house staff, and house staff are always, when they get a new drug, scared of it. And the first thing they throw up is, oh, they're going to make them hypoglycemic. It doesn't make you hypoglycemic if you're not taking insulin or SUs. It's extremely rare. As a matter of fact, even the FDA didn't even have it. And the reason is because the way the drug works is that your second messengers will not allow you to drop your glucose below about 80. That's it. Now, if you're taking SUs, you can drive it through, or if you're taking insulin, you can drive it through. But the cellular protection afforded you by, I guess, God protects us from doing crazy things. And certainly in this instance, it would be very difficult for you to make somebody hypoglycemic with taking an SGLT2. Now, you could be lack of insulin or something that is a rare disorder. And I'm sure the endocrine folks can come up with a case report of somebody that got hypoglycemic taking this without SUs and without insulin. But as much as I use this drug, this is really moved this is a cardiology drug, guys. This is not an endocrine drug or diabetes drug. We use this for heart failure. We use this for a lot of things, and we are not having any trouble at all. So I think it's possible people may be overly scared about it, because when it first came out, we worried about the ketoacidosis and the glucose, but then we found out, be careful with insulin and SUs. That came from the primary care guys. They taught us that, and the endocrine guys researched it. Dr. DeFranza, who's down the hall from me, I mean, Ralph would be the first to tell you, this is a fabulous, these compounds, SGLTs are fabulous drugs. They really work, and we just don't worry about the hypoglycemia with those exceptions I mentioned. It's a great question.
Are there other questions related to the cardiac presentation? Any other questions related to COVID-19, early access to treatment for sickle cell disease? Great. Well, we want to thank you for your presentation, Dr. Chilton, and bringing this information to our meeting. And we will go ahead and ask you to stop sharing your screen, and we will move on with our other.
Dr. Price, could I'm back. I'm sorry I lost connections. I want to extend my thanks to Dr. Chilton again for an excellent presentation. Thank you very much for joining us.
Thank you. Thank you very much.
Great. Thank you so much. And we just have a few housekeeping things that we will ask Kimberly to bring to the group.
Thank you so much, Dr. Price. So I just placed in the chat information to clarify what I shared last night. Before we end the meetings, so at the end of the meeting today, we will flash again the QR code and or the link to the CME, Morehouse School of Medicine CME department, where you can claim your CME credit for the meeting. So, but however, you first have to create an account. So the instructions that I placed there in the chat walk you through creating an account. So everyone will need to create an account. Again, to claim credit for yesterday, you will use code 11901. I'll share these again tomorrow. I'm sorry, this afternoon. The code for today is 11902. So those are the codes you need to claim credit. And reminder, the 2 cardiology presentations were non-CME, not a part of the CME program. So any questions before we take a break? CME your evaluations must be completed by Monday. This isn't a process we can drag out for the next week or year. Reminder, if you don't get this done by Monday, there is no follow-up process. It has to be done because once you complete the evaluation, you have access to your certificate immediately. Okay, thanks so much.
Very good. So we have one more non-CME presentation. You want to go into that now? And then we have a lunch presentation.
Yes, we can go ahead with our sponsored presentations if you want to do those.
Good morning, everyone. I'm David Harris with Sterling Seacrest Pritchard. Before I get started, I need to thank Dr. Williams for inviting me to introduce myself and our organization this morning and for dedicating the time over the last few months to educate me on the Georgia State Medical Association as we work together to hammer out the details of our partnership. I'm extremely excited to be working with y'all and really look forward to meeting all of you one-on-one before too long. Before I turn it over to our chairman and founder, Mr. John Miller here, I want to express my sincere appreciation to Dr. Cleveland for facilitating this relationship between the GSMA and Sterling Seacrest. He and John have a long-standing friendship that's been mutually beneficial. As we all know, this organizational alliance should be for many years to come. I'll state the obvious here. As a Black risk management professional, I have a particularly compelling personal commitment to seeing that the GSMA and all of its member organizations have all the backing you need to fully protect the practices you've built. You're serving and supporting a community, and we must serve and support you in kind. We need you to thrive because when you do, it's good for everybody. So for anything that you may need in the area of commercial insurance, from your employee benefits to your cyber liability, to your standard property and casualty, I'm your first point of contact at Sterling Seacrest Pritchard. I'll just share a little bit of my background with you so you know what you're getting here. I graduated from high school right here in Atlanta before getting my bachelor's degree from the University of Michigan. From there, I got my Juris Doctorates from Washington University School of Law in St. Louis. I came back to Atlanta to start my family and get to work. And I started off as an insurance defense attorney. I did that for about 3 years before I transitioned over into complex insurance services, where I have been since then. And in my 17 years in that realm, there really isn't a lot that I have not seen. So whatever may come your way, I'm pretty sure that I can be of some use to you, and where my expertise ends, someone else's here begins. That you can be sure. And I'll be honored to be there to help you for whatever you need. And with that, I'm going to go ahead and turn it over to our healthcare practice leader, founder and chairman, and all-around good guy, Mr. John Miller.
Well, thank you, David, and I appreciate the opportunity to be in front of y'all today. We are the largest privately held firm in Georgia, but I say that to tell you about scope. It doesn't necessarily speak to the fact that we're still humble, hungry, and smart is the way I like to think about it. So we really enjoy serving the 6,000 healthcare professionals that we serve here in Georgia and the surrounding states. We've got a team of over 300 people here, but 30 of those are dedicated to physicians and surgeons. And in that, we've got 3 attorneys on staff. So those three attorneys assist our physician practices because you deal with a morass of compliance issues, regulatory issues, those kinds of things. A lot of times practices don't know where to turn, or they turn to very expensive resources in counsel. Our attorneys assist David and I as team members regularly to help you interpret what particular issue is at hand. The other thing that is important for you guys to understand is that in our partnership, if you're a GSMA member, our consulting services are complimentary. And we view that if GSMA is our client, then all of its members are our client as well. So anytime you need anything, even if you just want a second opinion or just bounce something off of us, all of that comes without any charge to you. The last thing I want to share with you is that David and I are the team for your organization and any of your members in your organization. And that's a dedicated team of the two of us, along with the 30 people backing us up. So we're your advocate, both at claim time and in placement. And so the placement part's easy. That's the day we're happy. But the claim time is where the rubber meets the road. And I've insured many physicians here over the years that have said, guys, you guys really perform when the chips are down. And at the end of the day, that's what really matters, because if we can protect your practices, then we can make you successful to then in turn protect our community. We very much appreciate the opportunity to be with you and look forward to our continued dialogue.
Thanks, John. I am really looking forward to meeting as many of you one-on-one as possible over the next few months. As we ramp up our work together, be mindful, I cover the entire state. So wherever you may be, I have no problem traveling to you so we can work together in person. Now that we can, if you feel comfortable with that, I'm willing to do that. And I want you to just be aware that whatever the issue may be, however large or small, I want you to know that if you call Sterling Seacrest Pritchard, we will be here for you. And I look forward to meeting and working with y'all. And happy Juneteenth.
Thank you. And we know that everyone needs to eat, so we have a meal preparation, healthy eating demo for you, brought to you by JD's Kitchen.
Hi, I'm Chef Jasmine. Today, I will be showing you a meal combined with protein, nutrients, and fiber. We will start with a pound of shrimp and a teaspoon of each ingredient you see here: sea salt, paprika, onion powder, black pepper, and fresh garlic. For healthy results, use low sodium seasoning or no sodium. Make sure to toss the shrimp well and set aside. For your green beans, add a tablespoon of oil to a medium-high skillet. Allow the oil to heat and add your green beans. I always add chopped onions and peppers for more flavor and a pop of color. Season and toss your green beans. Add 1/2 cup of water. Bring to a boil and cover. Grab the shrimp that we set aside and add to a skillet with 1 tablespoon of oil, cooking both sides. For your brown rice, add water or no sodium veggie broth and rice to a saucepan. Bring rice to a boil, reduce heat, and cover until completely cooked. Here you have a healthy meal for the week. Thanks for watching.
And JD's Kitchen is local in Atlanta. The information is there. I will attest that this shrimp dish is tasting pretty good. At this time, we're going to take a potty break and a meal break, and we will resume our CMA portion of the program at noon on this Juneteenth day.
Hi, I'm
So
Chef
just any of
Jasmine.
you that didn't get a
Today,
chance to
I
eat,
will be
here's
showing
your
you a
last
meal
meal before
combined
we
with
start our
protein,
afternoon session.
nutrients, and fiber. We will start with a pound of shrimp and a teaspoon of each ingredient you see here: sea salt, paprika, onion powder, black pepper, and fresh garlic. For healthy results, use low sodium seasoning or no sodium. Make sure to toss the shrimp well and set aside. For your green beans, add a tablespoon of oil to a medium-high skillet. Allow the oil to heat and add your green beans. I always add chopped onions and peppers for more flavor and a pop of color. Season and toss your green beans, add 1/2 cup of water, bring to a boil, and cover. Grab the shrimp that we set aside and add to a skillet with 1 tablespoon of oil, cooking both sides. For your brown rice, add water or no sodium veggie broth and rice to a saucepan. Bring rice to a boil, reduce heat, and cover until completely cooked. Here you have a healthy meal for the week. Thanks for watching.
Again, your lunch was brought to you by JD's Kitchen, available in Atlanta. And we will now proceed. And I'm pleased at this time to bring on Dr. Yolanda White, who is presenting on behalf of the Georgia Clinicians for Climate Action. She is a staunch advocate for climate health. She's going to talk to us about the alignment between climate change and African American health. And we know we are already feeling the heat. Dr. White, take it away. Dr. White? We're not hearing you. You may be on mute.
Okay, great. Hello, everyone. Can you see my screen? Can you hear me? Okay, great. Thank you so much for inviting me to talk to you all today about the alignment between climate change and African American health, because we are already feeling the heat, especially here in the Southeast. And when we look at our changing climate, we're seeing that our temperature, the Earth's surface temperature, has increased between about 1 to 2 degrees Celsius since around the late 1800s. One of the main reasons is because our population has increased from about 1 billion from that period to now we're close to 7 billion. And as we inhale oxygen and exhale carbon dioxide is a greenhouse gas. It's one of the main greenhouse gases that contribute to climate change. As our population has increased, so has our use of planes, trains, and automobiles, because we've got to get around. The Industrial Revolution in the early to mid 1900s has also contributed to this whole climate crisis. Because they also release air pollutants as well as greenhouse gases. And of all the foods that we eat, beef tends to contribute more to climate change. While all the greenhouse gases have pretty much been increasing over time, we tend to follow CO2 levels the closest. And I showed this graph down at the below from NASA because just to highlight how last year, even after we reduced our operations for about a good 3 months as a result of COVID, our CO2 levels continue to rise. So this means that if we really want to get a good hold on this climate crisis, we're going to have to start taking aggressive actions very soon. In understanding the effect that greenhouse gases have on the planet, why it's causing all this, we can look at the effect of a greenhouse. Just as a glass greenhouse traps in heat and ultraviolet radiation to stimulate plant growth, well, greenhouse gases do the same thing. They form a layer over the Earth's atmosphere to increase heat, also increase radiation, but unfortunately, it also increases air pollution. And for this reason, we have a lot of planetary impacts to the land and the waters, and we're also having a lot of extreme weather events, which I won't go into in too much detail. I believe I've spoken to this group before about it. And this is resulting in a lot of health impacts. And also in our view of climate, for so long, many people didn't take climate change too seriously because we always thought about the polar bear floating on an iceberg. But really now the main impact of climate change that we're seeing on our health is the rapid increase in children with breathing difficulties, but mainly it seems to be Black children with breathing difficulties. And in our senior population, which is also a very vulnerable group, it tends to be older white people with COPD. So climate change has a number of health impacts, the main one being exacerbation of heart and lung disease. And this is mainly due to air pollution, which I'll go into in a little bit more detail, as well as heat-related illnesses, which I'll also go into more detail. Now with these unseasonable weather patterns, the trees don't know when to pollinate. Sometimes they pollinate early, sometimes they pollinate late, sometimes multiple trees pollinate at once, and that causes these pollen apocalypses and pollen tsunamis, or flood of allergies. Even with the natural disasters, we're seeing more physical injuries and also more accidents as a result of climate change. Many of us are going to be experts in tropical medicine at the end of this, because we're seeing also more vector-borne diseases from these hotter climates, especially malaria, dengue, Lyme disease, West Nile virus, especially in Florida of all states. And also we're seeing more diarrhea as a result of the poor water quality, mainly as a result of cholera and cryptosporidium. And even now we're seeing this new term of eco-anxiety with mental health effects, where many people become very anxious or depressed, not really knowing what to expect from the climate. I do want to congratulate the NMA for being the first physician organization that conducted a climate change survey amongst our member base. I was on the Commission Environmental Task Force at this time, but it seems that NMA physicians tended to be more responsive to and open to climate. The study surveyed just under 1,000 physicians, and it showed that 97% of respondents do believe that climate change is happening. 88% felt that they personally experienced it, and about 48% felt that the experience is either moderate or a great deal. Many physicians felt, about 88% feel that it was directly related to our patient care, and that it has harmed people in their own city. Also, it talks, the survey goes over some of the health impacts of climate change, and we also understand that our population tends to be more affected by it. There was another study done by the University of Wisconsin back in 2019, and I just showed the difference in results. This study included about 400 physicians and about 50 patients, and that's where I went to med school. But highlights of this study showed that about 44% of patients believe that climate change is affecting their community health. 6% of patients rank their physicians as the top source of information on climate change. 64% of physicians believe climate change is affecting their patients' health, and this is versus 86% of NMA physicians. And about 71% of physicians in Wisconsin believe that climate change is relevant to patient care, and 31% feel that, you know, we should have a more active role in discussing climate change with our patients, but only 17% feel comfortable doing so. When we look at the heat-related health impacts of climate change, the most common health impacts is distress, just being uncomfortable. There have been other studies that show how crime is increased in hotter temperatures. What makes heat cramps different from regular cramps is that heat cramps occur in in a hot environment. In pediatrics, now I alter the way I give my patient counseling, especially with newborns. I have to consciously and actively remind parents not to leave the baby inside of not to forget the baby inside of a hot car, because sometimes that does happen. Babies can overheat because their thermoregulatory mechanism is not so well developed. Also, many patients we're seeing patients with heat stroke and heat exhaustion. And this is especially in overweight patients who are physically active outdoors. Their temperatures can increase as high as 104 degrees. They usually don't sweat a lot, but this is taken very seriously because they usually end up in the ICU. and we have to closely monitor their brain, their heart, and their muscle and kidneys, which can they can have end organ failure with that. I've mentioned the vector-borne diseases, and also we're seeing more pregnancy complications, which I'll go into in more detail. And even the death rates can be related to looking at this one study, this one graph that was done comparing Atlanta to New York. It shows a direct correlation between ozone and elevated temperatures. As our temperature levels increase, so does our ozone levels. And just mind you, our current ozone level is regulated at 70 parts per billion. So anything greater than 70 is deemed unsafe, dirty air, dangerous air. And as you can see in this graph, during hot months, where the temperature can increase greater than 101, the ozone levels can exceed about 240 parts per million in New York. Fortunately, it's not as high in Atlanta, but I can explain a little later why about these heat islands and why New York temperatures and ozone levels can reach so high. But looking at our heat waves, since around the 1960s, we've seen that our heat waves are increasing, looking at several parameters, whether it's the frequency, heat wave duration, heat wave season, and also with the heat wave intensity. It's definitely getting hotter. The main problem with the air pollution, ambient air pollution and climate change is, well, the main way that we should look at it is that it should be taken as seriously and screened as often, and also counseled and billed the same way we look at tobacco exposure, because it causes very similar effects. The Clean Air Act only regulates about 6 air pollutants, but just giving a comparison to other countries such as Taiwan, South Korea, and Japan, they regulate dozens of air pollutants, and they also regulate indoor air pollutants. But I can tell you that, you know, here, if the EPA ever tries to add another air pollutant to be regulated, they get backlash. Rejected by Congress, they end up in the Supreme Court, the Court of Appeals. I mean, it's impossible, almost impossible so far, to increase our air pollutant regulations. It's so contentious that you can't even use the word regulation anymore. You have to use the word health protection. But the most concerning air pollutants is ozone, particulate matter, and nitrogen dioxides. And there's no need to separate these because they all exist together, and they all have a cumulative effect and also a synergistic effect where one pollutant can increase the toxicity of another. And so I've outlined down here the different mechanisms of injury. It can be pro-inflammatory, oxidative, mutagenic. These air pollutants, they tend to bypass our first lines of defense, being our nasal cilia, and it directly penetrates into our lungs and cardiovascular system, which is why the heart and lung impacts tend to be the most significant. And just like tobacco smoke, it destroys our ciliated airway cells and our alveolar cells. Decreases the mucociliary clearance and increases these pro-inflammatory chemicals. And in our patients, we're seeing a reduced lung function. We may just diagnose them with asthma, but we can see that this exposure to air pollution, it can cause asthma. It can also exacerbate asthma and COPD and other lung conditions as well. A long time ago, there was a debate about causation versus association. But now we have lots of studies and reports that show that, yes, it can cause and be associated with it. Also, air pollution can increase the risk of respiratory infections. That's usually about 4%, and mainly due to the pro-inflammatory response. And it can also increase the risk of all-cause cancer, especially lung cancer, as well as all-cause premature death. We find that African Americans tend to be more exposed to air pollution from all sources. This is our main disparity. Traffic, agriculture, and fossil fuel plants tend to be the most common. And we find that the difference that generally we have about 78% greater than average exposure. And the disparity between African Americans and whites is about 21%. And this is regardless of income. And I do want to highlight, I am a pediatrician, so I do want to highlight this one case of Ella, a 9-year-old girl in the UK who had about 30 hospitalization visits in 3 years, and turned out she lived near a major roadway. And by the way, here in Atlanta, we have an urban sprawl, the country's largest urban sprawl. But that traffic pollution is what exposed her to very high levels of nitrogen oxide and particulate matter that exceeded World Health Organization guidelines, and she died of an asthma attack, which led to cardiac arrest. What makes this case so important is that she had a very astute coroner who diagnosed her with her death with the cause of death as air pollution. This was the first time that this has ever been done worldwide. Normally, she would just be diagnosed with asthma. One thing that really struck out was that her mother said, had she just known about this risk of air pollution and asthma, that she would have just moved. But when you think how many of us live near the highway, how many of our patients live near highways and not really realize this or take this risk into account or take it as seriously as we should be taking it. Climate and heat also have impacts on pregnancy as well. Pregnant women, they tend to be less able to regulate their body temperature as efficiently. The high heat can alter blood flow in the placenta. It can increase and it also cause changes in the endothelium, weakening the placenta. They're also more vulnerable to heat stress. And as a result, pregnant women tend to have who are exposed to heat-related illness, high heats, tend to have babies more prone to prematurity, which is being born prior to 37 weeks gestation, low birth weight, which is weighing less than 5 pounds, 8 ounces, and also being born stillborn. As we know, we're still dealing with this maternal mortality in African American women, which tends to be about 3 to 4 times higher than in white women. So not only is it due to, the social determinants of health that we are very familiar with, lack of access to healthcare, poor quality of healthcare, and dismissing symptoms of Black women, we're finding that that women be more prone to these to heat related. So the solution is patient education, which starts with physician education. We really have to stress just the basic things, such as increasing the amount of rest that pregnant women get, increasing their water consumption and taking more cooling breaks, and also do a little bit more risk screening, such as asking about their work and heat exposure, and having more check-ins, check up on them, give more health reminders, just increasing the communications that we have with and I'm going to be putting a fact sheet inside the chat when I'm done with this. A fact sheet on increasing temperatures because of the climate change crisis is a reproductive issue in the U.S. And it's been going on for a while, which is why the groups that are involved now, they're seeking international human rights protection. So when looking at our social determinants of health, another reason why we as African Americans tend to be more disproportionately affected by heat, as well as climate change, air pollution, is because our urban areas are more prone to these heat islands. And that's because we have more buildings, more roads, and fewer natural landscapes like trees and waters. I'm from New York, and we call it concrete jungle, because these building roads, they tend to re-emit heat more. And sometimes the temperature difference can be about 1 to 7 degrees higher than in rural areas. And this ends up increasing our energy consumption, because the hotter it is, the more electricity you use. And we're finding that the electricity demand for air conditioning increases about 1 to 9%, 1 to 9% for each 2 degrees increase in temperature. And because we're using more electricity, air conditioning, we are burning more fossil fuels, coal, gas, oil, to meet these energy demands. So you can see how this is a vicious cycle, and it is compromising our health, I've mentioned before. And also, there's a study that showed that that the urban areas that are redlined neighborhoods also tend to be have higher temperatures than non-redlined urban neighborhoods. And the difference is an average of about 5 degrees Fahrenheit, and sometimes it can be as high as 13 degrees. But the solution is to really invest in green infrastructure, like have more green roofs, air conditioning, humidity control, because the humidity also affects the temperature, which is why 90 degrees in the southeast is different from 90 degrees in Arizona because of the difference in humidity, which factors into the heat index. And also, we should have more warning systems as well as cooling centers available to make a difference with our communities. And even looking at our melanin, pediatrics, our motto is children are not little people. And with African Americans, we're not just colored people, but we all have, regardless of your race and complexion, we all have the same number of melanocytes. But the difference in our complexions really relate to the number and concentration of our melanosomes, which contain the concentrate the melanin pigment. There's also a pheomelanin pigment, which is a reddish yellow hue. But when exposed to heat and UV or UV light, the melanin, the melanocyte cell, it goes from an oval shape and it transforms into it has these pseudopods, these dendrites that release the melanosome pigments into the keratinocytes. But even without UV light, heat alone can darken the pigment, especially if it's exposed to UV rays. And also, we have more that melanin gives us more thermal tolerance, so we're able to tolerate higher environmental temperatures, which can sometimes be unbearable with other groups. And now, while we can tan with the UVA exposure, it stimulates melanogenesis. We know that melanin is also very photoprotective. It's our first line of protection against UV rays and protecting us against skin cancer because it absorbs the UV radiation and dissipates it. So looking at our medical management of climate change, we are going to be treating our patients a little bit differently, and that we're going to be implementing more preventive health into our practice. So doing more environmental control counseling, even more disaster preparedness, more survival skills. When's the last time we asked our patients, do you know how to swim? How can they survive a flood? We saw what happened with Hurricane Katrina. And also more physician education and patient education, and including more handouts. When it comes to advocacy, the most important thing that we as physicians can do is to advocate for health and human services to codify our climate and environmental health diagnoses, codify the counseling, and also work with insurance companies to improve more biomonitoring labs. The CDC, they have a biomonitoring report that shows that we're all pretty much, every chemical they test for, it's pretty much in all our bodies. And so we can do more testing of the blood and urine because we do need this objective data. For so long, the biggest deterrent in our advancement of physicians adopting environmental health into their practice has been the big debate about, or the big argument about unfunded mandates. We don't need another unfunded mandate. We really have to work closely with Health and Human Services. But another thing that many of our organizations, including GSMA, the NMA, all these groups can do is just create more, well, the NMA does have a climate health resolution, but even our state associations and our other medical associations can also adopt climate health resolutions and policy statements and assist if anyone is interested with this. Also, many cities are adopting, going 100% renewable, making a commitment to 100% renewable, usually by about 2050. And we can work with our state legislators, state EPA offices, work on every jurisdiction to promote clean energy. And also, the EPA, the White House, Congress. One of the most important things that you guys can do, it's too much to track what laws, when a law is being introduced, when a bill is being introduced, and when to take action, and where that bill is, where it is in committee, did they make it out of committee, when are they voting on it? It's impossible for you to follow this on your own. So the best thing to do is to join one of the environmental advocacy groups, get on their email list, The Sierra Club is a big one. Here in the South, we have a Southern Alliance for Clean Energy. Many of these groups actually go out and help many of these EJ communities and really address a lot of the disease clusters that these EJ communities are seeing. Another thing we can do to help manage climate change is just change our lifestyle, reduce our meat consumption. That can have one of the biggest impacts. Transportation of meat increases the carbon footprint, and even the feeding the cattle increases it. Just so many factors around it can contribute to it. And also making sure that we buy produce locally and in season, and walking more. But overall, we're really going to have to reduce our dependency on fossil fuels, oil, gas, coal. You know, I think you guys know where coal comes from. It comes from a mountain, either mountain top removal, where they chop up the top of, put explosives on the top of mountains, and chop it off, or they put explosives inside of mountains to extract the coal. Here in the on the East Coast, they get it from the Appalachian Mountains, and they bring it onto trains, and that's taken to coal-fired power plants where they burn it, and that heat is used to generate energy. But we have to leave it in the ground, because those heavy metals that are in the ground, they are emitted into the air. And when it rains, it gets into our soil, and it gets into our waters, and it enters the fish. So we really have to reduce our dependency on fossil fuels to improve our overall health. And you know, even if these are unfunded mandates, we really have to do it for ourselves, because believe it or not, our patients and private citizens are all advocating for these environmental health protections. When I advocate, lobby, reach out, do rallies, press conferences, etc., we have everyone really advocating for these environmental protections, except health professionals. So that's the main thing that I really want us to become more involved in. And also now, so it means that we have to make a swift transition to wind, solar, and other renewables. Look into electric cars, buses, and school buses. Although they're not perfect, because sometimes, you know, they can short circuit. There are other issues going on with it, but also practice energy conservation. Just keep the lights off, unplug appliances, just practice energy conservation. And also work on campaigns. Right now, the fossil fuel industry is the most highly subsidized industry in the world. The same companies that invest in oil also invest in coal and natural gas. And this contributes to the economic injustice that poor communities have, because when our poor EJ communities, it's difficult, in fact, it's almost impossible for them to fight against these wealthy companies. So they just end up suffering, and oftentimes they end up being too tired to fight for themselves. So they really rely on many of these environmental groups to help advocate on their behalf. But what many universities and large companies have been doing is divesting from these fossil fuel companies. And now there are some bills that have been introduced to help reduce incentives given to fossil fuel companies. But you know, because so many politicians receive campaign contributions, these bills usually don't get passed. But another thing that we can do as physicians is to make sure that we are billing our patients, that we're coding our patients properly. So right now we are in smog season. Smog season lasts between May to September of each year, and here in the Southeast, it can the temperature of smog season can last even longer. But if your patient has asthma has asthma exacerbation during smog season, you can use this first code, Z77.1. If your patient lives near a point source of pollution, such as a coal-fired power plant or even a natural gas facility, or has any other concerns, you can also use that code. Many of our patients might have come in with allergic rhinitis symptoms. You do allergy testing. Everything is normal. Sometimes it might be due to air pollution. Also, you know, with babies that get overheated, you know, there's some codes for them: heat exhaustion, heat stroke, and also, you know, some of the heat problems due to our housing. One thing that there's a big push right now for PFTs to eliminate the race-based correction or the ethnic adjustment. As we know, when PFTs are done, they use the input race, height, and age to come up with a calculation. But when they input race, we get this ethnic adjustment that assumes a 10 to 15% smaller lung capacity for African Americans and a 4 to 6% smaller lung capacity for Asian Americans. It's about the same. There's no difference with Hispanic Americans. But this lower lung capacity measures, it's inaccurately considered normal. So therefore, but there's a lower threshold that is used in many of our reduced lung function tends to be overlooked. And so the immediate solution is to just use the white standard for all patients until this race factor is eliminated. And the same concerns are true for also hold for GFRs. You don't need that race. You don't need to adjust it for African Americans because it gives a very similar ethnic. So last month, President Biden just released the budget of the U.S. And so for the first time, we're really gonna be prioritized when it comes to cleaning up the climate, cleaning up this air pollution, because in this budget, Biden made a commitment to investing about 40% of the benefits of climate and clean infrastructure to go towards disadvantaged communities. Disadvantage is what we're called now. And this money is going to be invested into energy saving retrofits to our homes and schools. Many of us live in older homes and even the HUD homes or projects. Also, much of the money is going to be used towards climate resilience and disaster planning, also air quality monitoring and notification programs for EJ communities, as well as pollution cleanup programs, and also securing environmental justice, because it's even difficult for the EPA and for anyone, even your state environmental protection division to go against the fossil fuel companies, but having the funds can help with that. There is a HBCU climate change consortium that I want many of you all to know about as well. Dr. Robert Bullard is known as the father of environmental justice. He, along with the Deep South Center for Environmental Justice, came up with this climate change consortium to raise awareness of this climate EJ crisis in our HBCUs and to train our HBCUs students to be leaders, and also train our scientists and advocates. Because we are the ones who are going to be most likely to be advocating for ourselves. However, I can tell you that there are many other groups of other ethnicities who go hard for us as well. And also there's an HBCU Green Fund I wanted you all to be notified about as well. It's a nonprofit that works to green HBCUs, and this is mainly through loan programs. They help to finance energy efficient buildings like LEED certified buildings, and also infrastructures. We really need those green rooftops. And they help to support a sustainability curriculum and promote student engagement. Many schools now are having green clubs. We didn't have when I was in school, but now they're becoming more popular. And some other resources, and I'm going to be putting these resources into the chat as soon as I'm done with this, but there's a really great resource on climate change, indoor air quality and health. This is offered from the University of Connecticut, and it's on the EPA's website. The EPA, they also have offering a CME credit on particle pollution and your patient's health. Remember, of all the air pollutants, I have to say that ozone and particulate matter, also known as particle pollution, tend to be the most damaging to our health, our heart and lungs especially. And also, I'm with GCCA, Georgia Clinicians for Climate Action. We're a part of the Medical Society Consortium, and we have patient education posters that you can post inside of your clinic, and lots of other information that you can learn more about. And for you all, especially here in Georgia, there's no Tennessee chapter, but GCCA, please feel free to join us. We have our website there. You can even just Google GCCA and just join us, and we can send you updates on newsletters and other information, other news on what we're working on. But we are a new group, and so we are still developing, but we are doing as much as we can to increase physician engagement with climate change. And so happy Juneteenth, everyone. I just want to let you all know about Sarah Rector. She's a part of our Black history. She's a multi-millionaire at just about 12 years old. Her Her family was enslaved by Native Americans in Oklahoma. And after emancipation, under this Dawes Allotment Act of 1887, her family became entitled to land allotments. Each child was granted about 160 acres of land. Her family had leased the land to an oil driller who produced a gusher that brought in $300 a day. And by the time she turned 18, she was a multimillionaire. She was so wealthy, she was labeled white and changed their race. But thank you all. Thank you all so much for your time. I'm here if anyone has any questions related to climate, heat, African Americans, EJ.
Yes, Dr. White?
Yes, sir.
Yeah, this is Dr. Bass. Excellent presentation. Regarding stratosphere bioengineering, sun dimming technology, it appears that there's a huge interest by various wealthy entities to affect the sun. And, there have been talks about chemtrails, et cetera, utilizing carbon, carbonate, or aluminum to dim the sun. Could you elaborate on that? Would that affect vitamin D? It seems that 2/3 of my population have vitamin D deficiency these days.
Yeah, those are really great questions, Dr. Bass. I would have addressed it in my presentation, but I just couldn't find the peer-reviewed journals to support it, so therefore I left it out. But I also have my own concerns. In fact, when it comes to geoengineering, as I mentioned, our melanin is a protective factor, but unfortunately, there are some ethnicities that have less melanin who are more prone to the damaging effects of climate change. All the rhetoric that we're hearing is that African Americans are more disproportionately affected. African Americans are more impacted. That goes into the issue of nature versus nurture. Is it really biological? Is it really genetic? Or is it, environmental? Is it due to, not environmental in terms of pollution, but is it due to these other influences? But when it comes to climate change overall, we do have a biological advantage because of our melanin. And other groups that don't will try to, alter the natural landscape, which is very unfair. But yeah, there's a FAA whistleblower who came out about the chemtrails and concerns about the chemtrails. And even I have had concerns about, many of our infectious outbreaks being related to chemtrails. I've seen chemtrails in the sky that look like Star of David. I've seen some chemtrails in the sky that look like tic-tac-toe grids. I mean, it's like comedy these days. But looking into vitamin D, I think that's the most important lab that every African American should get, especially if you're dark skinned, because of that melanin. It's really great in protecting us. But we need that that vitamin D is that pre-vitamin D is made with the UVB rays. And there are fewer UVB rays that reach the Earth's surface. And generally, we have to get 1 minimal erythema dose each day to get enough vitamin D. And that 1 minimal erythema dose means you have to get a little bit warm and a little bit red, generally for 15 minutes. For some people, like fair complexions, they can be out in the sunlight like that for about, 5-10 minutes. But for others, depending on the season, you can be in the sun for 2 hours. But also, oil is a driver for that vitamin D synthesis. So when you do go out and sunbathe, just make sure that you put oil all over your body, and that can help with that vitamin D. But yeah, it's important for our kidney health. As we know, many African Americans are more prone to chronic kidney disease. Where unfortunately many end up dying of complications of chronic kidney disease that we didn't even know that we had, including some politicians. In fact, one thing that really got me involved in environmental health is that I realized that not only were children in pediatrics suffering more from environmental related conditions, asthma, autism, ADHD, neurodevelopmental problems, but their parents and grandparents were coming in on oxygen tanks and, were on dialysis, as well. And then I would see my colleagues, nurses and doctors, other health professionals who, they knew that I was environmental. So they would share with me their own concerns about environmental exposures, even in the hospital that we all work at. Then when I would lobby, I would see that several politicians were cancer survivors or, had chronic kidney disease or so. So this is really a we problem. And I don't think that we should wait for a funded, we should definitely advocate for funded mandates because we're doing so much as physicians. But there's, but even without that, we should be advocating on behalf of ourselves, on behalf of our own health. I hope that answers that.
Yes, thank you.
You're welcome. Anyone else? Any questions?
Very good, Dr. White. This is Linda Walden, also with the Georgia Clinicians. And I wanted to just ask you regarding the heat islands, what is your recommendation to prevent those or to get rid of them?
Yeah, now that, Biden's budget is calling for, investments into our infrastructure, we can really take advantage of that and really work with some of the green engineers on the green rooftops, also planting more trees. Here in Atlanta, we have groups called Trees Atlanta. They plant trees around schools and many of our urban areas. Yeah, we definitely need to improve trees. Trees, they capture carbon. We have a symbiotic relationship with trees. They give us oxygen, we give them carbon dioxide. Interestingly enough, hemp, of all the trees, hemp has one of the highest carbon capture rates using hemp concrete. But there are other things that we can look into with our infrastructure. This one slide also mentioned humidity control. I have a dehumidifier inside my home. Everyone should have a humidifier in their home, and make sure you have keep your indoor humidity between 30 and 50%, because if your indoor humidity is greater than 50%, it's going to increase the heat index. You're going to feel a lot hotter. So just by using your dehumidifier will help you to use less air conditioning. And even with air conditioning at home, it's it's best to keep it on the on switch as opposed to auto, so that air is constantly recirculating. Our indoor air is about 2 to 5 times worse than outdoor air, according to the EPA. But one way we can improve our indoor air quality is through increased circulation. But also, this one study showed that using warning systems in cooling centers, especially for the elderly, especially for people who have to watch their electric bill. You look at your electric bill these days, they bill nickel and dime us. You got like 5 different billing categories. Your bill is never going to be, I think they start at $20, even if you're not, you start at $40, even if you're not using electricity. So yeah, those are just a few things that we can do, and also work with other groups like, and also electric cars, just going green and electrifying our systems overall can really help with these urban heat islands. But, one concern about even electric cars that a few people are talking about is the cyber crimes. Right now, cyber crimes are not enforceable. So like with all the hacking, so, there have been some concerns that these electric cars, and even now some of our newer technology cars can be hacked and short circuited, or it can hack and drive itself, but you never know, someone who is a little bit more maleficent, what they can do. I hope that answers your question.
Thank you. Yes.
Please repeat what you said about indoor humidity percentage and all that.
Yeah, so our indoor air should be about 30 to 50, indoor air humidity should be between 30 to 50%. So as you know, if humidity is 100%, it's like outdoors, it's raining. But dry air, if air is below 30%, sometimes that air is very dry. Some people can smell if the air is very humid, or if it's going to rain. You can smell humidity and you can feel humidity. But if air humidity is is below 30%, sometimes that can predispose you to nosebleeds. And if it's greater than 50%, the air can be very humid, and it can worsen asthma. In fact, low humidity and high humidity both can can worsen asthma. High humidity can also cause proliferation of dust mites, which can also exacerbate asthma. So it is ideal to have it between 30 and 50%. I bought a dehumidifier for my home. You can buy it for the entire home, or you can buy it by room. But yeah, so the humidity meter, I'm sorry, the dehumidifier, it traps in the humidity and has a receptacle on where at the end of a day or a couple of days, it just collects a lot of water, and that can help to reduce the heat, the feeling of heat in your home. That can help to reduce the your use of air conditioning. By just using that dehumidifier. Some cars, they even have some dehumidifiers that you can use inside of your car if you want to conserve energy in your car as well.
Thank you. Thank you so much for your excellent presentation, Dr. White. And I encourage everybody to sign on to the listserv for the Georgia Clinicians for Climate Change and also the Medical Consortium. When we send emails out to you to ask you to sign on to letters that we're sending out to politicians and to Congress on major issues on climate change, please sign on and encourage your patients also to become more active, as Dr. White said. Thank you. We're going to move on to the next part of our program. And we have Dr. Maisha Standifer, who's going to talk to us about the All of Us NIH Clinical Trials Research Program, the precision medicine. She'll talk about the relationship to the COVID-19 pandemic, and also talk a little bit about the Satcher Health Leadership Institute and her involvement there. She has over 15 years of applied health program administration. She's a researcher. She recently relocated from Florida to Morehouse School of Medicine and is working very closely with Dr. Satcher on a number of initiatives. But she'll tell you a little bit more about what she's doing. She had a emergency and will not be with us physically today, but with the newfound technology and skills caused by COVID-19, she will be presenting to us virtually.
Hello, I am Maisha Standifer, the Director of Health Policy at the Satcher Health Leadership Institute at Morehouse School of Medicine, and thank you for allowing me to present. I will present to you on the All of Us program, clinical trials portal, COVID-19 vaccine trials, and our national network, along with the COBB Scholars Program. But more so, let me start off by talking about the Satcher Health Leadership Institute, where we are advancing health equity and policy, leadership development, and research. And so many of you might know about the Satcher Health Leadership Institute. Many of you may not, but the Satcher Health Leadership Institute aims to be the leading transformational force for health equity and policy, leadership development, and research. And of course, we're rooted in the legacy of our founder, the 16th U.S. Surgeon General, Dr. David Satcher. Our mission is to create systemic change at the intersection of policy and equity by focusing on 3 priority areas: the political determinants of health, health system transformation, and mental and behavioral health. In conjunction with these key strategic partners that we have, Satcher Health Leadership enhances leadership among diverse learners, conducts forward-thinking research on the drivers of health inequities, and advances evidence-based policies, all in an effort to contribute to the achievement of health equity for all population groups. If you'd like to learn a little bit more about the Satcher Health Leadership Institute, please go to our website I've indicated. And I guess it's great to provide a background on Satcher Health leadership, of course, knowing our profound significance and foundation at Morehouse School of Medicine. And it's great to talk about just being in a space, in a place, in specific location, and a great time to be at Morehouse School of Medicine. I'd like to highlight again a few of the programs that are just thriving at Morehouse School of Medicine. Particularly, we're very interested in talking about the All of Us research program. The All of Us program is a funded program out of the National Institutes of Health, where the mission is to, we say simple, we want to speed up health research and medical breakthroughs. Primarily, we're asking 1 million people to help find out things that can enable better healthcare for all of us, particularly our vulnerable communities that are very heavily impacted and really impacted. We know that it's this time within COVID, along with some of the existing comorbidities. And we want to really provide a more robust program where we could be very inclusive, particularly focusing on precision medicine and healthcare. And that is based on just individuals, right? But going a little bit deeper when we're taking into account factors like when you live, what you do, your family health history, being able to tell people that the best way to stay healthy.
What we're hearing now? Could you please mute your microphones if you're not speaking? Thank you.
Is to find out more of this information. You're looking at social determinants of health as well. Getting to the right information in order to achieve the goal is the aim of the All of Us research program. And we know to get there, we have to create a very large, as I talked about, a very robust, enhanced, diverse portal or database system by understanding people's health, the neighborhood, family, and lifestyle. Researchers will have information to better understand health and disease. This information is essential to create a healthier future for generations to come. More specifically, Morehouse School of Medicine will enroll over 1,000 participants, completing with their medical baseline data with blood samples from Georgia's incredibly ethnically diverse population of urban and rural, working with Morehouse Healthcare, Grady Health System, again, Morehouse Choice ACO, along with partners in Community Physicians Network for this particular research project, including the development of an enrollment core and biorepository. We're looking at the selection for this program is complementing MSM's commitment to the advancement and the achievement of health equity and participatory research in communities, as well as engaging these communities in large-scale, long-term follow-up studies, infrastructure building, and engagement of minority and vulnerable communities. To find out more, please visit the website I've indicated on the slide. Additionally, at Morehouse School of Medicine, we have the National COVID-19 Resiliency Network. We're calling this NCRN for abbreviation. We provide awareness and linkages to critical health information and services, helping families just to recover from difficulties that they may have succumbed to or been worsened by the coronavirus pandemic. We offer individuals, families, and community organizations access to new innovative COVID-19 related resources to help reduce any negative impacts the pandemic might have had on individuals and communities. NCRN is created for the community, by the community, to ensure the diverse needs of our nation are definitely being understood and addressed. A key component of our work, of course, is our collaborative partnerships with nonprofits, with corporate entities, academic institutions, health care centers, health systems, faith-based organizations, and federal agencies to provide critical, culturally relevant resources to communities who are experiencing the greatest negative outcomes from the pandemic. In order to join this network and to find out more about this, please visit our website. We are excited to have NCRN on board and being able to work with federal agencies, as also we indicated, nonprofits and corporate entities, to really combat what is occurring throughout the nation. We know that with, as indicated, our NCRN, we have some clinical trial and education and informative webinars that are being produced and conducted at Morehouse School of Medicine. We finally want to talk about the COBB Scholars Program, and I'm very happy because I am a product and a participant in the COBB Scholars Group. And we know that the great, who's the namesake after is W. Montague Cobb. This is the NMA Health Institute. And again, it was established, it's a COBB Scholars Program in 2016, continuing to develop enhancements to the program that will attract potential members and provide value for those individuals who have interest in participating in health disparities research. In addition, there is a desire among early career physicians, scientists, including social and behavioral, bench scientists, laboratorians, and population health scientists to be outstanding faculty members that serve in a unique way each of existing medical schools in the United States and within healthcare professions, as well as within other institutions of higher learning. We know that the COBB Institute was actually launched by National Medical Association in 2004. And we know that, again, under the academic home of Dr. William Montague Cobb, who this particular institute is named after. The mission for the COBB Institute is to focus upon identifying issues and developing solutions that will reduce racial and ethnic health and healthcare disparities, and to improve the health of all Americans. It has become apparent, of course, as we know with the current pandemic, that through these activities of the COBB Institute and affiliated programs that I'll also talk about, that there is a meaningful opportunity to engage in the early career advising, the mentoring, and specialized education, and again, conducting some of the webinars, as we talked about it, informing professionals who desire to excel as researchers, in addition to a federal and also private funding mechanisms. And I wanted to talk a little bit about one particular program. I am also a product of the National Research Mentoring Network, which develops young researchers, we call them early career researchers in their stages, focusing on biomedical, behavioral, clinical, and social sciences with evidence-based mentorship and professional development, programming that enhances and emphasizes the benefits and challenges of diversity, inclusivity, and culture. And this is a great program because it has a didactic curriculum developed to sustain, not just bring in and start, but we want to, this program wants to sustain some of the efforts for those who are federally funded, early career professionals who are in all a range of positions at institutions, HBCUs, and other institutions of higher learning, from associate to tenured full professors to assistant professors and research professors. We are looking at developing a robust cohort of early career scientists to continue to be the next generation to highlight the health disparities, and again, to hope to remediate some of those particular things that fall by the wayside in terms of being a faculty member when you have multiple tasks or responsibilities along with teaching duties. And so this particular program in RMN is part of the COBB Scholars Program, where many of the scholars, as I mentioned, including myself, are able to have direct mentorship with on-site institutional faculty, along with the network of faculty throughout the nation. So again, to find out more about the COBB Institute and the COBB Scholars Program, along with NRMN, please connect with anyone via the links I am providing. I thank you so much, and I welcome any questions.
Thank you so much, Dr. Stenifer. And we will proceed to any questions that you all may have with regard to any of the programs that was mentioned, and then we will proceed on to our next segment. Are there any questions? Great. With regard to the All of Us research program, we certainly want to make sure that all of you have the material that you need to engage not only yourselves, your friends, your family, and your communities to participate in the All of Us research program. As you know, the bold initiative to enroll 1 million or more individuals into the program has been stymied because of the pandemic. But despite the pandemic and the shift to address some of the issues related to COVID-19, over 370,000 individuals have already enrolled in the All of Us research program. Within that program, comparing to some of the clinical trials and the other research that have gone on heretofore, and you heard Dr. Tarver talking yesterday about the importance of having a diverse group of individuals involved. There are over 30% to 39% of the individuals who have enrolled come from underrepresented minorities and from rural communities. And so that is a significant achievement for the NIH All of Us research program. We want to continue to expand on that to make sure that as we get researchers developed to look at the data in the data repository, that we're being able to assess the outcomes and the impact of a whole host of issues relating to health and climate, as you heard from Dr. White's presentation, and how that impacts on the long-term health of individuals, families, and communities. So I encourage you to become involved. And at this point, I'd love to turn the program over to Dr. Adrienne Atkinson-Sneed, who is an East Point, Georgia-based female podiatrist with over 21 years of experience. And she completed her graduation from the Temple University School of Medicine. And she's going to lead us into another product-based component of the presentation. And so she will give clarification about the non-CME disclosure. And you can take it away, Dr. Sneed.
Yes, thank you, Dr. Price. I hope everyone can hear me. This is an exciting part of it. In fact, I think we are only doing the CME portion of this now. I am happy to introduce Dr. Felicio Faccarete. I met Dr. Faccarete just over a year ago, and he is passionate about limb salvage. So as a podiatrist, you know that would be very important to my profession also. He embodies two of my passions. One is about vascular health in general, and the other one, of course, is wound care and limb salvage. So he has, I'm going to read his introduction, and I'm going to tell you more about him that I know personally. So Dr. Faccarete grew up in Nigeria and immigrated to America as a young teenager. He attended college in New Jersey, where he obtained a Bachelor of Arts in Biology and a minor in Economics from Rutgers University. He received his medical degree from UMDNJ Robert Wood Johnson Medical School in Camden, New Jersey. He completed internship and residency in internal medicine at New York Presbyterian Weill Cornell Hospital. In 2018, as part of a congressional delegation, Dr. Faccarete testified on Capitol Hill in Washington, D.C. regarding the epidemic of peripheral arterial disease and spearheading a Sprint to Zero amputation campaign, with policy actions proposed to stop unnecessary amputations. He considers his title as MD as also an apron of humility, as a patient advocate and a community champion in his daily plight to be the voice of the voiceless. So I'll tell you more about what he has done just in 1 year. He is now the Peripheral Arterial Disease Chair of the Association of Black Cardiology. He is the lead clinical clinician for the National Amputation Reduction and Compassion Act, which we just started 3 months ago. He is the CEO of Cardiovascular Solutions of Central Mississippi. He is the Cardiovascular Advisory Board member for Men's Health Magazine. He's the Society of Cardiology and Angiography Intervention Chair. He also, if you all are familiar with the article, when he actually received his congressional award, last year, May of 2020, on ProPublica, it mentioned that his article 5 million times around the world. It is now up to 30 million times just in 1 year. And he is personally responsible for reducing amputations by over 88%, just in his area and all over the country. People fly to him from all over the world just to get his expertise in reducing these amputations. So it is my honor to introduce Dr. Fakoredi.
Good morning, everyone, and thank you for that gracious introduction, and thank you to the Georgia State Medical Association for the privilege of invitation. I am grateful and honored to be along here with esteemed panelists and esteemed moderators, and I just want to thank the board members and especially Dr. Sneed, who herself is a champion and is doing great work in her side of service, and we thank God for her. I'll share my screen, and I hope everyone can see it. Thumbs up, I guess everyone can see the screen. Thumbs up, there you go, thank you. I have no disclosures for this talk. All patients have consented to the sharing of videos, information in terms of this discussion. And basically, the Black American amputation epidemic was specifically titled for that ProPublica article to discuss a virulent practice that has occurred in our medical community for decades, for which the underlying condition which plagues this patient population is one that is the most prevalent, the most chronic, the most morbid, the most deadly, that most of our patients and their family members have never heard of. However, the generational scar has impacted their lives and livelihoods. And so it's an opportunity to highlight how systemic policies, institutional and medical practices, and other norms have worked in fragmented ways to perpetuate disparities in care, both in treatments and in outcomes, particularly in communities of color, and particularly in the African American population. So we fixed your brain on May 10th, and on May 14th, you went to get your toe amputated, right? Because it was dark and it was gangrene. And what happened?
I ended up in the emergency room, and they supposed to be taking off a toe.
And what did they take off from?
And they took off the whole leg.
What do you want the whole world to know? That this should not happen again?
This should not happen to no one.
Yes, sir.
Regardless, you know.
Yes, sir.
And if you go in and get a tooth pulled, I know since the dentist gonna cut your tongue out.
Yes, sir.
You see what I'm saying?
Yes, sir. Mr. Rucker is 66 years old, a diabetic, high blood pressure, high cholesterol, education level of about 3rd to 4th grade, had a toe, as you can see on the screen. We had restored circulation all the way to his foot. And that toe, when he presented to me, had already looked just like that. It was gangrenous and we could not salvage that toe. He went in for a toe amputation, and unfortunately his whole limb was taken off. And I'll talk about the clinical, economical, and human impact of what just transpired with him. So there's a cognitive blindness that occurs when you see people's limbs. As I've highlighted here, these are all patients that I consider family members who have come to my practice over the past couple of years, where we kind of have this indifference in our healthcare society, particularly when it comes to African Americans who show up. And some of these patients, have hopes, fears, dreams, just like we all do. But they suffer from the lack of genuine health equity. And what does that look like? Well, it looks like this. It looks like Mr. Rucker, who had his whole leg amputated. And what's not factored into this are there social determinants of health. We've talked about this all morning with great presenters, looking at the different facets and the different columns that affects our healthcare system. When we look at life expectancy of a patient, We in the medical community have a view or lens where we look at just the health column, but we need to look at what are the wealth gaps, what are the educational gaps, what are the food gaps or food deserts, what are the specialty deserts that exist. When we tell a patient to go exercise and to eat, what are some of the transportation safety issues? Do they have a park access to environmental safety? I know Dr. White talked about environmental racism. So this is the epidemiological catch-all for all non-medical factors that influence one's health. And so we need to do a better job of addressing this, not just on this level, but also in all our training programs. And even our policymakers and Surgeon General even stated, we have a sick care system where it's designed to get the result it gets. We focus more on the amputations rather than on the upstream preventative strategies that are needed. The reason why I reside in Mississippi is because of this patient. This is a 55-year-old diabetic who was on dialysis, who had 3 kids. He came in to see me for a non-healing wound. We restored blood circulation to his foot, as you could see on this video. I left town on a Thursday and I came back on a Tuesday, and his whole leg was amputated. And this was in 2015. And I decided that as a kid who came from New Jersey to Mississippi, that if this could happen with me on staff in a hospital, I wonder what happens when I'm not here or when I'm not around, or when at other hospitals that don't have a endovascular limb salvage specialist. Unfortunately, this gentleman died 3 years after that amputation. So there are trends in cardiology that we all have to be aware of. Before we start this discussion, we have an aging and growing population. There's a change in testing and procedure utilization. It's now a value-based care system. The prevalence of chronic diseases are getting worse. We have an aging healthcare workforce. We have shortages in primary care shortages and specialty shortages, evident in states like Georgia and places like here in Mississippi. And we have a low physician to patient concordance when you look at the enrollment of minorities in all continuums of healthcare fields. And social determinants of health and systemic racism continues to be elusive, even in spite of the fact that we've spent $16 trillion on social determinants of health. We're yet to see a significant bridge in that gap. And the prevalence of cardiovascular disease is only growing and affecting the Black population. The prevalence of PAD is about 20 million people. Actually, it's approaching 23 million. We need to update this. It's more prevalent than cancer, stroke, Alzheimer's, but the awareness is very low. It's lower than all these disease states that are listed here. So why fear peripheral arterial disease, which is a progressive atherosclerotic buildup of plaque and cholesterol in your system that narrows basically and prevents rich oxygen flow to get to the lower extremity or upper extremity or any arterial system outside of the heart itself? Well, we fear it because just like cancer, it's progressive. Patients don't come with your typical symptoms. They're atypical or asymptomatic. When identified, it's identified too late. And the co-prevalence of heart disease and strokes in these patients is so high that it leads to, number one, cardiovascular death. And 2, it leads to significant morbidity. And it affects these patients. But we also have an extremely prevalent growth of patients who are affected. So just for example, the death rate for peripheral arterial disease in terms of comparison to other major cancers, the 5-year survival rate is worse than breast cancer, skin cancer, and prostate cancer. That's why we fear it. And the patient makeup is our patients and our family members, the ones that we treat. Advanced age, diabetes, kidney disease, nicotine use. I avoid smoking because in rural Black populations, actually, most people will dip or chew rather than smoke. And so we have an epidemic that I labeled a diabetes epidemic, diabetes and obesity. Although I highlighted what Mississippi's numbers are, the Georgia numbers are right next door. And these are numbers that will lead to every county or most counties represented in diabetes belts, where we're projected to see worsening outcomes due to diabetes. So you'll have worsening heart attack outcomes, stroke outcomes, blindness, dialysis outcomes, and amputation outcomes. And as you can see, diabetics are actually at most risk for an amputation because they're 28 more times to get an amputation. It develops suddenly in terms of critical limb ischemia, which is the end stage of peripheral arterial disease. It increases with age, but also with the severity of their diabetes. And most of these diabetics are taken care by non-endocrinologists, right? Because of the specialty shortages and the lack of enough endocrinologists or specialists to take care of these patients. So primary care physicians and nurse practitioners primarily take care of these patients. And they do their best. But you know, there's only so much you can do in a 5 to 10 minute time frame. And so here are some of the relative risk factors. The higher numbers are predominantly in African American populations, which I'll get to. If you look at the risk factors by prevalence in terms of Black and white patients and Latinx populations, other than high cholesterol and active smoking, all other risk factors are predominantly carried by minorities. Clinical presentation, as I mentioned, these patients have atypical symptoms, but we failed in our textbooks to actually come to rural areas and gain the perspective of what patients and how patients describe their symptoms. Most of my patients don't come in with your typical quote unquote claudication symptoms. They come in with, hey doc, I walked to Walmart and my leg gives out on me. Well, when your leg gives out, it's not because of pain, it just gives out. They have a high, just a high flush occluded lesion, and anatomically they can't walk. And sometimes they actually, resist exertion so that it doesn't precipitate onset of symptoms. So they're classified as asymptomatic based on researchers that are conducted in Boston or San Francisco or New York. But if you were to come to Georgia or to rural Georgia or rural Mississippi and you ask those questions, they're actually atypical. So I think we need to go back and revisit this pie chart. So who's at risk? Well, based on the AHA-ACC guidelines, there's a patients who are either diabetic over a certain age, and that age is 70 or older. If you're younger than 70, 50 to 69, and have a history of nicotine use and diabetic, you should be assessed based on your symptoms, abnormal pulses or examination. If you have known co-prevalence of atherosclerotic disease, so patients who have had coronary disease, who have had end-stage renal disease, which is a CAD equivalent, who have carotid artery disease, those patients need to be assessed. And then African Americans, American Indians, and Hispanics have been shown to independently carry higher risk. And we call this the amputation lottery. Where you live and your race and socioeconomic status determine if you get amputated, but also the intense or lack thereof of hospital-related intense vascular care specialists will determine that. If you have a podiatrist who's active, like a Dr. Sneed, you're more likely to have someone who would advocate for limb salvage procedures at your facility. If you don't, then a surgeon who might not be aware as to what the options are will opt for an amputation first strategy. And the poorer you are, or the fact that you look like myself, meaning you're Black, or you're Latinx, or you're Native American, the more likely you're also to be given an amputation as a first strategy. And we've seen that. There's been published studies that show that there's regional variability in care that mirrors the Black census scope of America, which mirrors the enslaved population before 1860. Southern states have the lowest percentage and rates of revascularization and the highest amputation rates in the country. Here is Georgia for you. Those rates are equally as high. And let's do a deep dive. If you live in Albany, you live in Columbus, you live in Macon, and here are your rates. If you're a Black patient, Medicare beneficiary, who's a diabetic, you're more likely to get an amputation versus your white counterparts. That is unacceptable. So what else is unacceptable? The fact that we have a 90% odds of decreasing an amputation by performing strategies or an angiogram, which is basically a roadmap X-ray study to see where the blocked artery is and to go in the hands of someone who's technically competent to restore that circulation. It's called an angiogram and an intervention. Well, guess what? And about 50 to 73% of patients are not offered an angiogram. And in my area or site of service here in the Mississippi Delta, and as you all know on this talk, Mississippi has a 39% African American population, majority of whom live here in the Delta. About 89 to 95% of them have never had an amputation of my patients, but have never had an angiogram prior to an amputation. Almost 90% have never had an angiogram prior to an amputation. That is unacceptable. It even gets interesting. What about these patients who come in, like Mr. Rucker earlier, who had a gangrene toe? If you have a history of diabetes, which is the number one reason why patients have chronic kidney disease. So if you have diabetes, chronic kidney disease, which is more prevalent in our communities, you're more likely to have severe blockages and end up with gangrene or ulcer. We're seeing that more females as well are coming in with a higher rate of critical limb ischemia and independently offered an amputation. And for those who question if we have data, here's what I did. We pulled the 10 most important articles over the last 10 years that that actually highlight the disproportionately higher rates of amputations in minorities. Here it is for you. And even independently, when you factor and you control for social determinants of health, it's still higher. So the question becomes, is it a genetic construct? Or no, it's not. This is a construct built by men and women. And the fact that over the last 20 years, if you look at basically rural racial health disparities in America, this is a Journal of American College of Cardiology article that just came out in March. We have failed in addressing those risk factors, the diabetes, high blood pressure, heart disease, stroke, compared to our white patients, even compared to our urban Black patients. There has been little progress. So we have a lot of work to do. Why don't we screen for these patients? What's at stake? Well, we have a body, basically the fidelity of internal medicine and family medicine practitioners is called the U.S. Preventative Service Task Force that was founded in 1984. And the goal is to basically come up with basically screening programs that we determine are worth, looking at the benefits versus harms of these patients. And then CMS will follow up in terms of supplying some form of reimbursement if it's a class A or B recommendation. Well, what have they said about peripheral arterial disease in spite of everything I've presented? What the U.S. Preventive Service Task Force is, they looked at data, some of which came from international data, so predominantly white populations, younger populations. And what they said was, well, we don't have enough evidence to determine the benefit versus harms of recommending some kind of risk assessment screening for patients who are asymptomatic with PAD. Therefore, we give it an I statement, meaning there's insufficient evidence at this time. We're indeterminate, basically. And their comments is what actually raises my blood pressure. If anyone reads this comments, it cites that prevalence of PAD is disproportionately higher among racial and ethnic minorities and low socioeconomic populations. And the I statement could discourage testing and perpetuate disparities in treatment and outcomes. We recognize these well-established disparities in care. However, the evidence on screening and treatment in these groups is currently lacking, and therefore the USPSTF was unable to determine the overall balance of benefits and harms. Well, here's my evidence back to them. If you look at all cardiovascular trials to date and conducted in this country, only 5% of all cardiovascular trials to date, all comers, have included African Americans. Hispanics, 1%. Women, 33%. So what more data are we looking for when the data is not even included in the first place? However, we're seeing these patients presented into our sites of services with disproportionate worse outcomes. Of note, none of these members are endovascular physicians. And so it begs the question, what are systemic policies doing to our patients? Well, some of them perpetuate disparities in treatment and outcomes. And for those who don't care about the human aspect, well, if you're a taxpayer in this country or a policymaker listening to this talk, let's talk economics. The major amputation annual economic cost is about $23 billion to our healthcare system, not to mention the fact that we spend trillions of dollars on social determinants of health that has remained elusive. So who pays that bill? Well, Medicare versus Medicaid, predominantly Medicare, Medicaid. So the answer is taxpayers. If you pay taxes, that's where your taxpayer money is going to. And so when I see medical students, or I'm talking to colleagues as I am today, the best screening tool for peripheral arterial disease, or what God gave us, which are our hands, basically telling people to take off their socks, assessing their skin appearance, checking for the following factors, especially their pulses and other factors that are listed here, and listening to the patient. So being hands-on is vital in terms of assessing the patient. In addition, there are tools that are available. So what are those tools? The recommendation is to do an ankle brachial index. One has to understand their limitations to this, and we can discuss this on the chat. But if suspicious or if indeterminate of your patient is a diabetic or has end-stage renal disease or is older and has a lot of calcified disease that you've seen on an x-ray, you might want to have further testing with an ultrasound or CTA and have a vascular lab referral to that patient. But we have to treat their risk factors as well. Risk factor modification, upstream value-based care should focus on stratifying their risk. Let's adequately treat their glucose, their blood pressures, their nicotine use, which we've done a poor job. We've done a poor job as all comers in treating these, in risk stratifying these patients. So they're undertreated. In spite of having all the tools and all the advancements in technology to revascularize their legs, we have to do a better job of addressing medication goals and lifestyle changes that are listed here. Most patients who come in with peripheral arterial disease have some form of polyvascular disease. Screening these patients does not end at just diagnosing them with peripheral arterial disease. Once they come back to your office, is looking to make sure they have ischemia in their heart or in their neck. So it's basically a polyvascular workup is what I recommend for most of my patients. And that, if unaddressed or left blinded, that also adds $17 billion to your CLI cost. So what we did here is we established a program and took a holistic approach to identifying the risk factors of these patients, but doing our best to address other things. The fact that I am an African-American endovascular cardiologist who represents 1% of medicine, basically, as a Black male, it means a lot more to me in terms of serving my population, right? And making sure we address some of these issues. So it's not only building a culture of competency, both technically and interpersonally, but making sure your team is aware as to what those cultures are and making sure that we're efficient. And what we've done is reduced amputation rates by 88% over the last 4 to 5 years. But also addressing amputation disparities with colleagues. I was fortunate to be highlighted with, I think one of Georgia's finest surgeons is Dr. Olamide Alabi, who's at Emory, and other of my colleagues. And we talked about this. And it's to talk about what are some of the strategies, even though some vascular surgeons might disagree with some interventional cardiologists, at least there's a common ground where we start this conversation. And then you also be bold to talk about it when it comes to your society. The society needs to address this. And I spoke to my representative society as a Vascular Disease Council member, and we just published a white paper on this in terms of addressing these. Even in spite of that, this is last week, you're seeing these patients keep on coming in. And the fact that CLI and the management of this condition requires a multidisciplinary team that's listed here, that is in an ideal world that you get that on a big university setting. But amputation prevention requires a team, but most facilities, especially in rural areas, do not have a formal program, nor do they have the number of specialists that are required, are skilled enough to address these evils of amputation. And so what are these evils of amputation? Majority of our patients cannot walk after an amputation. Majority of them will require a contralateral amputation in another leg within 2 to 5 years. It has a high mortality and morbidity, especially if above the knee or below the knee. Mr. Rucker, who had an amputation, if that toe was taken off as a minor amputation, his life expectancy was not high. However, the fact that he had a below the knee amputation, his life expectancy rate was just minimized as hourglass was just turned, where 80% of patients like him are dead within 5 years. And what about caregiving? Who takes care of him? Who takes care of, the fact that lost wages might result? The fact that they need support at home. They need a ramp to get up the stairs. They need a new car that's retrofitted. And the fact that the lifetime cost to take care of an amputee is, hundreds of thousands of dollars, and majority of our patients are the median income in these states are about $39,000 to $40,000. So, when you can't change people's hearts, and as Martin Luther King said, it's all about trying to restrain the heartless, not necessarily changes people's hearts when it comes to judicial laws and policy. And so I got involved as a PhD chair for the Association of Black Cardiology and took a patient to Washington, D.C. to testify. It was a bipartisan testimony as a sprint to zero amputation reduction effort where we can address all the systems that are in play that affect this amputation epidemic and how we could address it aggressively, but also using a multi-societal effort. So this was a trans-societal effort. And basically what we came out with, the establishment of the PAD caucus, which Congressman Payne Jr. and Congressman Bill Arrakis are the chairs. And we hope that the majority of the people who are listening will definitely get their congressmen and women to join the PAD caucus. And the goal is not only to educate congressional staffers about this epidemic, but there is an introduction of legislation called the Amputation Reduction and Compassion Act, which the main provisions are to establish and coordinate an educational program on a national level to address all the risk factors and upstream products that lead to an amputation, i.e. diabetes education, nicotine education, and all those other social determinants. Establish coverage of PAD screening without cost sharing to those who we consider at risk, as defined by guidelines from vascular societies. And we need to address the fact that we need testing before an amputation is done on patients non-emergently based on Society of Vascular Surgical guidelines. And those exceptions are also highlighted in that provision. And we need quality measures to follow through. So it's not only doing that, writing about op-eds. And I'm a big fan of writing about op-eds. That's how the ProPublica journalist found me, actually, Lizzie Presser. But supporting your colleagues who do that, who do the same. This is Dr. Gary Daniel, who's an interventionalist in Georgia, who also discusses how this affects Georgians. Also being disruptive and highlighting in other forms. Reader's Digest, Men's Health Magazine, going to basically all forums that we can to discuss how our patients need to be educated, and equity to healthcare has to open all possibilities so they can live their best life. So my call to action are the following. One, continue to form multi-division strategic partnerships and raising awareness on a national stage, and this is one of them, and I'm very grateful for that. We need community-based participatory research to help formulate sustainable and culturally relevant strategies. We need to conduct research on that level, but with PIs, right, that are key to the success. So that physician-patient concordance, or PI community concordance, is very important. We need to address social determinants of health in all disparate populations. And we need to advance policy and systemic changes, such as the ARC Act, and have our policy members endorse that. And our workforce, what are we doing from a STEM standpoint, from a medical schools, from middle schools, from high schools? We need to get those young scholars and know that there's a fragmentation also in that pipeline that has to be addressed. Access to quality care across the entire continuum of care with an emphasis on preventative programs. As a cardiologist, there hasn't been a great preventative cardiovascular program that basically states that as a fellows in training, you have to go and join this preventative program, or there's an opportunity for you to become a preventive cardiologist. There are a few in the country, but there hasn't been a large emphasis, and we need to do a better job across all disciplines. We need to shift the delivery of care from ERs to outpatient care, because we don't want our patients to be presented to the ERs. They need to be seen as an outpatient, and we need to address why the Affordable Care Act has not been taken up in certain areas to provide not only access to care, but access to quality care. And in terms of improving our assurance and targeted education and outreach, we need to form strategic partnerships in that. Medical schools, nursing schools, podiatric schools, allied health programs must initiate a comprehensive PAD curriculum that is currently lacking. We need to address the recruitment and retention of specialists to highest regions of amputations, and they have to be incentivized. Advocacy of aggressive screening and using established guidelines that recommend therapies in outpatient outlines. In summary, we need our researchers, our payers, our policymakers to listen to great events like today. Healthcare systems need to understand that this is their cost. Patients have to be aware. So medicine encompasses the power of mankind to do good, to heal, to be humanistic. And I don't see my patients as a body part. I see them as family members. And this is a patient of mine who wanted to get involved after losing her right leg in terms of PAD Awareness Month. Her name is Tammy Sanders, and Tammy was a 55-year-old diabetic who lost a limb due to poor circulation, and social determinants played a factor. She lost her house in a fire, lost all her medications. She came to see us, and we tried to get her back on her feet, and we tried to get her involved in our PAD Awareness Month. And she had the following words to share with us. Well, unfortunately, Tammy is not here. Tammy died in March. Her amputation occurred 3 years ago, and she's one of those 80% who died within 5 years of an amputation. So this is my ask. Let's reach out to everyone. Let's agitate all levers of power and try and support the ARC Act. You know, as the great Georgian once said, continue to cause good trouble, but necessary trouble. We miss him today as we celebrate Juneteenth. Thank you very much.
Thank you very much, Dr. Fakoridi. That was wonderful, informative as usual. Do we have any questions on the floor right now? Okay, I'll start with one that I have. What is the prevalence of PAD, and why does it remain unestimated?
Sure, that's a great question. If you look where to Google right now, peripheral arterial disease, most people will see 8 to 13 million as the prevalence of peripheral arterial disease. However, it stems from a research that was done in San Diego in 1985. It's called the San Diego study. And what the San Diego study is looked at 613 basically upper to middle class white men who lived in San Diego, who were between the ages 38 to 82, if I recall. And that data basically looked at what was going to be their prevalence of PAD 10 years moving forward to 1995. And it was published in the big trial called the Partner Study. And the Partner Study is well known to everyone as the pivotal study that highlights peripheral vascular disease and what the outcomes of it will be. And it used an ankle-brachial index of 0.80 as its cutoff in that San Diego study. So here's what it failed to do. One, it failed to include the right population. African Americans were not included in that population, or minorities. Two, majority of these patients were not diabetic. So we've since had a growing diabetic population. It limited the diagnostic criteria based on an ABI of 0.9 or less, not 0.8 and less. So it has underestimated that population. So from 1985, if you were to look at the data right now as to what our population is in 2021, those numbers should be 20 to 23 million and not 8 to 13 million. But everyone has just copied and pasted the same thing in all different and quoted the same source. That's why you see 8 to 13 million.
Okay. Do we have any questions on the floor? You have the expert right in front of you. Okay, I have.
Yeah, this is Dr. Price. I have
Yes.
one question and commonality to share. I had the good fortune of visiting the research hospital in Cuba, and they expressed similar findings that you did in terms of the rapid approach to doing angiography, supportive care, and not amputating. And so I first want to take my hat off to you for being forward thinking and creating the advocacy that we need to do, but to continue to work towards getting this information out to the community so that we can save the feet and legs of all of our patients.
Well, thank you, Dr. Price, for that. I actually was privileged to go to Cuba as well as a congressional delegation with bipartisan congressional staffers to see the same thing you were talking about 2 years ago. And I was fascinated by what we saw, but also, as you know, there are political reasons why there can be discussions between their equivalents of their FDNRs for political reasons. And so it is always good to learn. And of note, to all medical students who are watching this, Cuba has the largest medical school in the country that's free, to be honest, with the expectation that they serve an underserved community when they all graduate. So yeah, that's another interesting and fun fact. But thank you very much. Truly appreciate that, sir.
Dr. Fakaridi?
Yes, sir.
This is Dr. Ray, Dr. Douglas Ray Bro.
Right.
Question. The data collection, as you know, there's 107 HBCUs, and out of the 107, there's actually 4 Black medical schools affiliation. So the majority of the patients we're really talking about are in actually non-medical school HBCU areas. And my reference is ultimately trying to collect the data from those underserved populations such that we can begin to bring social policy changes so that we can pretty much address the issues, because until policies are changed. So my question to you is, do you see the correlation of having midline, mid-level personnel, healthcare personnel tie in with the IT, information technology, to collect the data, bring about the changes so we can fulfill that purpose of trying to reduce the disparities? I know I'm kind of long-winded, but I'd like to hear you talk about it.
Yeah, I mean, I think the collection of data, when you talk about the collection of data, I'm very cautious as to how I respond to that answer, because as much as I'm called an expert right now with PhD, guess what? No one on this panel or no one in this country can tell you the true prevalence in terms of a number of peripheral disease in the African American community. Why? Because as I've mentioned, we are not studied and that data has not been collected. So who can come into a community like Georgia or here in Mississippi and go into those real rural areas and gather that data? There's a lot of things that have to happen before you quote unquote collect data. One, you have to have that trust that has been broken that preceded Tuskegee, right? We can talk about Marion Sims, and we can talk about a lot of things, even the first pandemic, as to what things were performed on our people before, before Tuskegee. That trust, that mistrust system is something that's been there. So it's, like I've said, it's, yes, collection of data and funding for the collection of data is important. But I think the agency or the agent who's going to collect that data also someone who has a lot of work and a lot of, emphasis on why this data is important for us to collect so that it stops that generational scar. HBCUs do have an advantage because of long historied relationships and trust that has facilitated care-seeking behavior. But we need to go beyond that because we're limited in terms of the breadth and the scope of this problem. I think it's just beyond that. That's just one avenue to use, and policy is another, but we also need to go to the grassroots and get other people to help out as well, other partners.
Thank you, very good.
Dr. Fakaredi, we have a question in the chat from Dr. Lisa Perry-Jilts, who is our president of the Medical Association of Georgia, and she would like to know, would telemedicine be useful?
Yes, yes or no. Yes, is because what the pandemic did was not only uncover, the disparities in care, because now everyone wants to talk about health inequities, right? Since the last year and a half, because of what they've seen with COVID-19, all it did was just unblinded everything to us, right? Unblinded the disparities that have existed for decades. But telemedicine half of my patients did not have access to telemedicine during the pandemic because they live in regions where the broad bandwidth and smartphones are not available because of their social determinants. Very poor. They don't have access. You know, there's a route that I take actually to a satellite clinic where for 30 minutes, no one can reach me on a cell phone. Until we address those disparities. But the benefit of telemedicine, it actually gives you a chance to engage with specialists who are not in your area. Like endocrinology, for instance. We only have 7 endocrinologists in the state. I can engage with an endocrinologist from here and have my patients, you know, have that discussion and that dialogue and that interaction, and that visit can be scheduled. And so my patients will have to come to me to do so. So there's still work to be done. I think we've noticed that in communities of color, about 40 to 50% of them don't have that, you know, that disparity in telemedicine exists. So once that infrastructure bill, which has to be addressed, passes, hopefully it addresses the telemedicine disparity and therefore can help bridge that gap in disparities in treatments and outcomes to these specialists and other conditions that are similar to PAD.
Okay, in the essence of time, I have one more question for you. So I know that each week, in 1 week, I refer at least 5 to 10 patients to an interventional cardiologist because of their PAD. That's per week. In my own practice, I always use the QuantaFlow, which is similar to an ABI, but it's used like a pulse ox. It only, instead of it taking a half hour, it takes maybe 3 minutes.
Right.
However, it has a 30% rate of false positive.
Right.
So what would you suggest? What can we put in our practice locations so we can identify more patients with PAD so that they are not overlooked, that it's not confused with gout or arthritis, but it's actually PAD pain?
Right. That's a great question. And also that's a big challenge because as I mentioned, one, we use an ankle breaker index is what we tell our providers. So we vascular specialists tell the non-vascular specialists to use an ankle breaker index or QuantaFlow as their primary screening tool. Here's the problem. When patients get older, your blood vessels get calcified or are less compliant, and which also can affect the results of your ABI QuantaFlow. 2, these patients can have chronic kidney disease or diabetic. That too can affect it. So in my slide, I put a referral to a vascular lab where they can do advanced studying with an ultrasound, or sometimes some people will say TBIs, but even with the toe brachial index or TPO2, there are limitations to those as well. So it's all about what's next step. In my practice, it's I use an ultrasound more commonly because it's not only identifying what that ankle brachial index disparity is, but also to seeing visually, morphologically, what you're looking at and what is the disparities in pressures or in flow. That's the best. Even with that, there are still limitations to an ultrasound.
Thank you.
So sorry. The combination.
But thank you. It was wonderful hearing from you.
Dr. Atkinson, can I ask a question? I'm sorry to be late.
Okay, we need to get to the next session. But
okay, so my question to Dr. Fakori, and I'm sorry I didn't get your name properly.
No problem.
Just apologize. But is there a way for all of the medical schools and the programs in Georgia to supplement the deficiency in health education by using PAs, by using nurse practitioners, whatever, to try to stretch the envelope? Because we can't keep saying that.
Can we park that question to the next panel because they'll be addressing any of those?
My short answer is yes. That's all.
Okay, that's fine. That's good enough for me.
Thank you very much.
Thank you.
That's good enough for me.
God bless.
Very good job, Doc. Good man.
We're going to turn the program over now to our next moderator, Dr. Lawrence.
Good man.
All right. Good afternoon.
Love you, man.
Thank you. I do have one announcement, and that announcement is that this program and Dr. Focaretti's talk on amputation prevention in the Black population is a CME program, so you will get CME credit for this program. All right. Our next program begins to focus on the future of medical practice and to really have a dialogue. I'd like to stretch our capabilities here and really look at the opportunity to engage a wide range of people in this discussion. As we have worked through these 2 sessions in our virtual conference, clearly we can all see the significance in the role that clinical trials play as that thread of information and that thread of analytics and that thread of clinical trials was through all of the talks. And we see the role that information plays in the development of what's called guideline-directed treatment and evidence-based medicine. So our discussion about clinical trials really does fit into our program. And as we have talked over the last session today, we talked about diseases that disproportionately impact African Americans. We've often also talked about challenges with access to services, access to care. And we have talked about the potential for engaging other clinicians in the care of patients. One of the things that we face that sometimes are unintended consequences of decisions made. So what we'd like to do now is turn to the future of medical practice, particularly physician practice, and look at the role of other clinicians and scope of practice as a question that I think we need to address. Joining us to discuss that topic with us is Bethany Scherer. She is an attorney who works with the Medical Association of Georgia and has compiled a great deal of information on scope of practice. She's going to share information about scope of practice with us, and that is to be followed by a response and dialogue with some of our physician leaders. We have Dr. Kevin Woods, president of the Atlanta Medical Association. We have Dr. Paul Douglas, past president of the Atlanta Medical Association and the Georgia State Medical Association. And we have Dr. Lisa Perry Gilks, who is a past president of the Medical Association of Georgia, very active in GSMA and NMA, and now the current president of the Medical Association of Georgia. With that, I'm going to ask Attorney Scherer to really give us an overview of scope of practice and what are some of the key issues. Ms. Scherer.
Thank you for that introduction. So I'm just going to start laying out the landscape of where we are in Georgia and the types of issues that we're seeing currently in our scope of practice environment within the state, and then sort of talk about nationally what we're seeing and how those trends impact where we go in Georgia. So obviously you have kind of your key players in the discussion, which is most of this is happening at the legislative level, which means it's happening between, the discussion is happening amongst legislators, and physicians and medical associations play a key role in helping educate legislators about the differences in education and the like that impact what decisions those legislators should make in order to ensure quality care for all Georgians. And from the sort of overarching perspective, we look at scope of practice as an effort to keep physicians as the leader of the team of healthcare. So it's not that physicians should be the only ones providing healthcare services. We have great advanced practice providers that provide great services to patients across Georgia, and they can help supplement in places that physicians cannot be. And as long as they're working through a supervision agreement with a physician, it can lead to really better care for patients. So we see a variety of issues, including advanced practice registered nurses. That's probably the #1 issue that we see in Georgia. And those issues range from requests to practice completely independently from physicians to increasing the types of things they can do under a protocol agreement, which is what we have in Georgia, which means a supervision. And these things can be things like radiographic imaging, ordering advanced radiographic imaging. That's, you know, one of the things we had most recently. And on the horizon, we'll have CRNAs asking for more practice authority as we go forward. And we're not exactly sure what those bills will look like, but we assume that there will be a component of sort of independent practice aligned with that. Physician assistants have not traditionally been as big of a threat to sort of a change in the way we practice in Georgia. It's important to remember that PAs fall under the Composite Medical Board like physicians do, whereas APRNs fall under the State Nursing Board. So that helps a little bit with the regulatory aspect, and that the relationship between the two organizations and two groups is just a little bit different. Although we just recently saw coming out at a national level that they want to change their name from physician assistant to physician associate. So that does impact that discussion a little bit. We don't know exactly how that will start to flow through the state. I'm sure that that will be a discussion at the medical board level as well, just in trying to make sure that we maintain. Georgia has sort of truth in advertising laws, and we call it a name tag bill that passed a number of years ago that makes sure that patients know which provider they're getting and sort of the level of education they have. Some other issues we've seen in Georgia that are a little different. We have CPMs, which are a type of midwife that is not a nurse. They do have some schooling. It's just dependent on the regulations. They're currently not legally able to practice in Georgia, although we know they are. And those discussions really bring about a lot of interesting issues related to underserved populations and people of color because of the maternal mortality rates, and making sure that people of color are getting the type of care that they deserve, and making sure that it's culturally competent care. And we really, you know, the maternal mortality rate in Georgia is an issue for Black women across the state, and it's something that we really need to address. And we need to address sort of on the front end from a physician association perspective in order to have a response during these discussions. And then, we do have pharmacists are an increasing concern throughout the country. Pharmacists are pushing to be able to test and treat. We have not had that really in Georgia. The Pharmacist Association in Georgia is more focused on PBMs as it stands. So we've been able to have a really good relationship with them, a working relationship where we don't have quite as many scope of practice issues there. And, you know, at the end of the day, it's really important for physicians to remain involved, to create relationships with their legislators, and to help sort of guide the policymaking process so that we can keep physicians as the leaders of the team, but also help increase access to care for all patients.
All right, thank you very much.
Oh, hey, I'm sorry. Quick question. The other category of midwife, are those more like the Dellas and the Hispanic population?
So there are a couple of different routes that you will see. The CPM is called it's a certified professional midwife, and they do have a type of sort of education system that they use. It is not anything near what a nurse midwife would go through, or obviously what an OBGYN would go through in order to get that training. And then there are different pathways. So whether you have an education pathway or sort of more of a apprenticeship pathway, which is another whole different category of midwife. And there are cultural backgrounds to both types of midwives. And I think that has added to that discussion and has made it a more complicated discussion to have. There are states that have varying levels of authorities to practice for non-nurse midwives. And I think that, you know, it's an interesting discussion because we come back to how do we deal with the patient choice and how patient choice factors into these discussions, but making sure that we maintain safe care for Georgia patients. And remember that, you know, it's the person giving birth. It's also the infant on the other side and making sure that they have quick access to pediatricians and those that are educated in sort of the intense care that a neonate may need at the end of the birthing process. So that's kind of, it gets to be a difficult discussion while you're trying to make sure we, are doing a good job of treating birthing people with a lot of respect and making sure that they are getting the care that they need and that we have better access to care. But it's not a great alternative in rural areas because in some underserved areas, because they need to have quick access to a hospital in case a transfer needs to happen very quickly. And we also just don't have great data on it. And we, with the physician community, we talk about data a lot. It's very difficult to get good data on out of hospital births because the reporting structure that we have in the US kind of forces the reporting to be done by the hospital. So if a mother is transferred to the hospital and a negative outcome occurs, that can actually fall back on the hospital. And it looks like the hospital had the negative outcome, not the out of hospital birth. So that's another thing that makes this a very difficult thing to legislate and to come up with good policy positions on.
Okay, thank you very much. Are there any other clarification points? All right, I think the critical factors here are that many of the decisions about scope of practice are made by the legislators, are made in the political sector, and less so by the state composite board or by physician associations. And I think the crux of the discussion is really about the role of physicians as part of a team of clinicians caring for patients going forward. I think we got some information about advanced practice RNs, CRNAs, certified anesthetists, PAs. I think there was a bit of discussion about the name change for PAs, CPNs, pharmacists. I would even throw one other possibility into this whole discussion. It's around the use of the term physician versus the term provider. So I would actually like to open this up now to Dr. Douglas, Dr. Woods, and Dr. Perry-Gilkes. I'm gonna start with Dr. Perry-Gilkes. From your perspective, Dr. Perry-Gilkes, please share with us some of your thoughts around the issues that we face.
Well, the longer I stay in medicine, the longer, the more apparent it comes to me is how much our profession is shaped by legislation. So when you think about what does it look like for physicians, it all matters on what legislation is passed. I think that the things that affect our practice and affect the future of medicine, because the way I was trained is definitely not the way that our new physicians are being trained. Even back in the olden days, we didn't have the call, the time limit and stuff like that. I see it as transitional period. We're going to come out the other side in a completely different way. I think we as physicians need to remember that we are the master of the ship and our future depends on ACGME, more legislation than I would have ever thought, as well as training and residency programs. We had to be really cognizant of what's going down under the Golden Dome. And I went for the first time in many years to the AMA meeting last weekend, and the rules and resolutions that are being passed, the conversations about criminalizing physicians for the heartbeat bill, the gender transition treatment are all things that are going to affect us. And I think we really need to pay equal as much attention to legislation and how to be a good advocate for our profession. We can't be asleep at the wheel. They can run off or run away with anecdotal information and our legislators that aren't fully educated can write registration that passes, just like malpractice here in Georgia. California has MICRA that limits the pain and suffering to $250,000. That's written in the Texas Constitution. Well, here in Georgia, the Supreme Court a few years ago said that there is no such thing. There's no cap on pain and suffering. So that is something that it's going to take 2/3 of the voters to change anything that's in the Constitution. So it's going to vary, and we're going to have to pay attention. But clearly, when I look at the medical students and the residents that are graduating, their idea of what practice is different. I don't expect to see as many or maybe any solo private practice in the next 10 years. With the Affordable Care Act, we're being more supportive and turn to group practices. And I am currently in a large single specialty group, which is absolutely, positively more access to more items than I did as a solo practitioner. But I, as being a solo practitioner since 1989 and owning my own practice since that time, is definitely a change as being an employee. But if you were always an employee, you wouldn't have any problem with that. So there is, for the physicians on our panel have been private practice, self-employed, and now join larger groups. So I think we're going to see many more larger groups. We're going to have a paradigm shift in the expectation of what physicians want with their practice. Our physicians at my part of career and age, our expectations were definitely different than what's going on now. And I can't say that the limitation of the call hours is a bad thing. But when you limit, especially for a surgeon, the percentage of cases that you cut out, the percentage of experience that you cut out, should we increase the residency time? When I was graduating, I had 17,000 cases. Now, if they have 1,700, that's acceptable. It is what it is. So just some brief ideas, and of course you may spur some more memories and ideas and contemplations by further conversation. I think that one thing that we really need to do as GSMA, I know we do it well, but have closer relations with our legislators. I know, I'm sorry, I forgot Lester's last name, and president of the caucus. I know he's the one in Savannah.
Jackson.
Yeah, Jackson. Well, he's a dentist, so he has some idea about healthcare, but our relationship with him is very good. But I think one thing that we may want to do as GSMA is have a media training for our leadership, as well as training on how to interface with your legislators. I want to invite you guys to be a part of or considering taking the Georgia Physician Leadership Academy session. Julianne has graduated and I graduated from that. That's a great opportunity for us to learn how to jump through the hoops, how to reach out to legislators, and just how to be more engaged. If perchance there are any students online or young physicians, I started my activity in organized medicine back in medical school with SNMA. But subsequently, when I was a young physician with the the California Medical Association, that's when you start to write resolutions and realize exactly how much power one person has. So you come with an idea, you formate that idea into a resolution, you turn it up from your state to the AMA, and then it may become legislation on the federal level. One of the things is that I can share with, it was in 1999, I wrote a resolution with Dr. Christy Dyer, and it was a resolution of 1 day of peace for the millennium. Well, that went from CMA to AMA to the United Nations, and it was passed there. So, I mean, don't underestimate your power. And the earlier you start in medical school, residency, young physician, the more effect you can have and change what's going on. So never fear and never throw in the towel, because you have people around you that will support you. Where you cut your teeth is here. And please stay engaged. If you're not at the table, if you're not a seat at the table, you're on the menu. That's true. So I can tell you, Dr. Ron Bengazer, who was AMA, he was from CMA, but he was AMA chair at COL, and he gave a talk to us young physicians. He said the best thing, the easiest thing to do, and it is for all physicians, is to show up.
Yeah.
How many people don't show up? How many positions have I gotten because I'm the only one there?
Mm-hmm.
Hey, I have an idea. Will you do that? I'll do that. So if you do this for medicine, then we do it for all. A victory for one is a victory for all. So stay engaged. And then we as physicians, that's really what we have to do. I know it is just almost like having another job, but you get so much information, so many things I wouldn't know. And being at GSMA, I love that we are one of the oldest physicians organization in the country.
Mm-hmm.
Dr. Perry-Gills, thank you.
Okay, thank you.
I want to pick up on one of the things you said, and I think that one of the things you said very clearly is that there's a very important role and connection between what happens in legislation and our profession. And one of the key things is learning how to advocate for the profession of medicine, or for the practice of medicine. I'm now going to turn to Dr. Woods and really ask to really talk about, Dr. Woods, what are your thoughts about scope of practice and how we as medical societies, practicing physicians, and what linkages we can build around some of the issues to kind of shape the role of physicians going forward? Dr. Woods.
Thank you. I'm a gastroenterologist, so I'll start from a more personal perspective. This is very, very timely, this conversation, because some may have read, there's a new published report out of Johns Hopkins Hospital that had a nurse practitioner training program for training nurses to become endoscopists, to provide colonoscopy care in rural and sometimes less available areas for gastroenterologists. And this got a number of parts of the study were interesting. One was the percentage of patients in which that were part of this trial, which unfortunately walks into many of the ethical questions we talk about with clinical research even today. Most of those patients were African-American, although Baltimore obviously has a large African-American population. It was not equally applied across the demographic. But it then raises the question of, should nurse practitioners be at the end of the scope, even when we have other practitioners that are available, like surgeons, for example, that do currently also maintain privileges for endoscopy. So I'll just let that sit there, because that really opens up a ton of questions that we talk about the future of practice. I think Dr. Perry,
That's okay.
Lisa Perry said the same thing in the sense of we have multiple complex issues. I don't think that it's just a legislative issue. It's about how we as physicians are going to take back power in the sense of how we deliver care in our own communities. Yes, we are starting to see changes with APPs. I enjoy using APPs in my practice because it does extend low acuity clinical settings to patients and give them access. It increases the productivity of many of our practices because it allows us to function at the highest use of our time. For example, seeing a new patient, for example, versus a follow-up can really change the P&L of many of our practices in our hospitals. But we still have a balance of how much is too much. And I think that this is obviously due to a financial incentive for hospitals and also a financial incentive to health insurers to essentially create a really flat payment structure for any provider. I think you brought that point up too. What's the difference between a physician and a provider? So, you know, I'll just say this because I think it'll spark discussion. I'm not in favor of scope of practice to be extended to NPs and APPs, especially around title changes, because I think it does two things. It devalues the physician in the setting of increasing and escalating medical care costs when it comes to education. As we know, many of us, and I sit on the board of Meharry Medical College, and most of our students today are incurring incredible amounts of debt, which in many cases will never be paid back, depending on how much debt you came in with before you reached professional school, if that's dental school or medical school. And when we think about that in the current environment, if we're taking away the ability for our physicians to make a living, that's going to create even more, I think, challenges to access to care. Culturally competent care, of course, is going to be impacted by that. And then the widening disparities that we see, that when a Black doctor or a person of color is treating a person of color, there is a benefit. I think we have to think about how we are eroding away that potential when we have APPs in the middle of that clinical engagement. And then finally, a solution, obviously, since we're going to want to block that, I think legislation is the key, but I totally agree. We need more of us, not only caring about legislation, but caring about our business. We are losing private practitioners. I think this is very, very difficult. I am in private practice right now, and it is very, very difficult without increasing our buying power. And I would argue that the GSMA, the AMA, and the NMA, we need to start to really think about how we can group our practices across the country and more affordable and using accountable care organizations to start to speak at this level. There are some groups, of course, many of you know, that are starting to do this, but I think it's a model that we have not really applied across the US and specifically in Georgia to actually give us a fighting chance to be able to make this argument without increasing what I would say competition among ourselves to try to solve a problem that can be solved at the level of an economic empowerment model for physicians.
All right.
I'll stop there.
All right, thank you very much, Dr. Woods. I would actually say, I think that you really pointed out the fine line between title changes and the language that we use going forward, and how that has a potential to really, with unintended consequences, shape the future landscape, and how important it is that we care not only about our business, but also about our profession. Dr. Douglas is one of our senior statesmen and as one of our longstanding leaders in Georgia State. We're going to turn to you for your comments on this matter.
Thank you, Dr. Saunders. I enjoyed all of the comments I've heard so far. One bit of levity, though, that I want to insert is that remember that only 20% of people in our country have primary care doctors. And I think that the COVID-19 pandemic helped to uncover much of the disparities that exist in our healthcare delivery system, helped us to understand why so many of us have been disappointed in our abilities to adequately care for our communities, and why the country has started to look to other solutions outside of organized medicine for improvement in the healthcare delivery system. You know, when you look at where we are now, particularly as you look at the state of Georgia, we are, if I have my statistics correct, next to the last or close to the bottom, for sure, in health statistics outcomes. And so when we look at our legislators, and we're asking our legislators to support us, I think that it's important that we help them understand that the value that physicians bring has been eroded. And much of what we have seen in the erosion of the physician as leader is being played out today in these poor health outcomes. And so I think that I agree with Dr. Woods. We really need to fight to maintain our position as the leader of the team. I think that that certainly has a tremendous impact on the scope of practice, what happens to the further erosion of the leadership capabilities and the willingness to invest in medical education, and why it's so important. Yes, we could produce people who can do colonoscopies, or people who can do various technological things, but critical thinking and the ability to solve problems is really what our healthcare system needs. And so I think it's important that we recognize that fact and assume the relationship as leader that we in medicine have always enjoyed. The final thing I would say is that we're at a particularly good point, I think, in that the killing of George Floyd and the fact that the country now is being very insightful as it relates to health equity. I think that this is a particularly vulnerable point for the country. We are paying attention to these inequities that exist in our society, and this is an opportunity for both the AMA, the NMA, and Georgia State and all of its component societies to take advantage of this moment and to demonstrate to the society the leadership that we bring to help solve these very important questions and challenges. And I'll stop there.
Thank you, Dr. Douglas. I think you pointed out very clearly that this is an opportunity that there is shared interest across medical associations around this particular topic. I'm going to take just a moment to see if there are any other members or any other participants who want to weigh in on this issue. But I am going to be fairly prescriptive in that I'm going to limit the comments in the interest of time. Are there any others who want to comment on this issue?
Dusty.
Mm-hmm.
I just wanted to say, if I get like 3 seconds, when our legislators want to cure the disparities of health in the rural areas, and they accept, or they ask us, they actually looked me in the face and said, well, what are we going to do? Where are we going to get people? And then the advanced practice and APRN say they'll do that. That's what the message that they carry to the legislators. But research has shown that they do not go to those underserved areas once they get their advanced training. And even so, what we want for all citizens of Georgia in the rural area as well as in urban area, we want quality care. We just don't want care. We want quality care, and that it can only be provided by a physician.
Okay, thank you, Dr. Gills. Anybody else? All right, I think in the interest of time, I'd just like to wrap this up. I think that this has been a good discussion. It opens a dialogue about occurrences today that have impact for the future. I think one of the themes that we have is that this may be an opportunity for the Georgia State Medical Association, the Medical Association of Georgia, along with all of our component societies and NMA, to really find an area where we have common ground, where that it is in all of our interests to act together and to work together. That was really one of the purposes of this particular discussion, is to really lay out this as a potential issue for us to really find our common ground going forward. If there's no more discussion, I'd like to thank Beth Scherer from Medical Association of Georgia. I'd like to thank Dr. Lisa Perry-Gibbs, Dr. Woods, and Dr. Douglas for participating in this discussion. So thank you very much.
Thank you.
Thank you. Thank you, panel.
Thank you.
Okay.
All right. I'm now ready to move on to the second component of this discussion. And I think it fits very well, because now we turn to our legislative arm and begin to look at how legislation and the profession of medicine, the practice of medicine, begin to work together to impact long-term health outcomes. It's very interesting, because I think that the term social determinants of health, one of the things about aging and time is that you know how a discussion started, and then you see how it's applied later on. If we go back to the beginning of the social determinants of health discussion, it was about the responsibilities of political jurisdiction and the role that politics and medicine and distribution of resources played in the impact of health. And it was designed to be a tool, in my mind, to really stimulate community development and action at the community level. As we have progressed now, we have begun to map social determinants of health to individuals and begin to say this individual carries a social determinants of health. I think that's good, maybe, but I'd also think that we ought to add a zip code to that as a way of getting back to the geography that's defined. And so with that as kind of a backdrop around the social determinants of health, distribution of wealth, access to education, access to clean water, access to safe neighborhoods, access to safe playgrounds, all of these kind of issues that impact health, we now want to bring on our legislative elected official arm. I think one of our first speakers here is going to be the Mayor Savannah, Mayor Van Johnson. And Mayor Johnson, I think you're on the line. I'm going to go ahead and turn the microphone over to you.
Thank you so much. I appreciate the opportunity to be with you and the opportunity to speak briefly during the Georgia State Medical Association's gathering. I think that it's good to be here, and frankly, it's good to be anywhere, particularly during this time. And I'm sure you all look forward to the time in which you are back together again in each other's company. Let me express my thank yous to you for what you have done individually and collectively in cities throughout the state of Georgia during the most difficult times in recent history. Certainly, you all were uniquely situated to see the situation from a unique vantage point. Certainly, you must have felt the pressure from all sides of being able to not only find ways to administer medical care, at the same time, unusual and unprecedented political opportunities and pressure that was coming from all sides. Here in Savannah, we resolved very early to be able to keep the faith and follow the science. And so that was it was a dichotomy in that we recognized as people of faith that we would get through it. And sometimes half the battle was showing up, but we were going to commit to following the science, recognizing that we don't know it all, and we have to rely on those who know more, those who've studied more, to be able to do that. And that you would think it was kind of simple, but it also got us in trouble. I'll take a moment to recognize Dr. Erica Russell Petty and the work that she did on behalf of your association, as my office had been in constant contact with her throughout this event, from our closing of Savannah early to the initiation of our mask mandate, which was the first in the state, in which we faced almost a legal challenge, to Governor Cuomo coming here and we learning from New York State what they did as it relates to the medical side of this. And then, of course, our constant conferences in terms of how we would get out of this. How does it affect young people? How does it affect older people? How do we move it to vaccinations? And so Dr. Russell Perry, on behalf of the city of Savannah, I want to thank you for your help in that. So as it goes right here, we recognize that very fully that this virus and the times we are has shown that those that are poorer got poorer, those who are sicker got sicker, and there are definitely opportunities for equity as it relates to the administration of healthcare in our state. And so to me, it's not that hard. This pandemic hopefully is reset as we have to learn about with George Floyd, about how we administer criminal justice and how police do their work, that we have to be able to talk about the same thing as it relates to medicine. How do we deal with issues of equity? How do we deal with issues of making sure that those folks who need help are able to get help? Those folks who can't come to get help, how do we get the help to them? How are we able to engage those that have not been engaged before and those who don't have the wherewithal to be able to do that? So I think for us, it is about equity, it is about diversity, and it is about inclusion. And I think that in this case, politically, we need doctors to be more legislatively involved, particularly minority doctors, because you're the voices of those that you serve. And so you know those stories, and we're willing to hear them. And since I don't mind getting in trouble, I'm willing to push those stories to where they need to be. So thank you all so much for this opportunity.
Thank you, Mayor Johnson. Any comments or questions for Mayor Johnson? If not, I'm going to now turn to Representative Lester Jackson, who has worked with us before, and I think his name has come up before. So Representative Jackson, I'm going to turn to you. So thank you for joining us today.
Well, thank you very much. I'm honored to be a part of the Georgia Medical Society, especially this conference that you're having. It's good that in Zoom that we can all come together from all parts of our state and be a part of moving Georgia forward. I'm honored to share this platform, this panel with the mayor of Savannah, Georgia, Mayor Van Johnson. He's been doing a spectacular job, not only when it comes to protecting the public, but leading our city and being the spokesman for a city that's on the move and in the and headed in the right direction. So Mr. Mayor, thank you for your efforts, thank you for your vision, and thank you for getting us through this healthcare crisis. But to you, the Georgia Medical Society, thank you for your leadership and the opportunities that you provide, giving access to millions of Georgians across this great state. And to your president, Dr. Petty, job well done. I don't know if you know this, she had the opportunity to introduce the, what was it? What was that? Was that the vice president or president or somebody who came to Savannah a little bit? I was so proud that she stood up for healthcare and talked about healthcare to the nation. A fine example of representing your organization, introducing the vice president not only to Georgia, but introducing the vice president to America. I'm gonna be brief, but I want to tell you that as a society, we're in a healthcare crisis when it comes to African Americans. The African American physician workforce in our country is at 13%. The African American workforce in the state of Georgia is at 13%, and the country is at 9%. We're in a state where 30% of this state are of African American descent, but only 13% of our workforce are physicians. That's a problem because we know that people tend to live longer who go to African American physicians. We know that African Americans do a great deal of identifying healthcare and identifying problems, especially when it comes into the African American community. So we need to solve that because we need to be promoting more of our young people into the medical profession, and not only into the medical profession. We need to encourage state officials and along me and many other my colleagues. We need to encourage my colleagues to do what we can to put more dollars in the budget to put more African Americans into the physician or the medical workforce. And when we talk about the Georgia Medical Society being not only an advocate, but being a leader when it comes to talking about legislation, talking to legislators, we need, as a society and as a group, we need to talk about Medicaid expansion. In the state of Georgia, we don't have Medicaid expansion. We don't accept those federal dollars. And what that does is that leaving nearly $600 million on the table. And what that does is it puts our rural hospitals in jeopardy. It puts people's lives in jeopardy, and it puts a large percentage of Americans in Georgia who could have access to primary health care that neglects them from having access to health care. So there are a lot of issues that we need to combat in this great state. Many of you know all our problems. You know that Georgia is number one in maternal death rate in our country. Georgia ranks number one. In fact, the state of Georgia, there's 10 times more likely a woman of African American descent can die giving birth in Georgia than in California. An African American woman is 4 times more likely to die in a hospital giving childbirth than her white counterpart. We need to find out why this is. We need to put more emphasis in infant mortality in our state. We need to invest in Medicaid expansion. We need to invest in child care. But who brings this to the table, to the Georgia General Assembly? Who do we rely on? I'm asking that the Georgia Medical Society, the leaders in healthcare, the leaders in opportunity, the leaders in giving access, join in this fight to fight for more opportunities, to decrease maternal death rate, to decrease infant mortality rate, and increase more access, especially in rural Georgia, especially to rural hospitals, but especially to the disenfranchised people. When we look at it at the state and our counties, 6 counties in our state, Georgia, in our state have no physicians. 63 has no pediatrician. 66 has no general surgeon, and 79 has no OBGYN. In fact, they're saying about 159 counties, over 120 are underserved. So we need to put more attention on giving access, giving not only giving access, but also take advantage of the new innovations that's happening to Georgia. We recently passed legislation in the past few years to legalize marijuana. I think, like it or not, medical marijuana or medical cannabis, it will be legal to help with people with chronic pain and people that deal with long-standing illnesses. So I think that the African American physicians need to be on the front line when we talk about giving cannabis, and being on the front line, and who should get cannabis, who should not, and being the leaders in research. We have some great medical institutions in our great state, but what's important is, are African Americans getting access to those opportunities in our medical institutions? We are appalled that in a state that's 30% African American, only less than 10% are getting access to going to those institutions. So we have a lot of issues, and then people boast about Georgia is the greatest state to do business in the country, but we still live in a state where 29% of the people live below the poverty rate, and of those 29%, they are Medicaid and Medicare is their only access to health care. And we also live in a state where multitudes are the working poor who have no health care access at all. I need the Georgia Medical Society working with the Georgia Legislative Black Caucus and all members of particular interest to move Georgia forward, to promote more access, to expand Medicaid expansion, and to give more people access to health care. But I want to thank you for the job that you're doing, the access that you made for millions of Georgians, and the good work, because you are the shining example of what's good in Georgia. In fact, one of the greatest occupations you can still be in America and in the great state is a physician. And I want to know what we can do to expose more young people, especially African-American males, to go into the medical workforce, to give aid, and to do research, and to make our not only our state grow, to make our country grow, and to protect the disenfranchised, the poor, and those that need access to health care. Thank you very much for being a part. I'd like to open up for questions, and let me know what I can do.
All right, thank you, Senator Jackson. I think I made the mistake of calling you Representative Jackson in the beginning, but thank you very much.
It's good, man.
And I also think that you're seeking another office in terms of the Department of Labor, right?
Yes, sir. You know, along with giving people access to health care, number one this year was that there are thousands of Georgians who did not get their Medicaid. Didn't get their unemployment benefits. There are thousands that still need to learn technical skills, to learn vocational skills. Oftentimes in Georgia, we talk about increasing minimum wage. We talk about increasing the $7.25 to $8. What we need to do is talk about and teach people to learn skills, to learn occupations, so that they can earn the education background, so they can apply and have access to livable wage jobs and opportunities. So I'm running for Labor Commissioner to bring on change. I'm asking that all of us be a part of this movement to bring on the social change, to get more people access not only to good jobs, but good to opportunities that they can become good corporate citizens in our great state. So yes, I'm running for Labor Commissioner, something that I'm passionate about. I want to move Georgia forward. I want to give people access to livable wages and access to good jobs. So thank you.
All right, thank you very much. And I think that you also bring up one other topic that's important that we really don't have time to discuss in this particular session, and that is the role of Medicaid expansion and how important that's going to be going forward. It gives me great pleasure to really bring our next speaker to the microphone or to the camera, because she is one of our own and grew up with us here at Georgia State, Ms. Donnie Turner. Her father, Dr. Dennis Turner, has been a faithful member of this organization and has served as a physician, as a surgeon in the Atlanta metropolitan area. And I've known him much of my career here in Atlanta. His daughter is now in the position to shape legislation and public policy and is in direct contact with our two newest senators, works for John Ossoff, and I'm sure she has close connections with Senator Warnock as well. With that, I'm going to turn it over to Ms. Turner and say thank you very much. And we're very pleased and proud of you and pleased to have you join us.
Thank you so much. It's so great to be part of this conference. Thank you for inviting me. As you said, I am a daughter of this organization, kind of grew up in it. My father, Dennis Turner, mom, Janet Turner, part of the auxiliary. So really pleased to be able to talk to everyone about the importance of working with Congress and in particular the Senate. And now that we have Senator Ossoff and Senator Warnock, it should make it a little easier for Black physicians to get some of your priorities through Congress. And yes, I am one of 6 Black legislative directors in the entire United States Senate. It's very exciting to bring my experience and background to the office of Senator Ossoff. I've worked on and off the Hill for about 20 years now. And so I have a little bit of an idea of how the Senate works. It is its own animal with its unique quirks and rules. But working with the House, our partners in the House, we hope to get some legislation through to support Black physicians, HBCUs, our communities, whether it's rural hospitals, it's community health centers. The funding that Senator Ossoff and Senator Warnock were able to achieve in the last COVID relief bill was definitely related to them being elected to the Senate, because without them in the Senate, we would not have the breadth of legislation that passed in March. So there's money to support HBCUs, money for direct money for local government. So that money goes to support police departments and fire departments and to keep public service workers. In the past, that money has gone through the state. And so a state like Georgia could decide which city and which local government could get it. So Senator Ossoff fought to get that money directly to local governments, make sure there was money for free vaccines. That's another reason why we are out, not wearing a mask in the Senate. We haven't worn masks in the
Randy,
Senate.
Dr. Walden, I just want to get my usual,
Please turn off your mics if you're not speaking, Dr. Walden.
Because we can now, go out and about and function in the Senate without wearing masks, thanks to vaccines and the great work that Black physicians are doing across the state and across the country. Money for schools to safely reopen and provide in-person instruction, and to use the money that they've been received for mental health counselors and school nurses. We know how important healthcare is for young people, and to be able to address some of the trauma that they've gone through in the last year. That's really important. So then they can focus on their actual classes, instruction, and be successful in school. And as we say, school, college, career, and life. We also provide additional money for community health centers and rural hospitals as well. So hopefully we won't have another rural hospital closed, especially in Georgia. We know how rural hospitals are important for their communities, and we don't want people to have to drive an hour to get to a hospital. That's not what we think of when we think about high quality healthcare, and that's what everyone should have access to. And not only access, but be able to afford that healthcare as well. So I want to, thank Mayor Johnson. Really important to working with him. Senator Ossoff and Senator Warnock have both met with him, been to Savannah, talked to him about what else we can do on the federal level to help Savannah and communities of color, communities that are served by physicians. We know that physicians of color, more than not, work in communities of color. And so we support those physicians. And one of those ways is support HBCUs, but also support the public health service that funds and recruits and trains and provides primary care physicians and healthcare providers to community health centers and also to rural areas. So we definitely want to make sure that we continue to fund the public health service. During this discussion, I know we're recording, but I just want to make sure, this is off the record. If you want me to ask, to be frank and answer questions about what's going on in the Senate and the House, this is a conversation that I'm happy to have, but just know, this is between us, and that, that this is off the record. Someone asked about the competition bill and what's in it for HBCUs and minority physicians, physicians of color, Black physicians. And there is billions of dollars for technology. There is $29 billion specifically to increase the amount of research conducted at the nation's universities. There is an additional $52 billion for fiscal years 2022 and 2026 for research and development programs, and for building the STEM workforce, for improving the STEM education, partnerships, programs, agriculture, quantum information science, technical education, all of the things that our HBCUs are working on. We want to make sure those schools partner with our federal agencies and are able to access billions of dollars of money. And so all of you physicians who are in research, who have connections to universities, whether it's Georgia State or whether it's Clark Atlanta, We want to make sure that our physicians in training, our students who are interested in going into public health, interested in going into medicine, into nursing, have access to these research dollars. Because how are we going to compete with our countries around the world if we don't have the numbers of Black and Brown physicians and nurses and healthcare providers that we know we're going to need to be competitive in the coming years? If you're looking at the demographics of our country, we have to increase the number of Black and Brown students going to medical school and succeeding in medical school. We have to look at the number of Black and Brown students who are attending graduate programs and contributing to research, and also, of course, who are working in public service, who are either working on the Hill or who are in federal agencies, who are conducting the research that then goes on to help our communities and benefit our country. So I know time is a little short, so I wanted to leave some time for questions. If anyone wants to jump in, I don't see anything in the chat, but I will, just drop off now and just hopefully answer any questions anyone might have about what the work we're doing or what we could be doing. And I also want to encourage physicians, you are your best advocate. I see the AMA all the time. I want to encourage the NMA, Georgia State, Tennessee, everybody. You are the best advocate for your patients, your practice, your communities. And we want to hear from you. So in Senator Ossoff's office, I'm sure Senator Warnock's office would say the same. Please reach out to us when there are issues of concern to you, whether it's research dollars, whether it's funding, whether it's Medicare reimbursement, whether it's keeping hospitals open, whether it's maternal health. We were talking about that earlier, whether it's graduate education, residency slots. I know, some of these issues keep coming up, and it impacts our community a little differently than it impacts others. And so we should be as vocal and as active as other communities in making sure that senators, as well as our members on the House side, know what's important to you. And being an advocate is how we know what's important and what we should be focusing on. So I wanted to put that plug in. I want to make sure that you all reach out to our offices and let us know what you're thinking.
This is Winston Price. Thank you so much for your comments. We plan to have face-to-face again next year, so I look forward to my annual GSMA hug.
Yes.
And give my best to your parents. My only question is forward thinking. We know that there are several millions of dollars put into healthcare for COVID, but we really don't have the formula for what the long-term impact is going to be. This is the first time we've had a decrease in life expectancy for people of color. And so what kind of discussion is going to go on in terms of making sure that not only Georgia, but certainly the US looks to make sure that 10 years from now, we have the infrastructure in healthcare and at the social level to avoid the impact that we've suffered from the pandemic?
Great, thank you so much. That's a great question that leads me into infrastructure and what we're going to do in the Senate. I know you're probably hearing about the 50-50 split that we have and how there's a lot of compromise in the Senate. President Biden has this broad infrastructure plan. It's not just roads and bridges. It includes healthcare, it includes housing, it includes education and childcare, all of these things that contribute to a high quality of life. And so if we're talking about healthcare infrastructure, in the Senate, it's a little more difficult to get legislation through, but Senator Ossoff is fighting for this broader 10-year plan that you're talking about. He's working with the White House and working with our Democratic leaders, as well as with Republicans. He meets with Republicans all the time, talking about how can we work together. If there's an issue for rural healthcare in Georgia, it's probably similar to what's happening in South Carolina and North Carolina. So, we can work with our Republican senators who represent those states. So, very good point that you're making about infrastructure and how important it is, and to broaden that discussion healthcare, to make sure we have the resources we need for our schools, our hospitals, our community health centers, their practices, making sure you have the technology so that you are up to date and can provide this high quality healthcare to your patients. And some of that assistance may come in the form of financial assistance to physicians and to hospitals to upgrade that technology, and also to make sure you have the skills training to use that technology, right? So all of that is what we need to hear as part of the Senate. And so really appreciate you bringing that up, Dr. Price. Thank you so much.
Ms. Turner, this is Dr. Wilkes from Atlanta. Can you hear me?
I can hear you, Dr. Wilkes.
Good to see you. In the National Medical Association, especially ophthalmology section, we are concerned about the number of minorities who are in the ophthalmology programs. We know that the medical schools get federal assistance, to train postgraduate residents.
Right.
We want to know that at some point, I think we're going to have to look at the disparities between other ethnic groups and their numbers versus the numbers for African Americans. To train a resident is a sizable amount of money to do that. As we look to the future and try to replace ourselves, we need a strategic plan in place with funding that's going to increase the longevity and the expansion of the number of physicians, not only just in primary care, but in the specialty. To treat our community. That's not only on the practice management side, but it's going to be on the research side as well, because many of us want to do research as well as practice. So can you lift up a little bit of insight on the concerns about there? You mentioned that there was some funding available to the HBCUs. Share a little bit about that, and if you can give some contact numbers or tell us where to go to follow up with that after you respond to that.
Oh, sure. Great question. Focusing on, you're right, focusing beyond primary care into the specialties. Yes, Dr. Wilkes, we need someone to help you with your practice and make sure it continues. Same thing, with my father as well, a general surgeon, who's going to come after him and take care of his Medicare patients. We're finding that the physicians that are coming out are not going into the same fields of practice. Certainly not in the underserved areas, whether it's rural areas, underserved areas, in urban areas as well. And so, yes, so there is money definitely for research and for to increase the number of Black students. And the pipeline, as you know, begins earlier. It used to be you could get a scholarship in college and be able to get into medical school and do well. Now, what the focus is to build that pipeline in elementary school so that youngsters have this career pathway into a healthcare field, whether it's through STEM or research, PhD, graduate school, or through public health, or going into medical school to be a physician. And so that pipeline has begun to be funded, but there's a lot more that can be done. You're exactly right. We need to ensure that our youngsters have the resources they need to be able to take the classes that they need to take in elementary school, in middle school and high school, be able to take AP classes, be able to do some dual degree programs with their local college. They can get some of these credits early, so college is not so expensive. So then they can look to medical school. What happens is by the time they get to college and they see how much college costs, then their options are limited in terms of, well, I'm not sure I can afford medical school, let alone finishing college or going on to get an additional degree. So if we can keep college affordable and put those resources into our K-12 schools, that will definitely help increase that pipeline for youngsters going into medical school and being able to afford to go to medical school, because then their student loans aren't as high.
And thank you. And the best way to reach you?
Oh yes, let me put my email in the chat. Would that help?
Okay. That'd be great. Thank you.
You're welcome.
All right. Thank you, Dr. Wilkes. I think one of the things that that particular discussion comes to, and I think you mentioned it earlier, Ms. Turner, is the advocacy for sufficient residency positions, particularly in historical his HBCUs. I think we heard very clearly at the beginning from Dr. Wimberly the challenges and successes that many of our HBCU residency programs face. So I think that's an important area. So are there any other discussions? All right, thank you very much for joining us. Thank to our legislative group. I think this was very informative. I hope this convention, I hope our scientific sessions have at least served to provoke some thought. I think I've watched that some connections have been made. So thank you to all the participants for making this a success, and to all of the speakers for engaging with us. With that, I'm going to turn it back over to Dr. Russell Petty. And I think she has some announcements and some special things that she would like to do. So thank you very much.
All right. As she proceeds to the mic, today is Juneteenth Day. We celebrate the end of slavery, the day we memorialize those who offered us hope for the future, and the day when we renew our commitment to the struggle for freedom. So said Angela Davis. We want to thank all of our sponsors for today's program, particularly those who have been supporting GSMA through the year, and those who've supported us for our annual convention. This concludes day 2 of an excellent program, and want to thank the Planning Committee and our Executive Director for all of the effort and time and commitment that they put in. You will have a concluding remarks from our President, Dr. Russell Petty, and clarification on the CME process. Dr. Petty.
Yes, so thank you all. Thank you all. This has been a great program between yesterday and today. Definitely want to thank all of our everyone, our moderators, our speakers, everyone from our planning committee, just everybody that has put in all their efforts. I wanted to first, last night, of course, there was our awards program. And I had two people I wanted to recognize that I knew would be on today that I wanted to give presidential commendations to. And so the first one that I wanted to give that to is Mayor Johnson. I met Mayor Johnson a few years back when he was an alderman, and I was president for our local society here, the South Atlantic Medical Association. And pretty much every activity that I would go to in the community, I would always see him there as well, trying to help out in the community. We of course didn't know at that time, but have seen now that, God had a plan to kind of move us both forward in a way that we would be able to further use our abilities to help out in the community. So as he alluded to earlier, when I became president of GSMA, actually that same day was the day that we talked and, agreed on being the first city in the state of Georgia to implement the mask mandate. So thank God we did. So of course, throughout the year, he's continued to be encouragement to me, supportive of everything that we're doing in Georgia. As you all have known, that he's, even today he had a lot of Juneteenth activities going on, but it's still taking out the time to be here with us. And so I just wanted to recognize Mayor Van Johnson and let you know that you will be getting presidential accommodation from the Georgia State Medical Association.
Thank you, and I'm beyond honored. Thank you so much, Dr. Petty.
And the other person, of course, that I wanted to recognize is Senator Lester Jackson. Again, I met Senator Lester Jackson a few years back as I was, again, president of our local society here. And he would come and share, being already in other legislative positions, come and share with our society, and always working towards helping to move us forward. He's continuing to do that. He has been instrumental in sponsoring and helping to pass many pieces of legislation that affects the minority doctors as well as our patients here in Georgia. Again, he continues to encourage me and others to be more involved, as you heard him say, with our government so that we can understand how, if we help to make the laws that will govern us, then we can have a better effect on our loved ones and our own community. So yes, this year's legislator of the year is Senator Lester Jackson.
Dr. Petty, thank you so very much. I'm in the midst of between two Juneteenth celebrations, one in Macon, and now I'm headed back to one in Savannah. But this is a great honor. Thank you for doing God's work. Whole Georgia Medical Society, thank you for doing God's work, taking care of the least of us. And continue to be
I think your phone might have went out in the last few words there, but definitely thank you. I know you're on the road, so we probably have lost connection there, but so thank you again. Again, I thank all of our speakers from last night through today, and I won't go back through and name them all, but thank you all. I thank our convention committee, Dr. Price, Dr. Williams, Dr. Grant, Dr. Douglas, and Dr. Adrian Atkinson-Sneed for everything. And the only other thing that I wanted to make sure that everyone, I did go through our process. I know a few people had problems with the CME accreditation, but you should be able to, you can either scan the code that's on the computer and it'll take you right to the link, or you can put in the actual right at the top of the QR code. And once you do that, somebody needs to mute there. You need to mute. But if you go on and you, it's going to ask you initially, unless you are already part of Morehouse, you'll have to create an account. I'm sorry, I'm not sure. I can, okay, there we go. If you go on and it'll ask you to create an account for yourself, and all you have to do is just put your email address in there. It's going to send a code to your email. You put that code back in, and then that creates your account. Then you'll use the codes that we gave you, your activity codes, and I think that they'll put them back up there again. Or I think they might have put them in the chat. Oh, let me see. The one for yesterday was 11901, and the one for today is 11902. And so you'll put each of those codes in there, and then you want to claim the hours that you actually participated, in our convention, and then it'll give you your certificate. It'll send it back to will allow you to print it out, or you can send it to your email. So it works pretty easily once you just have to create an account initially. And so I believe that is all of the things. I do ask each of you to keep, if you can, periodically just check back on our website as other things are coming up. We've been trying to send out newsletters to let you know what things have been going on. And then we'll also post things on our website. We want to make our website more interactive with all of our students. As we know, we've been trying to figure how to keep everybody engaged and continue to move forward. And so that's what we're going to be using our website to do more and more as we're going forward. And so unless anybody else has any questions. Any other questions?
No, just when you're running for mayor.
Well, that depends upon when Mayor Johnson is going to be running for his next office. Otherwise, we're keeping him as our mayor. So, but no, I'm not running for any, no.
Thank you so much, Dr. Petty, for your leadership in organizing this annual meeting and scientific program.
Thank you, thank you. And so if Dr. Wilkes, Dr. Shelby Wilkes, if you would give us a closing prayer, and that will end our scientific meeting. And then I think that will be all for now.
Can you hear me now?
Yes.
Yes.
Okay, let us bow our heads. Lord, we thank you for this great opportunity to get very informative information and clarification about some of the issues facing our community. Bless our leadership, including those who came from the outside and thought it not robbery to participate in our program, including Mayor Johnson and Senator Jackson, and all of the other speakers from MAG. Bless our president, Dr. Russell Petty, and the moderator, including our IT person who has worked tirelessly to keep everything on schedule. Again, as we leave this place, help us to keep our hearts and our minds focused on what we ought to do and try to make a difference in the lives of others. In Jesus' name we pray, amen.
Amen.